मैं कट डाउन कर दूँ, आपका फ़ोन काट दूँ मैं? मैं बस ट्राइंग।
मम्मा कहाँ है? ढूंढ रही थी। मम्मा को पारी कर दो, बस पारी कर दो। मम्मा को गुड बाय कर दो।
मेरा मीटिंग जा रहा है, लाइव जा रहा है।
अरे 2 मिनट रुक जाओ।
मैं कैमरा ऑफ नहीं करना जानती इसमें।
अरे बस पारी कर दे, कौन सा फर्क पड़ जाएगा?
गो ओके, आई लव यू बेटा। Hi everyone. So I got a little late because of some technicalities. So thank you so much for waiting. Today we'll be covering rapid revision obstetrics and gynae. It's a big subject, so no matter how rapid it is, it will take at least 4 to 5 hours. So but our target is we will finish it in 4 to 5 hours. The thing is, what we'll be doing, we'll be revising every question, and with each question, whatever the topic there is, we will not discuss the whole topic, we will discuss only 4 to 5 important points of that topic. Okay, so we will just keep on quickly revising important topics based on the questions that have been asked. Okay, so is everyone ready? Right. First of all, if I'm audible, then please just give me a thumbs up if I'm audible. Can I have one thumbs up if I'm audible? Dr. Tawfiq, if I'm audible, can you please give me a thumbs up so that I'll know that yes, the voice is clear. Good afternoon. It's good morning, Dr. Tawfiq. Okay, so let's start. The first question. Okay, the first question. We'll start from the basic. We'll finish the obstetric first, and then eventually we'll go to the gynecology. The first question was the normal placenta features they asked. Whether it is discoid, it is hemochorial or deciduate. What it is? It is all three. It is discoid, it is hemochorial and it is deciduate. Let's quickly see what it is. This is a mature placenta. Can you see what the shape is? It's a disc-like. It is not a sphere, it's disc-like. So the size is 20 centimeter and thickness is 3. This can tell you it is disc shape. That is why we call it discoid. The weight of a mature placenta is 500 grams. So the average weight of a baby in India is 3 kg, not in India. I mean, average weight of a baby delivered term is 3 kg. So what is the ratio of the baby to the placenta? If this is 500 grams, this is 3 kg. What will be the ratio? 6:1. Important, asked many times. So in a mature placenta, the ratio of the weight of the baby and placenta is 6:1. It is discoid and size is almost 2 centimeter. Then what do we have to know? Another question which was asked in just last FMG. Which part of the decidua forms placenta? What is decidua? Decidua is nothing special. जो maternal endometrium है, the maternal endometrium, when it gets pregnant, the same endometrium which sheds in every cycle, when it gets pregnant, it will call decidua. It is nothing new. But the thing is, this hole is endometrial lining, isn't it? Which part of the whole uterus will form the decidua? It is this. See, baby has invaginated into the uterine wall, isn't it? It has gone into the upper segment. So the wall it has imaginated into, it will form chorions. Chorions क्या है? Villi. It will form chorion frondosum. The part where it is implanted here, that part will be called decidua basalis. So can I say that decidua basalis is the one which is forming placenta? Yes. Then what is the name of other deciduas? This, which is just capsulating it. It is just surrounding the baby. Can you see the chorions are not here? It is decidua capsularis. And this remaining decidua where the baby has not even implanted, it is parietalis. It is standing just like a wall. Parietal means wall. So decidua basalis, where the baby has gone into the uterus and forming placenta, giving the villi, that decidua basalis is forming the placenta. ठीक है? So ये चीज़, this is clear. This was the last year question. Now ठीक है, we got to know that placenta में the maternal part is called decidua. What about the fetal part? The fetal part is trophoblast. What is trophoblast? Can you see what is this? This is a blastocyst. A blastocyst has this inner cell mass and blastocyst has surrounding circular cells. Inner cell mass will be forming the actual baby, the heart, the forebrain, the midbrain, the brain, everything, the GI will be formed by inner cell mass. What is the function of this? This is trophoblast, and the function of trophoblast is forming placenta. So maternal part is decidua and the fetal part is trophoblast. Now trophoblast can be divided into two parts. Villus. Villus trophoblast is the one which is forming the villi. The villi you see of placenta, that is villus trophoblast. Does that mean there are other trophoblasts also? Yes. It is called extravillus, which is not forming villi. Then what is it doing? It is basically, just hold on a second, I just need to read this. Yes, Dr. Jamal, it is for FMG, dear. You will eventually know all the questions are from FMG, right? Okay. So villi, so extravillus, what are they doing? They are not forming villi. So they have particular function, right? What is their function? There are two types. One is endovascular. This endovascular trophoblast is very smart. It will go inside maternal vessels, invade the vessels. It will turn thin vessels into big channels so that baby can have good blood supply. Though it is not forming villi, this endovascular trophoblast is the one going inside maternal vessels. Interstitial trophoblast is forming a framework. These villi will not hang in air. No, they need a framework. So this extravillus will forming that framework where the villi will be growing up. Okay? So they invade the spiral arterioles, they lie between villi and they form the villi. So these villi are being formed by which trophoblast? Villus trophoblast. But you might have heard the word hemochorion. Chorion. What is chorion? Chorion is nothing but this, when this villi form, you know this is primary villi. What is secondary villi? When it is invaded by the mesoderm. Trophoblast plus mesoderm is nothing but chorion. So it is okay if I say that trophoblast is forming villi, chorion is forming villi. That is okay. So it is chorionic villi. I can say it is chorionic villi which is forming the placenta. Remember what is the maternal part? Decidua basalis. So primary villi and either, so this whole part is the fetal part. This whole part is the maternal part. They both come together to form placenta. These arterioles are nothing. They are uterine artery blood supply. This is uterine artery which gives arcuate artery, then radial artery and the spiral arterioles. Can you see these corkscrew arterioles? These are the spiral arterioles. These are the one which are invaded by which trophoblast? Endovascular trophoblast. These spiral arterioles are invaded. When endovascular trophoblast invade these spiral arterioles, what happens? It fills the intervillous space. The blood is being poured into intervillous space. So the placenta, blood is coming in contact with what? The chorion. The fetal blood vessels are lying safe inside the villi. They are never coming in directly contact with maternal blood. What is coming in contact with maternal blood? Chorion. What is chorion? Trophoblast and mesoderm go together, we called chorion. So is our placenta hemochorial? Yes, it is hemochorial. Heme, what is heme? Heme is maternal blood is heme and chorion is the fetal part. So it is discoid formed by decidua basalis and it is hemochorial. Got it? Another very important question. These are the timelines when the villi are formed. Not very important. Important one is this. Tertiary villi means when the trophoblast followed by mesoderm is invaded by fetal vessels. That is tertiary villi. When the tertiary villi has formed, it means now the circulation has established. Now this maternal blood will be exchanged with the fetal blood. So when is the feto-placental circulation established? Day 17 post fertilization. Whenever I'm talking about the embryo, I'm always talking about post fertilization. So when is it feto-placental circulation being established? At day 17, because at the day 17 the tertiary villi is being formed. Got it? ठीक है. The second important thing in placenta which we have to know, अभी हमने what we have all read, we have read B, it is discoid, we have read feto-placental ratio, we read कि decidua is the maternal part, we read the chorion is the baby part. उसमें the villi are of three types, extravillous and villous. Extravillous में endovascular and interstitial. इसके अलावा there is one more important thing. The time I told you that endovascular trophoblast invade the spiral arterioles, that doesn't happen in one go. They take time, they slowly invade. So we call it wave of invasion. First wave of invasion, when the endometrial blood vessels lying in the endometrium, when they are invaded, it is first wave. That happens within 12 weeks. Second wave is a little difficult one. Now the trophoblast has to invade the myometrial blood vessels. This is second wave, which happens at 12 to 16 weeks. Is it important? Yes. Because when this invasion, second wave of invasion is abnormal, the trophoblasts are not able to invade the vessel, it leads to a pathology called as preeclampsia. Okay? Got it? So this much about the placenta is more than enough. Now we not want to discuss about the amniotic fluid. So amniotic fluid पे भी questions have been asked. Majority of time they want to know about the amount, the causes of oligo was asked in the last year exam. So amniotic fluid is basically from the maternal and fetal origin both. Okay, it is basically 98% water. It is little hypotonic. Very important question which is frequently asked: when is the maximum volume? See, the amniotic fluid volume keeps on increasing up till 36 to 38 weeks. When it is maximum. After that, till 40 weeks, it is constant 800 ml. So it is maximum in third trimester. After 48 weeks, it starts decreasing. So in post-dated pregnancy, we very frequently find oligohydramnios. It starts decreasing. That is why we need to deliver the baby here. Otherwise, the fluid will start decreasing. So the maximum fluid is in 36 to 38 weeks in third trimester. After that, it will decrease. Okay, this is one important question. Then we need to know about the source. See, it is a balance between formation and absorption. Formation कहाँ से होता है? Formation the first 20 weeks में kidneys नहीं बने. The kidneys have not formed in first 20 weeks. So urine तो नहीं. So baby will not produce urine. How will the fluid will form? Through the membranous secretions. The fluid will be secreted from the skin, from the placental surface. So this transmembranous and transcutaneous secretion is the main source till 20 weeks. What happens after 20 weeks? The skin gets keratinized. And as soon as it gets keratinized, I hope it is not. So as soon as it gets keratinized, now the skin cannot secrete the fluid. As a result, what happened? Now kidneys take over the function, urine starts forming, and the fetal urine become a major contributor at 20 weeks. Okay? And what about the absorption? Absorption is through GIT. So remember, whenever there is renal anomaly in the baby, so kidneys are producing amniotic fluid. Any renal anomaly will lead to less fluid production, oligohydramnios. Baby is taking the secretion, absorbing it. That is how the secretion is taken into the baby. So if there is abnormality in GIT, it will lead to what? Absorption will not happen. It will be lead to excessive fluid. So renal anomaly, oligohydramnios, GI abnormality, polyhydramnios. Clear? Up till 20 weeks, what is the major source of amniotic fluid? Skin, transcutaneous secretions. After 20 weeks, what is the major source? Kidney. Right? So about oligo and polyhydramnios, a little detail, since this last year the question was asked. What is oligohydramnios? Amniotic fluid index, I'll just change my pen color. Amniotic fluid index less than 5 or single deepest pocket less than 2. That is polyhydramnios, AFI more than 25 or single deepest pocket more than 8. ये तो definition है, you have to remember. What is AFI? You have divided uterus into 4 quadrants. When I am taking only single measurement, that is single deepest pocket. When I am taking all 4 measurements and adding them up, that is AFI. Okay, so less than 5 or less than 2, that is oligohydramnios. Causes. The most important cause of any lady comes to you at 24 weeks. She tells, my fluid is very less. Ultrasound tells me. The most common cause is rupture membrane. Just see that whether she has landed into preterm pre-labor rupture of membrane or not. So that is the most common cause. Okay. Then other causes of oligo are placental insufficiency. Whenever placental insufficiency are there, there will always be oligo. IUGR. Then renal anomalies, because urine is the source. Urine is the source. So when renal anomalies are there, hypoplastic kidney or obstruction is there, kidney is functioning well, but there is posterior urethral valve. The urine is not getting out. As a result, there will be oligohydramnios. Right? Polyhydramnios, the causes, the most important causes are genetic anomalies. So genetic anomalies, especially neural tube defects, are very common cause of polyhydramnios. इसके अलावा viral infections, all the torch group of infections which cause congenital anomalies, they will lead to increased fluid. Why? Because see, if there is neural tube defect, there is no scalp and the whole of the brain is being exposed outside. The brain will secrete fluid. As a result, there will be polyhydramnios. Right? So viral infections, neural tube defects, diabetes, they are the causes of polyhydramnios. Okay, clear? Chalo. So next question on this. Renal agenesis. Very good, Dr. Tawfiq. Correct. So, okay. So, Dr. Nanda has said that my video is getting stuck. Is it happening with everyone? Just let me know. Is my video getting repeatedly stuck? Then I just need to talk to the tech team if it is so. Tech team, can you please look into it that it should not get stuck? Right? Okay. So next question is, this was the next question, that which of the following finding is being seen? So can you see this dark vertical line? Can you see this? What is this line they are asking? So tech team, can you please just check into it that why my video is getting stuck? Just look into it. I don't know why it is happening. It is very irritating for the students to see a video like that. So what is this vertical dark line? It is linea, definitely not striagravidarum. Striagravidarum are like stretch marks here. Cloasma is on face, butterfly rash. What is it? Linea alba or linea nigra? See, linea nigra is the Latin word for black line. And same, so when the individual is not pregnant, then she has a vertical line which is white in color, linea alba. When she gets pregnant, then because of hypermelanin, because of increased melanin content, this same line turns black. In Latin, we call it linea nigra. So this is linea nigra because she is pregnant and it is dark color. Right? Let's move on. Okay. Next is, good morning, Dr. Utkarsh. Okay. Which of the following is the best parameter for indicating the fetal age? So you tell me, what is the best parameter? What is the best parameter when I want to see the fetal age in first trimester? Yes, it is crown rump length. So in first 12 weeks in crown rump length. After 12 weeks, significance of crown rump length is gone. It is not important. Then comes biparietal diameter from second trimester. So the important points about antenatal care which we have to know. So we are not going to discuss the whole antenatal care. We'll discuss the points which we need to remember. We have to know about the calculation of EDD. EDD, expected date of delivery, we know how to calculate. How do we calculate? Whatever date has been given, 25th March. So not 25th, let's do 24th March. We just add 7 days and 9 months. Okay, so always add 9 months first. So 9 months plus 7 days. So add 9 months in 24. March, April, May, June, July, August, September, October, November, December. Now add 7 days. When you add 7 days in 24, 25, 26, 27, 28, 29, 30, 31. So always see that this month will have 31st date or not. Suppose this date would have been 25th. So then the date तब हमारा EDD क्या होता? 1st January. So that is why always calculate month first. पहले month calculate करो, then you calculate date, because date might be 30, 32, then you have to jump on to next month. So EDD is calculated by Nageli's formula, where you add 9 months and 7 days. Here I know you must all be knowing this exactly, but what you all must not be knowing is if they give you the date of embryo transfer. जो EDD है LMP से we know 9 months 7 days. What about embryo transfer? Embryo transfer LMP की 14 days बात करते हैं. We do embryo transfer after 14 days of LMP. So we have to subtract those 14 days. So EDD from the date of embryo transfer is 9 months minus 7 days. Remember that. It is not plus. So if the question has given me the date of embryo transfer, I will add 9 months and I will subtract 7 days. Got it? This is very important. Okay, so Dr. Tawfiq has asked me to give the EDD of 23rd February. Okay, calculate Feb से 9 months will go. Feb, March, April, May, June, July, August, September, October, November. 23rd, 30 November. So it's easy. Problem कब होती? If it would have been 25. फिर हम क्या करते? फिर 30 November, इसके आगे 2 days we have to add more. It will be 2nd December. ठीक है? Clear? चलो. So EDD calculation we have to understand. Then we have to know GPLA calculation. Gravida, para, live and abortion. This is very important. They will always give you only one scenario. They will give you gravida, एक lady है, she is pregnant for the 3rd time. इससे पिछले डिलीवरी में she had one abortion. इससे पहले she had a twin delivery. They will always mention that because they want to know whether you know or not. In twin delivery, para is 1. Para means how many times she has been pregnant. So twin deliver हुए, but pregnant तो she was once only, no. So even when she has twins baby, it will be para 1. So if she has come for the 3rd time, she is gravida 3. She has one abortion, so A1. She has 2 live issues because it was twins. So this is the GPLA formula. Clear? Is this clear? Okay. So these two we have to know on antenatal care. Next, what do we have to know? The gestational age calculation that we have already revised. So first trimester में best is the crown rump length and second trimester में best is the biparietal diameter. This we have to know. ठीक है? Next, what do we have to know about the antenatal visits? So according to WHO, what are the antenatal visits that we have to do? 8. What are the postpartum visits that have been advised by WHO? 4. Okay, so I am just revising. Now I am not going to tell you what 8 visits at what gestation. No, it is not important. 8 visits होने चाहिए, that you have to know. ठीक है? Then calorie need. इस पे भी questions are asked. What is the calorie need? So calorie need in pregnancy, first trimester is always 0. And it is 340 and 452 in second trimester and in third trimester. ठीक है? Supplements, yes, questions are very frequently asked. अभी last year only they asked about the supplementation of folic acid, right? So folic acid prophylactic dose. Prophylactic dose का क्या मतलब होता है? What is prophylactic dose? The woman is not sick, she has no problem. Still you give her folic acid and iron to prevent anemia and neural tube defects. That is what we call prophylactic dose. So according to NRHM, जो हमारी guidelines है, according to NRHM, folic acid is 500 mcg, iron is 60 mg. ये बिल्कुल just remember this. गांठ बांध के just remember. 500 mcg folic acid and 60 mcg, 60 milligram iron. Got it? Then there are certain conditions where we have to give the increased dose of folic acid. There, why are we giving increased dose? Because women has some problem, some or other problem. That is why we are giving increased dose. It will not be cause prophylaxis. Prophylaxis we give to a person who is not ill, who has no high risk factor. It is called therapeutic dose. Why you are giving it to a person who has some problem? What problem? She has a problem in absorption. ठीक है, malabsorption है, obese है वो patient, her need is more, right? Or she has a high risk of neural tube defect. What is high risk? Her family history has neural tube defect. She has previous birth which was neural tube defect. Any of the parent is suffering from that. That is high risk. Diabetic women, women on epilepsy. So women on epilepsy, when she is taking an anti-epileptic, the folic acid metabolism becomes too much. In all these conditions, you have to give therapeutic dose which is 4 milligram. Somewhere it is 5 milligram also, depending on how much dose is available in market. It can be 4 milligram or 5 milligram. That is not the debate. Debate is in which conditions we give increased dose. There is one more condition, hemoglobinopathies, thalassemia, hemoglobin, sickle cell anemia, where RBC hemolysis is happening. For RBC manufacture, we need folic acid. Here we are giving hemoglobinopathies ke liye we need giving folic acid for RBC, not for neural tube defects. So no matter we are giving increased dose of therapeutic folic acid here, we will give it till 12 weeks. But in hemoglobinopathies, RBC hemolysis is happening all the time, right? So we will give high dose till 9 months. Is this clear? So what is the indication of therapeutic dose of folic acid? Hemoglobinopathies and all these conditions. Got it? This is just the last year question. You have to remember it. Let's discuss a little about vaccine. Okay, let me read a little more comments. अच्छा, डॉक्टर तौफीक has said third semester में 10 femur length. That's correct. Let's see about vaccines now. So what is routine vaccine? You might be knowing अब TT को remove कर दिया है TD से, tetanus and diphtheria. So they say कि अब pregnant women को we have to give tetanus and diphtheria both. ठीक है, कितना देना है? First visit पे TD दे दिया, after 1 month second dose दे दिया. Suppose she is a multi-para woman. She is delivering for the second time. If the last injection was given less than 3 years, her last delivery was less than 3 years, उसको पूरा she got an whole immunization, then we will give only one booster. So women come to me, she tells me that I have a baby boy of 2 years. Now I want TT dose. What will I ask? Did you got the whole vaccine, 2 doses in your first pregnancy? She said yes. Then I will tell her, bhai, you need only one booster because your duration is less than 3 years. Clear? This much? Now tell me about these vaccines. Which vaccines are allowed in pregnancy and which are not? So live vaccines are not allowed. Okay? Pneumococcal and meningococcal, are they allowed? Is pneumococcal and meningococcal vaccine allowed in pregnancy? Please somebody write. Pneumococcal and meningococcal are allowed. They are not live vaccines. They are kill attenuated vaccines. So they are allowed. I'll just change the ink. Yes. ठीक है, so pneumococcal and meningococcal. Doctor, अच्छा, one question has been asked that when will we give the booster? You can give it any time, but 4 to 6 weeks before delivery. So you can give booster any time, but give it before 4 to 6. That gap has to be there between the booster dose and the delivery. Okay? Chalo. Now pneumococcal and meningococcal, they can be given in pregnancy. HPV vaccine cannot be given in pregnancy. MMR, it's a live vaccine, not given. Varicella, not given. Yellow fever is a live vaccine. It can be given. It is the only live vaccine that can be given in pregnancy. Many times when questions are asked, people mark rabies. Yes, rabies vaccine can be given in pregnancy. Agar if a dog has bitten the lady, you can give rabies vaccine. It is not a live vaccine. It is a killed attenuated vaccine. Only live vaccine which is allowed in pregnancy is yellow fever. Right? So this much about antenatal care we have to know. Gestational age, GPLA formula, how many antenatal care we need, vaccines and folic acid. ठीक है? इससे ज़्यादा we don't need to know. Then the questions are asked on signs of pregnancy. So this is a very, very theoretical thing. I just hate teaching this because there are no ways by which you can explain it. They are just something you have to remember. But still I have taken out few ways by which you can try remembering them. Goodell's sign. So remember good. Good cervix is a soft cervix. So pregnancy may there is always a soft cervix, and it is very good because it is when the cervix is soft, it is a very good sign for labor. So good cervix, remember, soft cervix is good cervix. So Goodell's sign means cervix becomes soft. That is the only way to remember. Second, Osiander's sign. So remember os. Os कहाँ पे होता है? Cervical os is where? It is around the cervix. Os is near the cervix. So when you put your hands into the os, near the os, in the cervix, means in the fornix, you can feel the pulsation. So os, see, under, say, remember, when I'm keeping my hand around the os, then I can feel the pulsations of the vessel, and that is the Osiander sign. That is how you have to remember. Then comes the Piscace's sign. So P, how I used to remember, P ko ulta kar dete hain, this. So it is basically lateral implantation of the baby. So when there is lateral implantation of the baby, it leads to asymmetrical enlargement. It is Piscace's sign. Okay. Higgard's sign, see, H. H alphabet kaisa hai? If you are trying to approximate your fingers around H, can you approximate your fingers in the upper segment? Yes. Can you approximate your fingers in the lower segment? Yes. I cannot approximate my fingers in the middle segment because of this. That's what Higgard sign is. There is difference in consistency. So upper part is thick due to fetus, middle part is soft, and lower part is firm. So it is reverse. In Higgard sign, I cannot approximate my fingers above and below. I can approximate in between. That is what the Higgard sign is. Right? Palmer sign, when using my palm, both my palms, I am putting my hand in the uterus and on the abdomen, I can feel the rhythmic contractions. That is Palmer's sign. Okay. One sign, jiska I have no mnemonic, you can learn through it. It is Jacquemer's sign. So Jacquemer's or Cadwick's sign is dusky hue or vestibule. Why it is happening? Whenever the uterus becomes pregnant, suddenly the uterine blood flow increase. So when the blood flow increase, the vestibule and the vagina around and the vulval area become little bluish. So that is Jacquemer's sign. Got it? Is this clear to everyone? Chalo. Now let's solve some questions. We have read so much. Let's solve the questions which have been asked. Preconceptional use of dash leads to reduced incidence of neural tube defects. We know it is folic acid. What dose of folic acid is recommended for a woman who wants to become pregnant but has a history of pregnancy complicated with neural tube defect? So will it be prophylactic? No. She has a history. It will be therapeutic dose, 4 milligram. Right? Now, so we have covered the antenatal care, we have covered the placenta. Now we come on the favorite topic of FMG, that is MTP. And fair enough. So FMG, what is the purpose of asking these questions? So they want that once you have cleared the FMG exam, you have done the internship. If you are sitting as a medical officer, you will not just straight go away and clear the PGs, start practicing, right? You will somewhere sit as a medical officer. You have to know basic things. If a lady is coming to you, you don't need to do PG to tell her that what medical method you will be needing for abortion. You don't need to do PG to tell her ki bhai, what contraception will be best for you. So what folic acid dose you will be getting. So for that they want ki bhai, before doing PG, ye basic knowledge should be known to you. So that is why abortion is asked very frequently, because abortion is being faced very frequently. Okay? So last year 2 questions were there on medical termination of pregnancy. So women request MTP and doctor performs suction evacuation. Suction evacuation means just suck out. It is not curettage, just suction evacuation. Okay. So suction evacuation, till what date it can be performed? Suction evacuation can be done only till first trimester. After that, after 12 weeks, the baby becomes big. Uske fetal part starts forming. Now you cannot suck out only. When the hand is being formed, everything is being formed, you cannot suck it out. So you need furthermore methods that we will discuss. So for suction evacuation, it is 12 weeks. Let's discuss comprehensive abortion care guidelines of our country 2023. Important things only. Till what gestation the abortion is allowed? Till 20 weeks. Anyone can terminate. It's not anyone. Means anybody who's a physical disability, mental disability, rape victim, the baby has anomaly, anybody can terminate. One thing is contraception failure. So this contraception failure is a cover jiske under anyone can have come and tell that I am pregnant because of contraception failure. So she can terminate. So up till 20 weeks, with permission of one RMP, even a contraception failure patient can terminate the pregnancy. Till 24 weeks. But hamari abortion lines are very liberal. If you will see outside, they are very strict. Our abortion care guidelines are so liberal that they give women the liberty that you can have the abortion. So after 20 weeks, 24 weeks tak, till 22, only special category can have the abortion. Any physical or mental disability in the mother, she is a minor or she is a rape victim, then baby has any malformation, all those are allowed till 24 weeks. So suppose a girl comes at 22 weeks gestation, she was a rape victim. You will not let her be pregnant just because she has crossed 20 weeks. So till 24 weeks she is allowed. What is not allowed here? Contraception failure. If you have conceived because of contraception failure, come before 20 weeks. After 20 weeks, I am not going to entertain you. So this was the question. Just last year in FMGE exam in January, what they asked. 22 weeks, girl comes with contraception failure, how will you terminate? Permission of 1 RMP, 2 RMP, no permission. At 22 weeks, she cannot terminate. These conditions can terminate up till 24 weeks. And there is special category which can terminate at any gestation, and that is baby having any severe malformation. Many times when the malformation is diagnosed, it is too late. Sometimes it is diagnosed very late, at maybe at 30 weeks. So government said that if there is significant malformation in the baby, you can terminate your pregnancy at any gestation. But here you need permission of a medical board. From 20 to 24 weeks, you need permission of 2 RMPs. And contraception failure is not included in it. Is this clear to everyone? Yes, Dr. Toffee, 2 doctors needed from 20 to 24. Remember just that contraception failure doesn't come in this category. Right? What else? One more question was asked. The consent. If the girl is minor or she is mentally retarded, who will consent? Parents, doctor, legal guardian or spouse? Legal guardian. Neither parent. So this is the term. So this is what I have taken from the guideline. Only the consent of women is required, and in case of minor or a mentally ill woman, consent of guardian. So this is the term which is written in the guideline itself. Guardian will be giving the consent. Guardian can be anyone. It can be the spouse, it can be the parent, it can be the nurse taking care of her, but the guardian will do it. ठीक है? इसके अलावा one more thing which I think can be asked is according to POCSO. So protection of child against sexual offences, that any girl who comes at less than 18 years for abortion, as a doctor, what is your duty? They say you have to report to the medico-legal system, either the local police or the juvenile police. So as a doctor, you will check her, you will take her consent, you will do the rape kit examination. Will you inform the police? Yes. Right? Okay. Yes. So there is one more, without any anomaly, she should continue. Dr. Tawfiq, correct. So without any anomaly, that was the question, that she is 22 weeks without anomaly, she will continue the pregnancy. Correct. So we have read what does the abortion care guidelines say. Now we'll quickly see the methods of abortion. First trimester abortion. In India, medical methods are allowed only till 9 weeks. So we can give medical method of abortion only till 9 weeks. It is no more 7 weeks. It is till 9 weeks. Okay? What is the method? CAC is the Indian guideline. They say only 1 tablet, only 1 kit, mifepristone and misoprostol. That's it. So they keep it simple so that anybody, we as an MBBS graduate, any peripheral nurse can give the abortion. So mifepristone and misoprost on an OPD basis will be given as medical abortion for 9 weeks. How is miso given? According to WHO, just remember the name. WHO कहता है give miso. You can give miso alone, and WHO says letrozole and miso भी दे सकते हैं. It is not used right now in our country. How do you give? When the lady has come on day 1, I give mifepristone 200 mg. Remember the dose. I don't even remember how many times this has been asked. N number of times they have asked about the dose. So mifepristone 200 mg on day 1. Then on day 3, so for 24 hours do nothing. On day 3, call her again, give her misoprost 800 mcg. ये भी remember. You will just see how many questions has been asked on just these 2 doses. ठीक है? Day 3 पे we will give her misoprost, and then we will call her on day 15 to check whether the abortion is complete or not. How will we check? Either by doing the PV examination, if we have the facility, by doing the ultrasound examination. ठीक है? Then अगर suppose she is not ready for medical abortion, then we will do surgical. What it is? Vacuum aspiration. That was asked in the question. Vacuum aspiration means bus take the syringe, create a vacuum and remove it. The pregnancy is so small, you don't need to dilate and cure it and take it out. So vacuum aspiration is the term that you have to use during the first trimester. It can be manual, it can be electric. Manual matlab This syringe, this is a manual vacuum aspiration syringe, MVA syringe. It does not need electricity. It's just a big syringe. Insert it using a cannula and suck out. It is so small, the contents of reproduction are so small, they will come out. So this is manual vacuum aspiration syringe. ये Carman's cannula. It is for electric vacuum aspiration. ठीक है? So it is allowed only till when? First trimester, till 12 weeks. Because after first trimester, the baby has become little big. Now you cannot suck out. So the term used is dilation and evacuation. Dilate the cervix, evacuate. Evacuate का क्या? What do you mean by evacuate? खाली करना, to empty something. So evacuate using the cannula, using the suction, again cannula, again suction. So it is a little bit long process. So the term is dilation and evacuation. What do we use for evacuation? Ovum forceps. Remember this image also. So ovum forceps is used in second trimester. Plain suction is used in first trimester. Clear? Now let's see the questions. Okay, one more. So syringes are of two types. Manual vacuum. ये important है भाई. This was asked in the question. So either they are double valve. Can you see two valves? Double valve or single valve. So capacity in both of them, it has 50 ml capacity. It has little more 60 ml capacity. Pressure created is 660 mmHg in both of them. But why are they different? Because the cannula we attach here a cannula. It is of 6 mm cannula. Cannula ka size depends on the gestational age. If the gestational age is almost 4 to 5 weeks gestation, I will use this cannula. Here I can attach a cannula of 12 weeks. So if it's a larger gestation, I will use this. That is the only difference. Capacity is very similar, pressure is similar. Now let's see the question. Just 2021 mein this was asked. Which of the following is false regarding this instrument? What is this instrument? Manual vacuum aspiration syringe. It is used for termination up to 12 weeks, correct? Can be done on OPD basis? Yes, absolutely. Capacity is 30 ml? No, capacity is 50 ml. It creates a negative pressure of 660 mm? Yes. So this is your answer, right? So Dr. Tawfiq has asked how we can give. So Dr. Tawfiq, basically my video is running late, your questions are coming afterwards. So just let me know what you have asked, the complete question, how we can give. For what you are asking, how we can give. Because I am not getting it. Okay, so this was the question. Again, this was, can you identify? It's a very bad image, but that was the image. It's the Carman's cannula, which I showed you, the Carman's cannula. So this is for electric suction. Usage of the given device is measure the length of uterus. So see, there is a, can you see there is a hole? If you want to measure the length of uterus, why do we need this hole? Because menstrual regulation or aspiration is another name, another very old name for first trimester abortion. So this is the answer. Okay. So Dr. Tawfiq, you want me to repeat the medical method of abortion? I have told you, day 1 pe we will give mifepristone 200, remember the dose. Day 3 pe, for second day we do nothing. Day 3 pe we give misoprostol 800 mcg, remember the dose. And day 15 pe we call her again just to confirm if abortion is complete or not. If we see uterus is enlarged, os is open, products are coming out, ultrasound is showing me products, means it is incomplete. Okay? Acha, you explain. Thank you. Okay, right. Okay. A woman presented in her 8th week, first trimester, seeking MTP, appropriate dose of misoprostol. What it is? 200 mcg देखते don't mark. 200 mifepristone का होता है. That 2 milligram. 800 mcg. ठीक है? So this is all about the questions that have been asked on abortion. Okay? So we should move to ectopic pregnancy now. So which is the most common location of implantation in ectopic pregnancy? Obviously ampulla. So the most common location will be what looks like ampulla is most likely it is, I think, D. Yes, ampulla. Because the fertilization happens at ampulla, so it is the most common site. Okay. So ectopic pregnancy mein we will discuss only the points which we need to remember. Okay. 95% time the ectopic is in tubal. In tubal the most common site is ampulla. What are the risk factors? Anything which is distorting the anatomy of my tube, that will cause ectopic. जैसे कि PID हो गया, surgery, and important, using contraception. If she has been using contraception, as such she will not get pregnant. But if contraception failure occur, chances she might land into ectopic. Especially which contraception? Progesterone contraception. क्योंकि progesterone का one of the action is it decrease the tubal motility. That is why. So progesterone only pills, progesterone injections and IUCD Mirena, they increase the chances of ectopic. ठीक? How will you diagnose? The diagnostic method of choice for ectopic. In our time, it used to be surgery. That when you are doing surgery, you see it is there, then only it is diagnostic. But now it is TVS. It is so good now. So in TVS, either you will see a ring of fire. It is very characteristic. Can you see this gestational sac with ring of fire? This ring of fire is the blood supply. So this ring of fire is very typical of ectopic. Or you can see an adnexal mass, right? Or you can see a proper gestational sac with cardiac activity. So TVS is the diagnostic method of choice. How the question will give you scenario? Question will give you a woman with amenorrhea, with pain, abdomen and spotting. So amenorrhea, pain and spotting, early pregnancy they have given. Think of ectopic. ठीक है? Cervical motion tenderness and the signs of peritonitis can be there. What algorithm you need to follow? Again, Dr. Tawfiq correct. Risk factor में I forgot. Previous history of ectopic is the most common risk factor in fact. ठीक है? What algorithm you have to follow for the treatment? So expectant कर सकते हैं. Expectant means do nothing, send her home, it will resolve. Second is medical, third is surgical. Expectant when can we do? When she is stable, the sac size is less than 3.5. Remember, this was the question which was on. Sac is less than 3.5, beta HCG is less than 1500. Then only you can do. Suppose if the everything is same, she is stable, sac is less than 3.5, but beta HCG is more, then you can give medical up till 5000. So for medical, sac size should be less than 3.5, she should be stable, and the beta HCG can be 1500 to 5000. As soon as beta HCG cross 5000 or the GSAC is more than 3.5, I have to do surgical. What will I do? Laparotomy or laparoscopy? My method of choice is laparoscopy, and that too self-injectomy. I will cut the tube. When can I do self-injostomy? Self-injostomy means tube नहीं cut करना, just remove a part of the tube, take out the GSAC. That is done when the question is given that contralateral tube is damaged. Remember, FMG will not give this. I told you that they want you to know the basic things. बहुत hi-fi they don't want you to know. So remember, the treatment of choice is laparoscopic self-injectomy. Done if the beta HCG is more than 5000 or the sac is big or the cardiac activity is present. अगर baby की cardiac activity is there in the tube, this will rupture for sure. The baby is live, it will grow, it will rupture. Okay? What do we do for medical? क्या देते हैं? Methotrexate. Single dose or multiple dose? Single dose. In 95% patient, single dose से it is treated. So the treatment of choice is single dose methotrexate. ठीक है? Now let's see. 27-year-old female comes to emergency with bleeding and amenorrhea of 7 weeks. She is in hemodynamic shock with UPT positive. Any women, this line is written in Datta also. Any UPT positive patient with shock, until unless proved otherwise, it is ectopic pregnancy. Unless you can prove something else like pyelonephritis or fibroid, which are very uncommon. UPT positive shock, it is ruptured ectopic. ठीक है? चलो. Which of the following is not an indication for expectant management? Not. Initial beta HCG less than 200. 200 is very less. We can give till 1500. GSAC more than 4. GSAC less than 3.5. Asymptomatic, yes. Decreasing beta HCG, yes. So this is the answer. Here we cannot give expectant. Here we cannot give even medical also. Here surgery has to be done. So this finish our ectopic. Now comes the gestational trophoblastic diseases, GTD. So this was the question asked in 2021. This is the ultrasound finding of a primary 3 months amenorrhea. What it is? So many vesicles. Uterus is filled with vesicles. Molar pregnancy. Ectopic, definitely. Ectopic means you will find an adnexal mass, proper GSAC. Oligohydramnios, no chance. Baby नहीं है. How the oligohydramnios? Multiple renal cyst तो नहीं है. When there is cyst, सिस्ट बहुत डिफाइंड साइज की होती है. सी हाउ द सिस्ट लुक लाइक, डिफाइंड, रेगुलर. दे विल शो किडनी लाइक स्ट्रक्चर विद डिफाइंड सिस्ट. दीज आर वेसिकल्स, ग्रेप लाइक, किसी भी शेप के, एनी शेप. सो दिस इज मोलार प्रेगनेंसी, राइट? So gestational trophoblastic diseases can be benign and can be malignant. Why are they happening? Remember the trophoblast? क्या था trophoblast? In a blastocyst, this was inner cell mass and this was trophoblast. So whenever trophoblast is abnormal, it leads to GTD. So they can be benign when they are called molar. Complete or partial molar are benign, but they are pre-malignant because they can change into malignant one. What are malignant? They are malignant GTDs are together called GTN. Gestational trophoblastic neoplasias, which are invasive mole, PSTT, choriocarcinoma, all those. So क्या partial and complete mole will be called GTN? No, they are not neoplasia, they are benign. They are called GTD. ठीक है? Molar pregnancy में what important points you have to remember? Important point is complete mole हमेशा diploid होता है, XX, YY. ठीक है? एंड एंड्रोजेनिक होता है. इट मीन्स एम्प्टी ओवम को 2 sperms हैव मेड द ovum fertilized. So it is androgenic, means it has only paternal chromosome and it is diploid. Whereas partial mole is triploid. It has 3 chromosomes, X, X, Y. 1 is of mother, 2 is of father. X, X, X. So triploid is partial mole, complete mole is diploid and androgenic. ठीक है? This is how a complete mole look like. There is no baby, it's only vesicles. This is how a partial mole look like. Partial mole has a baby. This baby will not live, it doesn't live. It always presents as missed abortion. But this is partial mole, this is complete mole. ठीक है? How the question will give you the scenario now, this is always the main point. Now question, how will the scenario will be given? Question will give you early pregnancy with bleeding. They will mention large uterus. Molar में the uterus is always larger than the gestational age. And how you diagnose molar? Ultrasound. How you diagnose? What is the diagnostic of choice for ectopic? Ultrasound. Diagnostic of choice नहीं है molar के लिए ultrasound. Diagnosis में ultrasound will help you in diagnosis. Diagnostic of choice means you cannot confirmly say it is molar unless you get the histopathology report. क्योंकि वो complete mole है या partial, that only histopathology will tell you. कई बार baby इतना छोटा होता है, you cannot make out where the baby is. So confirmation is histopath. ठीक है? It looks like this on ultrasound, which was asked. Snowstorm appearance कहते हैं. What other thing the question can give us? Theca lutein cyst. Theca lutein cyst are present in molar. Why? क्योंकि ये जो beta HCG है ना, it is very high in molar. It leads to stimulation of ovaries forming big cyst. So these two, when given in question, they are indicating molar pregnancy. How do you manage molar? One line only and only one answer. Suction evacuation. Never say methotrexate. Methotrexate is not the treatment for molar. Be it partial mole or complete mole, it is suction evacuation. Right? What do we do about anti-D? We give anti-D in all the RH negative women. Post evacuation surveillance. किससे करना होता है? बीटा HCG. First of all, क्यों करना है? Why do we want to do the surveillance? Suction evacuation कर दिया, send her home. Because I told you it is pre-malignant, it can convert to GTN. And how will I know ये molar GTN में convert तो नहीं हो रहा है? By doing this surveillance, which I have to do till 6 months. So after suction evacuation is being done, I'll do the HCG levels weekly, and as soon as it gets negative, I will do it monthly till 6 months. Why? Because I'm scared of GTN. ठीक है? So gestational trophoblastic neoplasia में क्या क्या आता है? जेस्टेशनल ट्रोफोब्लास्टिक नियोप्लेजिया की बात करें, ये एक मैलिग्नेंट कंडीशन है. इट इज़ अ मैलिग्नेंट कंडीशन. इसमें आता है इन्वेजिव मोल, कोरियोकार्सिनोमा, PSTT एंड एपिथेलॉइड ट्रोफोब्लास्टिक ट्यूमर. इट इज़ अ मैलिग्नेंट कंडीशन. what are the risk factors? I don't think so are that important. मैनेजमेंट क्या है कोरियोकार्सिनोमा का? मोलार का मैनेजमेंट है सक्शन इवैक्यूएशन. कोरियोकार्सिनोमा का मैनेजमेंट है, इट कैन बी मिथोट्रेक्सेट और इट कैन बी कीमोथेरेपी डिपेंडिंग ऑन द रिस्क. कहाँ तक मैलिग्नेंट, कहाँ तक इट हैज़ स्प्रेड, हाउ रेजिस्टेंट इट इज़, what is the level of beta HCG. You don't have to remember the values, you just have to remember कि भी अगर it is a high risk patient, I will give her her whole chemotherapy. If it is a low risk patient, I will just give her methotrexate. Multi-dose methotrexate is given here. ठीक है? I will give methotrexate at day 1, 3, 5, 7 folic acid at day 2, 4, 6, 8 and then I'm done. अगर हाई रिस्क है तो आई विल गिव हर ईमाकोरेजिम. ईमाकोरेजिम की डोजेज याद नहीं रखनी है, बस ईमाकोरेजिम देना है हाई रिस्क में, ये याद रखना है. इसको भी फॉलो करना है. वी हैव टू सी ना कि पूरा का पूरा कैंसर हैज़ रिजॉल्व और नॉट. सो वी इसको फॉलो करेंगे फॉर 1 ईयर. मोलार को फॉलो कर रहे थे फॉर 6 मंथ. इतना इन कोरियोकार्सिनोमा एंड मोलार इज मोर देन इनफ. So because we have to follow this lady, we ask her to avoid pregnancy for 1 year. Got it? Clear hai? So a pregnant woman presented with complaints of passing grape-like vesicles. Ultrasound showed this. Which of the following hormone levels need to be checked? We have discussed. How are we monitoring the molar? HCG. How long we will monitor after management? 6 months. Clear? A woman who underwent dilation and curettage for molar 6 months ago presented with persistent symptom of pain and distension. On further evaluation, we saw beta HCG was high. Yani we were evaluating her, but it was high, and cannonball in lungs means it has metastasized. So molar tha, but it has metastasized. It means it has turned to something malignant. What is that something malignant among these? GTM. Simple? Okay? So, I just noticed that Dr. Nandini, you have written OHSS for those ovary. This is very good. So, when I showed you the ovaries, these ovaries, remember, just I'll take 1 second. I need to explain this. Exactly. These are hyperstimulated ovary. And here they will be called theca lutein cyst. Theca lutein cyst are those present with molar. OHSS, ovarian hyperstimulation syndrome, ovary look exactly the same. So अगर आपको question नहीं, this picture has been given, how will you differentiate between these two? Based on history. That's not what I am saying, that's the book say. Ovaries looking like this, you can differentiate कि वो theca lutein cyst है या OHSS based on history. Infertile patient है, she is taking IVF treatment, it is OHSS. Pregnant patient है, bleeding है, this picture, molar. ठीक है. चलो नेक्स्ट, ये हो गया. सीरियल मॉनिटरिंग ऑफ सीरम बीटा HCG इज रिक्वायर्ड इन विच ऑफ द फॉलोइंग कंडीशंस? विच कंडीशंस? यू टेल मी. किस कंडीशन में वी नीड सीरियल बीटा HCG? मोलार, राइट? So these all are PYQs. These all questions have been asked. So this much is more than enough in molar and GTM. Now this question. Okay. A 24-year-old woman comes to infertility with complaint of recurrent abortion. On investigation, she has a septate uterus. Which of the following corrective procedure has best obstetric outcome? So septate uterus means uterus is there is a septa. Obviously, she will have recurrent abortions. Jones metroplasty, Tompkins metroplasty, ये abdominal procedures हैं. You open the abdomen, open the uterus, cut the septum, stitch the uterus. So after surgery, uterus has such a big scar. Will this be a good surgery for a baby? Eventually, when she will get pregnant, this scar can rupture anytime. Trans-cervical resection means you go through vagina and you cut it like this. After surgery, uterus has no scar. Internally, आपने septum को cut कर दिया. So this has the best outcome. This uterus will never rupture, right? So let's discuss about the uterine anomalies now. Only the important points. I know you might be knowing majority of the things. We'll revise only the important things. So different classes होते हैं. Class 1 होता है जो हम amenorrhea में we will read MRKH जिसमें dysgenesis होता है. The uterus and vagina are not formed. Class 2 disorders है vertical fusion defect. ये होता है vertical. Means the lower segment has not combined with the upper segment, leading to what? Vaginal septum, which we read in cryptomenorrhea. So transverse vaginal septum, cervical agenesis is vertical fusion defect. When we are reading about recurrent abortion, we are reading about the lateral fusion defect. Mullerian ducts are two tubes which combine eventually in the uterus only. When the baby is intrauterine, then only they combine. So it is the combination that happens within the uterus. Now when this combination is not happening, it is lateral fusion defect, right? It can be uterus diadelphys, fusion हुआ ही नहीं है, 2 vagina 2 uterus, bicornuate, then septum and unicornuate. They all are lateral fusion defects. So Common questions which are asked are, which is the most common anomaly? Septate uterus. How the patient will present? In a lateral fusion defect patient कैसे present करेगा? With recurrent abortions. Uterine cavity is small, so she will have either recurrent abortion or she will have preterm labor. ठीक है. और जैसे diadelphus में there are 2 vaginas, so while having coitus she will have a painful coitus, dyspareunia होगा उसको, right? और क्या हो सकता है? She will be having difficulty in using tampons because there is a septum in the vagina, so that's how the patient will present. Among all these, which one has the worst obstetric outcome? Unicornuate. This uterus has the bad obstetric outcome. Very early preterms happen in this. Which has the best outcome? Septate followed by diadelphus. What is the diagnostic method of choice? 3D ultrasound. पहले we used to say it is laparoscopy plus hysteroscopy. It was initial years में when the 3D ultrasound was not there. So what is the diagnostic method of choice for uterine anomalies? 3D ultrasound. ठीक है. How do we manage? Septum है तो resect the septum. We have just read that abdominal methods है and hysteroscopic methods है. Bicornuate है uterus, then you try to unify them. ठीक है. So this was the procedure. Jones metroplasty and Tompkins metroplasty. You don't need to know much detail. Just remember कि these are abdominal procedure where we cut the whole segment जिसके अंदर septum है. So it is such a big segment you are taking out and you are giving such a big incision. Will it have a good obstetric outcome? No. Whereas when you are doing a transcervical resection hysteroscopically, then you are not giving any scar on the uterus, which has a good outcome. Correct? Ciao. Now this was again a question. Primigravida woman gives birth to a baby with following defect. Identify the anomaly. This is craniorachis. I don't know how to pronounce it, but all these are neural tube defects. You have to just remember based on the image. When this defect is running from the brain to cervical vertebra up till thoracic vertebra, it is this defect. ठीक है. Meningoencephalocele presents with the sacral vertebral defects majority of time. Okay, myelomeningocele. Meningocele means just the meninges are coming out. Myelomeningocele will present with either a hair tuft is here or a tuft is coming जिसमें neural tissue भी है, meninges भी है. ठीक है. बार बार बताओ यार क्या कर रहे हैं. So let's discuss a little about fetal aneuploidy screening. ठीक है. So aneuploidy screening because there are risks of aneuploidies in the fetus. Aneuploidy का क्या मतलब होता है? Chromosomal defects. ठीक है. Chromosomal basically defect in the chromosomal number. So in first trimester में what all we can do in first trimester? We can either do blood test or we can do the ultrasound. So blood test को हम कहते हैं dual test. Why? Because we are checking the 2 markers, PAP and beta ECG. So question क्या पूछा जा सकता है? When do we do the dual test and what markers are we checking? That's it. So we are doing it in first trimester. We are checking beta ECG and pregnancy associated plasma protein. अल्ट्रासाउंड भी करते हैं जिसमें भी चेक दी जिसको हम कहते हैं लेवल 1 स्कैन. फर्स्ट टाइम कर रहे हैं, सो लेवल 1 स्कैन वी कॉल इट. सो आई एम जस्ट okay, level 1 scan. So what are we seeing on level 1? Basically nuchal translucency. As such nuchal translucency का अपना it has no significance on itself. ऐसा नहीं है that if this fluid is more in the baby will have some problem because of this fluid. No, it is an indirect indicator of aneuploidy. It's an indirect indicator. दूसरा, can you see this nasal bone? So absent nasal bone ऐसा नहीं कि it is just absent. It is an indirect indicator of the aneuploidies. So when this level 1 scan show increased nuchal translucency means more than 3 mm, we are thinking about trisomy, which is most common 21. It can be 18 and 13 also. If not trisomy, suppose आपने कर लिया karyotype, there is no trisomy. Is this baby with high nuchal translucency at any other risk? Yes. The baby is at risk of Turner syndrome and cardiac defects. Cardiac defects में भी nuchal translucency बढ़ जाती है. They both are done within 11 to 13 weeks. After 13 weeks, when the lymphatics are established, this fluid will go. Nuchal translucency will अपने आप decrease. So even if it is trisomy, it will decrease. So there is no significance of doing it after 13 weeks. You have to do it in early gestation. You got it? What do I do in second trimester? नहीं आई patient first trimester में. She didn't come. In second trimester में do I have an option? Yes. I can do blood test, which is called either triple test or quadruple test. Triple test, remember with ABC, alpha fetoprotein, beta HCG, C से याद रखो unconjugated estriol, C ये वाला C, थोड़ा सा I know it's not a good example but that's what it is, unconjugated estriol. इसी में inhibin डाल देना, inhibin A, it is not inhibin B. Inhibin A ऐड कर दो, it is quadruple test. ठीक है? So when am I doing quadruple test? I am doing it at second trimester. Is there anything else we can do for aneuploidy? Per se, no. In second trimester we cannot do as such for aneuploidy. We'll do a level 2 scan. Level 2 scan का मकसद क्या है? Now the baby is big enough. उसकी baby has got hands, legs, everything has formed. It is basically now for structural defect. कोई structural या कोई neural tube defect तो नहीं है. Aneuploidy is a chromosomal defect. Down syndrome में baby में कोई structural defect नहीं है. It is a problem in the chromosome. But level 2 scan is for any structural defect. जैसे कि neural tube defects, cardiac anomalies. ठीक है? So first trimester screening में we did this nuchal translucency, HCG and PAP together. Suppose we get a low, high risk, और अगर हमें we get a high risk result, what will we do? As we get a high risk result, we'll do straight away diagnostic test, which is either chorionic villus sampling or amniocentesis depending on gestation. ये भी हम याद करेंगे at which gestation हम क्या करते हैं. So I get first trimester screening result high risk, I do these. I get low risk result, I'll send her home. कोई risk नहीं है, go home. I get a intermediate risk, I do second trimester screening. That is how we manage the patient. Is this screening done in every woman who is pregnant? या कोई is there a criteria कि भाई if she is old in age, she has high risk, तब करते हैं? सब में. Every lady who has been pregnant, you do aneuploidy screening in everyone. If she has come in first trimester, do first trimester screening. She has come in for the first time in second trimester, do second trimester screening. It is done in everyone. Another question can be asked, what is this? Can you see the cannula is going to the placenta? It is chorionic villus sampling. Chorion, अभी हमने पढ़ा था, we read it. Chorion is placenta. So chorionic villus sampling done in first trimester. Can you see the needle is going in the amniotic fluid? Amniocentesis done in 15 to 20 weeks. ये gestations याद रखने. इतने early gestation पे amniotic fluid is not that much कि आप amniocentesis करो. So amniocentesis is done at 15 to 20 weeks. This is done at early gestation. So the question, in which trimester is quadruple test performed? Second trimester. Right? ठीक है? ठीक है? So somebody is asking me my Telegram link. Dr. Sandeep, I don't have a Telegram group. I'm so sorry. I have a WhatsApp group which is exclusively for the questions and answering the questions and doubts. Dr. Tawfiq Noor. So I will share that link. You can become part of that WhatsApp group. Okay? Chalo. So what we have read, we started from the basics to placenta pe, abortion, and then ectopic, molar, and then we read aneuploidy screening. Medical complications mein, I have always seen they are mainly focused on two medical complications. That is diabetes and hypertension. So in this last minute, we will revise only these two. थोड़ा सा we will revise RH also. ठीक है? And if suppose some medical complication you think was important to discuss, once you are in my chat group, you ask me question, I will be always available to answer. ठीक है? So this was the question. The screening method for GDM. Okay. Yes, okay, so Dr. Nandini is asking the chordocentesis. Yes, the chordocentesis is another confirmatory idhar. So when do we do diagnostic test, one more test besides chorionic villus sampling and amniocentesis, books like chordocentesis भी लिखते हैं. But you know, chordocentesis aneuploidy screening के लिए generally नहीं करते. We don't need it. You need to go up till the fetal umbilical cord. Umbilical cord is thick enough at around 15 to 20 weeks. You can do it that time also, but it is risky. Chordocentesis का main indication क्या है? RH negative. When the baby is RH, in an RH negative woman, the baby is anemic. Then you go into the cord for the vessel, and you, when you want to give the blood transfusion, then the chordocentesis is done. Is it a diagnostic test? Yes, it is. But is it commonly done? No. What is the gestation when it is done? 15 to 20 weeks. Because उससे पहले cord is very thin. You cannot go inside the cord. ठीक है? चलो, दिस वॉज द क्वेश्चन. द स्क्रीनिंग मेथड फॉर GDM इन इंडिया इज डन बिटवीन. पहला स्क्रीनिंग इज डन एट फर्स्ट विजिट. इन आर कंट्री जैसी वीमेन आती है OPD में, वी डू ऑल द स्क्रीनिंग टेस्ट, बिकॉज इंडिया में शी हैज़ कम नाउ, यू डोंट नो व्हेन शी विल कम अगैन, एंड दिस इज एक्चुअली द सिनेरियो. वो एक बार आ गई, यू विल नेवर सी हर इन लाइफ अगैन इन गवर्नमेंट हॉस्पिटल. तो ऑलवेज द फर्स्ट स्क्रीनिंग इज एट फर्स्ट विजिट. उसके बाद इफ शी इज़ नेगेटिव, आई रिपीट इट एट 28 to 32 वीक्स. ठीक है, सॉरी नॉट 20, आई एम सो सॉरी, 24 to 28 वीक्स. बिकॉज GDM होता क्यों है, ये जो प्लासेंटा है ना, दिस प्लासेंटा प्रोड्यूस सो मेनी एंटी इंसुलिन फैक्टर्स जिसकी वजह से GDMs हैपन्स. फर्स्ट विजिट पे तो हमने कर ही लिया है. वाई? बिकॉज इंडिया में मैनी लेडीज आर डायबिटिक, हमें पता भी नहीं होता है. एनीवेज वी डू इट फॉर फर्स्ट ट्राइमेस्टर. अगर इधर नेगेटिव है, वी डू इट एट 24 बिकॉज वी नो कि 24 पे प्लेसेंटा इज लार्ज इनफ टू कॉज GDM नाउ. Many times when placenta is large, then only GDM happen. So I will repeat it at 24 to 28 weeks. ठीक है. So as per WHO, we have to screen at the first visit, and if negative, then again at 24 to 28 weeks. What do we do for screening? Universally पूरी दुनिया में OGTT करते हैं. ठीक है. Where they do fasting. पहले वो fasting करते हैं, फिर वो 75 ग्राम they give glucose, then they check sugar at 1 hour 2 hour. But we don't need to remember the values and all this. Why we do DIPSI? Because see, in our country women will be coming fasting from that far area. She will come after 1 hour and 2 hour. That is not possible. We have to keep the things simple for our country. That is why DIPSI जो था Diabetes in Pregnancy Study Group of India, उन्होंने they made this criteria. They said we will not do fasting. भैया हमारी women is coming from a rural area, we cannot ask her to come fasting. We will not do fasting. It is single step. We will give her 75 gram glucose and we will check blood only once, that is after 2 hours. So single step है. Single step means glucose दिया, after 2 hours we check the sugar. We have to keep it simple. If it is more than 140, she is GDM. Irrespective of gestational age, अगर वो 10 weeks gestation भी है, we will call it GDM. उसको diabetes नहीं कहेंगे. So GDM is not depending on gestation एज. कोई भी gestation एज हो, आपने फर्स्ट टाइम उसे डायबिटीज़, यू हैव डायग्नोज्ड इट फॉर द फर्स्ट टाइम इन प्रेगनेंसी, वी विल कॉल इट GDM, अनलेस द शुगर्स आर वेरी हाई. GDM is happening because placenta is releasing the anti-insulin factor. The sugars will not be very high. If the sugar is very high, it means आपने glucose दिया and after 2 hours it is 200. Remember, no matter what the gestation is not important here. She is not GDM, she is diabetes mellitus. उसको पता नहीं था, she never knew she was actually a diabetic patient. So whether she is diabetic or not, it is not dependent on gestation, it is dependent on the value of sugar we are getting. So if her HbA1c is high, her fasting is more than 126, ये वैल्यू तो याद रखनी पड़ेगी. Her fasting is high, HbA1c is high, her random blood sugar is more than 200, we have given glucose, it is 200, then she is not GDM, she was a overt diabetic. It is nothing to do with gestation age. ये never say this कि more than 20 weeks है तो GDM कहेंगे, less than 20 weeks है तो diabetes कहेंगे. नहीं, ये hypertension की discussion नहीं कर रहे हम. ठीक है. It is sugar value which is telling us, the sugar value is telling us that whether she is DDM or diabetic. So this was the question. I really like FMG questions. So FMG में they always ask basic question कि whether you know definition of diabetes और GDM में difference. Treatment तो you will remember later also. पहले learn the definition. So this was a very good question. Yes, so 30-year-old patient at 18 weeks. 18 पे her random sugar is 243. Further test किया, fasting is 146. HbA1c is 7.6. Everything is high. What is this? Is it maturity onset diabetes of young, overt diabetes, gestational diabetes, latent autoimmune diabetes in adult? We don't know about all this. As a gynecologist, we know it is overt diabetes. ठीक है. Later it can be checked whether it is autoimmune induced or MODY, whatever the definition is. For us, she can be either GDM or overt diabetes. With such high sugar, she is actually overt diabetes. Overt diabetes मतलब diabetic पहले से, before pregnancy she was diabetic. Got it? So complications क्या हो सकते हैं pregnancy में? So remember, GDM or diabetes have similar complication except one. I'll tell you what is that one. So maternal complications are same. Antenatally क्या क्या हो सकता है? There is high risk in diabetic patient. One who is diabetic, there is high risk she can be preeclampsia also. ठीक है, इसलिए you give aspirin prophylaxis in everyone. इसके अलावा in both of them there is tendency of giving a macrosomic baby, big baby. Both of them can have a big baby. So all the complications are because of that. Large gestational age, obstructed labor, cesarean section, delivery हो गई तो postpartum hemorrhage. So everything because of large baby. One complication is extra in diabetes, which is not there in GDM. That is the fetal anomalies. Patient जब pregnant हुई, when her organogenesis was happening, GDM में sugar was not high, and generally GDM develops later in life. So her organs will develop normally. उसको anomaly नहीं होगा. But a patient who was diabetic already, when organogenesis is happening, because of increased free radicals, her organs will be affected. So congenital anomalies will not happen in GDM. They will happen in diabetes. ठीक है? First trimester में she can have abortion, she can have congenital malformations. Second trimester में ये तो common है, ये दोनों में हो सकता है. Hydramnios, preterm birth, intrauterine death, है ना, ये सब you know, shoulder dystocia, large gestational age. About congenital malformation, what is the most common malformation in a diabetic patient? Cardiovascular. Which cardiovascular defect is most common? VSD. Which cardiovascular complication is most specific for diabetes? TGA. So TGA is not most common, it is most specific, but most common is VSD. जैसे कि the most specific congenital malformation क्या होती है डायबिटीज़ में? Sacral agenesis. Sacral vertebra नहीं बनती है. Is it most common? No, it is very rare. But it is very specific that if patient has sacral agenesis, we will think of diabetes. Got it? Is it clear? ठीक है. So if we know that a diabetic patient has risk of fetal malformation, is there something which tell us कि which diabetic patient has high risk, which diabetic patient has low risk? The best is to predict. Predict मतलब अभी वो pregnant नहीं है. How can we predict who will have high risk of malformation? HbA1c. HbA1c is showing the sugar control she is having. If her HbA1c is very high, she has such a high risk of malformation. So she need to control her HbA1c before she gets pregnant. So what is the HbA1c that should be told to patient before getting pregnant? 6.5. 6.5 से ज़्यादा है, think of your pregnancy, it can be risky. So this is the preconceptual targets. Targets मतलब what do we give to women? So I'm just checking this. Okay, yes. So preconception counseling क्या होता है? That if a diabetic patient is coming, these are the target sugars she have to keep to be on when she becomes pregnant. Low HbA1c, FBS less than 195, 1 RPP less than 140, 2 RPP less than 120. ये वैल्यूज याद करो, एटलीस्ट ये वाली वैल्यू याद करो. 1 RPP लेस देन 140, 2 RPP लेस देन 120. ठीक है. क्या ट्रीटमेंट करना है? व्हेन शी इज़ डायबिटिक एंड शी गेट्स प्रेग्नेंट, सर्टेन ड्रग्स हैव टू बी स्टॉप्ड. व्हाट ड्रग्स we cannot give in pregnancy? ACE inhibitors, AT antagonists, statins. We cannot give all this in pregnancy. Then her HbA1c, we ask her कि भाई अपना HbA1c and fasting control करो. We will give her aspirin. Why? We are preventing what? Preeclampsia. ठीक है. And high dose folic acid. Diabetes mellitus is an indication for therapeutic folic acid. ठीक है. Delivery, very important. Be it GDM, be it diabetes, I don't care. If she is controlled, she will be delivered at 39 weeks. If she is, besides giving insulin and everything, her sugars are not controlled, I will deliver her at 37 weeks. ठीक है. This has also been asked. When will we deliver? 39 and 37 weeks. Even if she is on insulin, even if she is on oral medications, she is on diet, कोई फर्क नहीं पड़ता. Everyone who is controlled, you will deliver her at 39 weeks. ठीक है. सो डॉक्टर तौफीक, वी आर कमिंग टू द ड्रग्स ऑफ चॉइस. सो ट्रीटमेंट ऑफ शुगर्स का कैसे ट्रीटमेंट करना है? वेन एवर अ वुमेन गेट्स प्रेगनेंट एंड शी इज़ GDM और डायबिटिक, फर्स्ट थिंग यू एडवाइस इज न्यूट्रिशन एंड एक्सरसाइज. आफ्टर दैट यू विल चेक, आफ्टर 2 weeks you will check the sugars. Remember what were the targets? 2 RPP should be less than 120, 1 RPP should be less than 140. अगर ये हाई है, then you start with metformin, and if metformin is not giving you control, you start on insulin. भले यू स्टार्ट मेटफॉर्मिन पहले बिकॉज इट्स एन ओरल ड्रग, But if asked, what is the drug of choice? It is always insulin. First line drug is always insulin. Metformin cannot be given in a lady who is less than 20 weeks. So what is the drug of choice for a pregnant in GDM? Insulin. Right? Clear hai? So this much about GDM, ki when to screen, when to call it GDM, when to call it overt, and how to treat. Basic. Doses nahi, they will not ask you doses. At least you should know the drug of choice. This is more than enough. Clear? Chalo, dusra, what do they ask a lot? A 32-week gestation admitted with BP 150/90. Urine dipsticks 2+. So you can understand what we are discussing. On examination, she has pedal edema. What is the diagnosis? 32 weeks hai, hypertension hai, urine protein plus hai. What is it? Previous abruption hai, preeclampsia. It was such an easy question, right? Okay. So what is definition of preeclampsia? Now here comes gestation. यहाँ पे gestation comes. Hypertension beyond 20 weeks. Either value of hypertension doesn't matter. After 20 weeks we call it preeclampsia. Before we call it chronic hypertension. So hypertension at more than 20 weeks plus any of the following means proteinuria. Suppose proteinuria नहीं है, but तेरी maternal organ dysfunction है, means LFT deranged है, pulmonary edema है patient को. She is telling you permanently headache है मुझे, which is a sign of neural involvement. So all these are also preeclampsia or uteroplacental insufficiency. Hypertension at more than 20 weeks with baby IUGR, it is preeclampsia. So proteinuria is not a necessity. ठीक है? Significant proteinuria किसे कहते हैं? Proteinuria has to be significant. Means protein can be secreted in urine as such also. If a patient gets UTI, उसको भी protein secrete होता है ना. So there has to be significant proteinuria. Means more than 300 milligram in 24 hours or +1 on dipstick or urine protein creatinine ratio more than 0.3. ठीक है? So ये तो भैया we have to remember. Okay? So when a lady has come to me, she has suppose at gestation of 24 weeks, she has high BP. What will I do? First test जो मैं करूँगी, which is more easy to do for making a diagnosis, is urine protein. सबसे पहले I'll do dipstick, because if urine protein is high, I'll know she is preeclampsia, because preeclampsia is a severe condition, right? इसके अलावा I will check. Preeclampsia is a multi-organ disorder. It will involve lungs, it will involve brain, it will involve kidney, and it will involve the baby. So I'll do everything check. I'll check everything to see क्या organ involved है. I'll do LFT, I'll do CBC because I want to see the platelet count. I'll do serum creatinine and I will do ultrasound. Upper abdomen, why? Because आपको पता होगा that liver hemorrhage happened. And for the baby, I'll do ultrasound. All this will tell me that what all organs are involved in preeclampsia. Why is it so important for knowing क्या involved है? Because if any of these organs are involved, LFT deranged है, creatinine deranged है, thrombocytopenia, then she is severe category. And we have to rule out whether the preeclampsia is severe or not, because management is totally different. Totally different. Severe and non-severe, they are totally different management. ठीक है? So any patient with severe preeclampsia, do we admit? Yes. When do we start the treatment of preeclampsia? What is that BP range? 140/90. It means any patient with high BP 140/90, I'll start treatment. ठीक है? What will I give for treatment? My first choice in preeclampsia, in hypertension, chronic, anything, pregnancy with hypertension, my first choice is always labetalol. Oral labetalol अगर non-emergency है. If it is an emergency high BP, IV labetalol. But labetalol is always my first choice. Nifedipine, methyldopa. ठीक है? As second choice, third choice. ये है for non-severe hypertension. So इसमें remember this thing. बस ये last, remember the last box. I will admit severe, I will not admit non-severe. I will deliver severe preeclampsia at 34. I will deliver non-severe at 37. That is why I was doing CBC, LFT and KFT, because if any organ is involved, I will call it severe. If BP is high, I will call it severe, and I will deliver her at 34. Are there any indications where I can deliver her immediately? Can I deliver this patient immediately? Yes. So early delivery is when I am not able to control BP or deterioration or organ dysfunction, means eclampsia है और HELP है. These are the last stages. अगर ये हो गया है, डू आई वेट टिल कि भी सीवियर को तो आई मैम ने कहा था 34 वीक्स तक वेट करना है. नो, इन सच अ सीवियर कंडीशन यू डिलीवर इमीजिएटली. सिमिलरली इन बेबी, इफ इट इज़ एब्रप्शन मीन्स इट इज़ द लास्ट स्टेज फॉर द बेबी. इसके बाद तो बेबी विल बी IUD ओनली. सो इन दोज टू कंडीशंस यू डिलीवर इमीजिएटली. Okay, what did we discuss about drugs? Labetalol, nifedipine, methyl-dopa are the important drugs. What do we have to remember? It's okay if you don't remember the doses. Remember this. Contraindications of labetalol. This is the last year question. Which drug you cannot use in asthma? Labetalol. What will be your second choice? Nifedipine. ठीक है? So asthma and heart block, I cannot use labetalol. Okay? एस्थमा में और क्या क्या यूज़ नहीं कर सकते. आई कैन नॉट यूज़ प्रोस्टाग्लैंडिन्स, PGF2 अल्फा. आई कैन नॉट यूज़ मिथर्जिन इन PPH. आई एम टॉकिंग अबाउट PPH. ठीक है? एंड आई कैन नॉट यूज़ लैबिटोलॉल इन एस्थमा. सो दिस वॉज द क्वेश्चन. अ प्राइमी ग्रेविडा कम्स एट 26 weeks with BP this high. What is the test that should be done next? Just we have read यूरिक एसिड, LFT, CBC, यूरिन डिप्स्टिक. इफ़ यू रिमेंबर हम सारे टेस्ट कर रहे थे. बट द फर्स्ट स्टेप इज मेकिंग अ डायग्नोसिस. अभी 150-90 है. इमीडिएटली डायग्नोसिस में विच विल हेल्प देन एंड देयर यूरिन डिप्स्टिक. इफ इट इज़ पॉजिटिव वी नो इट इज़ प्रीएक्लेम्सी. सो द फर्स्ट स्टेप इज बी यूरिन डिप्स्टिक. बाकी डोंट वी डू दैम, वी डू दैम, बट द फर्स्ट इज डिप्स्टिक. ओके, चलो नेक्स्ट है भाई, हाउ डू वी मैनेज. So when it comes to, so if it is a non-severe hypertension, it is not severe, कोई organ involvement नहीं है, BP is less than 160-110, then give her antihypertensive and deliver her at 37 weeks. But if it is a severe hypertension, then there is 3-prong management. इसी flow में याद रखना है. सबसे पहले मैक्स सेल्फ, उसके बाद antihypertensive and then deliver her. So remember, any patient BP 160-110, फर्स्ट स्टेप क्या करेंगे? क्वेश्चन ने पूछा फर्स्ट स्टेप, एंटी हाइपरटेंसिव नहीं देंगे. फर्स्ट स्टेप शी विल हैव कन्वर्जेंस, गिव हर मैक्सेल फर्स्ट, देन गिव हर एंटी हाइपरटेंसिव एंड देन प्लान फॉर हर डिलीवरी. ठीक है? स्टेरॉइड्स आर गिवन इफ शी इज लेस देन 34 weeks. सो मैक्सेल्फ के बारे में हमें व्हाट डू वी हैव टू नो? वी नो 2 regimes, प्रिटचार्ड एंड ज़ुस्पैन. सो लोडिंग डोज दोनों में सेम है, 4 ग्राम IV प्लस 10 ग्राम IM. दोनों में 4 ग्राम IV प्लस 10 ग्राम IM, दोनों में इट इज़ द सेम. बट यस, 10 ग्राम IM दोनों में द डोज इज़ द सेम. बट मेंटेनेंस डोज ये IM होती है, ये IM देते हैं. इट इज़ वाई इट इज़ प्रेफर्ड. दिस इज़ इन्फ्यूजन. इंडिया में इन्फ्यूजन सेट इज़ नॉट अवेलेबल एवरीवेयर. सो इन इंडिया व्हाट डू वी डू? वी गिव प्रिटचार्ड रेसिप. मैक्सेल्फ के बारे में व्हाट डू वी हैव टू रिमेंबर? बस रिमेंबर दीज पॉइंट्स. व्हाट इज़ द फर्स्ट साइन ऑफ टॉक्सिसिटी ऑफ मैक्सेल्फ? लॉस ऑफ डीप टेंडन रिफ्लेक्स. नेक्स्ट साइन क्या होगा? एक बार लॉस ऑफ डीप टेंडन रिफ्लेक्स हैज हैपेंड, व्हाट विल बी द नेक्स्ट थिंग दैट विल हैपन? रेस्पिरेटरी डिप्रेशन. सो मैक्सेल्फ हैज़ अ वेरी स्मॉल थेरेपेटिक इंडेक्स, मीन्स जैसे ही दैट वैल्यू ऑफ थेरेपेटिक इंडेक्स इज क्रॉस्ड इट विल कॉज टॉक्सिसिटी. सो वी हैव टू डू अ वेरी क्लोज मॉनिटरिंग एवरी 4 hourly. सो ऑब्वियसली हम उस 4 hourly मॉनिटरिंग में क्या देखेंगे? I will see deep tendon reflex because that is the first thing to go. I will see the respiratory rate because respiratory depression can happen. Or I will see urine output. Why? Because MaxSelf is excreted via urine. So I will check urine output कि वो कम तो नहीं हो गया, because if that is come my MaxSelf toxicity will happen. So these 3 things are checked every 4 hourly. What is the antidote? Calcium gluconate, calcium chloride. These things you have to remember about MaxSelf. Okay? So what were the antihypertensives for a non-severe hypertension? I said be labetalol hai. I'll just change to a better color. Labetalol followed by nifedipine followed by methyl-dopa. So see, they are a little slow acting. Oral labetalol, nifedipine. When for rapid control in severe cases, my first choice is labetalol again, IV. Again the contraindication is asthma. But if labetalol is not working, my second choice here is hydralazine. Hydralazine is only used in rapid control. It is not used in a non-severe patient. Hydralazine is second choice, 5 mg IV. I don't think so you need to remember that. Third choice is nifedipine. Methyl-dopa एक बहुत slow acting drug है. We do not use it in severe hypertension. Okay? चलो, so we read about the preeclampsia का what is the definition, how are we investigating, when will we terminate and how will we terminate. We read two emergency conditions, HELP and eclampsia. थोड़ा सा we read about HELP. What is HELP? It is a triad of hemolysis, elevated liver enzyme and low platelet. Hemolysis question हमें कैसे दिखाएगा hemolysis? Either they will give hemolyzed RBC or they can give high LDH. Remember, LDH is an enzyme from RBC. So when the LDH is high, it is hemolyzing. It is the hemolysis which question is showing us. Elevated liver enzyme means AST/ALT more than 2 times. इससे ज़्यादा नहीं होते हैं. It is more than 2 times. मतलब around 80 to 90. Low platelet. All 3 should be present to call it HELP. All 3 of them. ठीक है? Now this was the question. A 23-year-old at 25-week gestation present with right upper quadrant pain, nausea, vomiting. BP is normal. Now this was a little controversial thing. BP normal, but peripheral smear में there is hemolysis and leukocyte count is okay 10,000. Platelet is less. Hematocrit is 26%. AST is 90. So when 3 things are present, it means HELP can be there even if the BP is normal. Yes, it can happen. Not very common, but yes. But in this scenario, HELP is fitting the most. हेपेटाइटिस में AST/ALT इज़ 1000. रिमेंबर, आपको कोई भी कंडीशन दी हो, अगर AST/ALT 1000 है, सीरम बिल डज नॉट नीड टू बी हाई. इफ AST/ALT इज़ हाई, इट इज़ हेपेटाइटिस. एक्यूट फैटी लिवर 25 वीक्स पे नहीं होता, वो अराउंड 34 to 38 वीक्स पे होता है. इट इज़ लेट. Patient will typically have hypoglycemia. She will not have upper quadrant pain and all. She will have shock. She will be in shock. She will be fainted. That is how it presents. Obstetric cholestasis में main thing the question will always give is itching. That is the main important thing. Patient will always have itching. AST/ALT is around 80 to 90 only, but itching बहुत होती है palms and soles में. That is obstetric cholestasis. So here the answer is HELP syndrome. ठीक है? So eclampsia क्या है? It is also a terminal stage of preeclampsia, means hypertension with convulsions. There are some premonitory symptoms. Premonitory symptoms means eclampsia हो क्यों रहा है? Because of lot of neurotransmitters are being released. So before convulsions start, there are certain indications which are telling you कि भाई control this patient, she will have convulsions. These are called premonitory symptoms. जैसे headache, disturbance in vision, photophobia, confusion. They all are premonitory symptoms. Means symptoms just before convulsions. इन्हें हम premonitory symptoms कहते हैं. Eclampsia को कैसे मैनेज करना है? We have read मैक्सेल्फ, एंटी हाइपरटेंसिव डिलीवरी, सारे के सारे इमरजेंसी कंडीशंस का यही मैनेजमेंट है. हेल्प को कैसे मैनेज करना है? मैक्सेल्फ, एंटी हाइपरटेंसिव डिलीवरी. ठीक है? गॉट इट? सो दिस वी हैव फिनिश्ड hypertension and diabetes. Now we will enter into complicated pregnancy. Okay? So should we take just a 10 minutes break and then we'll meet again? Will that be okay? So just 10 minutes break and we will meet. Have some water, go and freshen yourself, then we'll meet in 10 minutes. Bye. Hi everyone, I'm back. Please let me know if I'm audible and I'm visible. Can someone who's there can let me know that if I'm audible and I'm visible? I am chopped. Okay. So let's start with complicated pregnancy. Okay. So we have discussed two medical disorders. We have not discussed the RH pregnancy. RH negative pe as such many times questions have not been asked. It was asked in the last year. The dose of RH pregnancy, RH negative pregnancy. So anti-D dose. Just remember the anti-D dose. See, there are basically anti-D क्यों देते हैं? So when I'm talking about an RH negative pregnant woman, there is a lady who has never been exposed to RH positive blood group. Never exposed. So here when she becomes pregnant, now in her body she has an RH positive baby. If she will be exposed to this blood, she will produce so many antibodies that will go and in fact kill the RBC of the baby only, leading to fetal anemia. So I will give anti-D in her so that is anti-D ka what is the role? कि that small amount of blood that will be leaked from this baby to this mother, ये जो anti-D है ना, this will just kill these RBCs. This is the function of this anti-D. So I am giving it for prevention. In a woman who has never been exposed to this RH positive blood, I am giving it for prevention. When will I give? I will give it any sensitizing event. Sensitizing event means those events which can lead to the leakage of baby blood into the maternal blood. That is sensitizing event. जैसे कि abortion, the leakage of blood can happen. Ectopic pregnancy, or I am doing same thing. I am doing chorionic villus sampling, or I am doing amniocentesis. They all are sensitizing events. Second dose I have to give at 28 weeks, irrespective of any event. It is said that after 28 weeks, fetal blood is leaked into mother. You do something or you don't do something, it is leaked. So at 28 weeks, every woman is given anti-D. Okay? Every woman means she has to be antibody negative. A woman who has already formed antibody, if she has antibody in her body already, why will you give prevention? What are you preventing it from? Already antibody to hai. You cannot prevent it from anything, right? So at 28 weeks also I'll give it if there are no antibodies, and I will give it at delivery. Delivery is the biggest sensitizing event. सबसे ज़्यादा blood leak happen in delivery. But you can say कि मैम why will I give in delivery? भी baby तो बाहर आ गया, अब baby will not be affected. When I'm giving anti-D at delivery, I'm trying to protect her for the next pregnancy. Because अगर उसने antibody here, if she has made the antibody after delivery, the next pregnancy में the baby will have anemia. So here I'm trying to protect the next baby. So what will be the anti-D dose? FOGSI यानी कि Federation of Obs and Gynae Society ने 2022 में recent guidelines दिए हैं for anti-D dose. They have said any event at less than 20 weeks, any event, 150 mcg is the dose. पहले क्या होता था डोजेज? पहले होता था डोजेज if it is less than 12 weeks, we used to give 50 mcg. They said forget it. दो ही वायल्स अवेलेबल हैं, 300 mcg and 150 mcg. So any event happening after 20 weeks, I will give 300 mcg. Any event happening before 20 weeks, I will give 150 mcg. So what will be the dose given at 28 weeks here without sensitizing event? I will give 300. What will be the dose given after delivery? Within 72 hours of delivery देते हैं 300 mcg. What will be the dose for chorionic villus sampling? Chorionic villus sampling कब कर रहे थे हम? First trimester में. What will be the dose? 150 mcg. Amniocentesis when were we doing? 15 to 20 weeks के बीच में. So again 150 mcg. ठीक है? So this was the question which was asked last year. Okay, chalo. Now start with a very commonly asked topic. Now I don't know, FMG people are very obsessed with antepartum hemorrhage. They always ask question on antepartum hemorrhage in every exam. तो उसको we will read in little detail. ठीक है. So a woman comes at 32 weeks with severe pain, bleeding, loss of fetal movement. Uterus is tender. It is directly indicating you the diagnosis. Whenever there is pain with bleeding, it is never previa. Previa is always painless bleeding. Polyhydramnios means excess liquor. Why will the patient bleed? Preterm labor में why will she bleed? She will bleed. Bleed means bleed. So preterm labor में you can say मैम labor में show तो होता है ना. So show में examiner will not like bleed. यार examiner is not foolish. वो bleeding थोड़ी लिखेगा. वो लिखेगा spotting और blood mixed with mucus. Bleeding पर वजाइना में loss of fetal movement हो गया है. So and severe pain है. Uterus भी tender है. So it is abruption. Okay. So antepartum hemorrhage can be due to majority of time 2 reasons: placenta previa and abruption. What is more common? Placenta previa is more common or abruption is more common? Abruption is more common. So let's discuss one by one. Placenta previa का क्या मतलब है? Placenta lying in the lower uterine segment. So there are 2 classification. This is the recent classification. पहले जो था Brown's classification category 1, 2, 3, 4, this was little confusing. But questions are still asked on this, so we will discuss. अभी कैसे classify करते हैं? True placenta previa means placenta up till os. Yes, Dr. Tawfiq, good. Abruption is more common. So true placenta previa means placenta is covering the os. Right? So whether the uterus, cervix is dilated, not dilated, doesn't matter. If it is covering the os, it is true placenta previa. It is not covering the os, but it is lying within 2 centimeter of os. It is low lying. These are the 2 terms. Browns used to classify in 4 categories. Low lying means in the lower uterine segment within 2 centimeter. Marginal means reaching up till the os, somewhere up till the os, but not covering. Incomplete means covering the os, but a closed os. जैसे ही os dilate हुआ, placenta has shifted back. So it is incomplete. Complete means even when the os is dilated, placenta is covering. The common question that can be asked: what is the dangerous placenta? Second placenta has 2 types: 2A and 2B. 2A मतलब anterior, 2B मतलब posterior. Why are we classifying it like that? Because when this is uterus and this is suppose ऐसे, when the placenta is low lying and in the posterior wall, what will happen? When the baby will try to come out, the head of the baby will always, because remember sacrum is also, L of sacrum is also like that, and here also placenta is there. So first of all, AP diameter कम हो गया, there will be problem in delivery. Whenever the head will come out, it will always compress the placenta, leading to hypoxia. So placenta 2B is considered a dangerous placenta. As such, you are thinking it is low lying. You are thinking that baby might deliver, but baby will not. Every time baby will come out, it will cause hypoxia. Which of these can be delivered normally? So category 1 and 2A, you can try for vaginal delivery. Try for. But category 2B, 3, 4, straight away LSCS. At term, straight away LSCS. ठीक है? Symptoms. What the question will give you? Listen very carefully. So question will give me vaginal bleeding, sudden होगी, painless, recurrent and causeless. There is no cause. ठीक है? It is not associated with pain unless the labor starts. Unless the labor starts, there will no pain. ठीक है? Signs क्या होंगे? Uterine height will correspond to gestational age. Yes. Why I am giving this point? Because many times question will give you that the uterine height is more than gestation. That will be in abruption. Abruption में क्या होता है? The blood keeps on collecting behind the placenta. As a result, uterine height increase. ठीक है? Malpresentation क्यों होगा? Head floating क्यों होगा? Because lower segment में placenta is there. So head will be floating or it will be malpresentation. ठीक है? Stalwardy sign क्या होता है? When the labor is happening again, placenta is getting compressed, fetal heart rate is dropping. That is Stalwardy sign. So these are the signs that are there. Now what is the question that has been asked? First, so first diagnosis of placenta previa कब बनती है? At what gestation? Sonologist will tell you that she is placenta previa. At 20 weeks. So 12 weeks पे वो नहीं बोलेगा placenta previa. 12 weeks पे placenta is very ill formed. At second level 2 scan, remember we are doing a level 2 scan for fetal anomalies. When it shows low lying placenta, the radiologist will tell you it is a placenta previa patient. ठीक है? Then when will you repeat? This is the last year PYQ. Last year पूछा गया था. When will you reassess? I will reassess at 32 weeks. But why am I reassessing? Placenta previa diagnosis has been made. Why will I reassess? Because placenta has a tendency to shift upwards as the uterus becomes enlarged. 20 weeks पे umbilicus तक uterus है. It is low lying, but the uterus will enlarge. It will result in shifting of the placenta upwards. Because of that, many times the person you called placenta previa, at 32 weeks you will see that it is not even placenta previa, it is up. So I will reassess this patient at 32. Remember this term because when the question was asked, the options were very close by, 32, 34, 36. So 32 pe I will reassess. Here also if she is placenta previa, chances of shifting up are very less now. I will reassess this patient at 36, and now here also if it is placenta, now it will not shift. I will plan the mode of delivery at 36. So how am I reassessing? 20 weeks per diagnosis bana, reassesses 32 and then at 36. This is what about placenta previa. Delivery at 38. Mode of delivery we have discussed. Category 1 and 2A, try for vaginal. Category 2B, 3, 4, cesarean. At what time? 38 weeks. Okay? Till then, suppose if the bleeding has stopped, pelvic rest is the term. Pelvic rest means it is not bed rest. Pelvic rest means avoid sexual intercourse, avoid lifting heavy weight, avoid squatting position. That is pelvic rest. Okay? Now, this is the question. Identify the condition. Can you see this pink colored placenta in the babies here? What is it? Vasa previa, placenta accreta, abruption. Placenta previa. And placenta is low lying. Identify the placenta. This, can you see this placenta? It is what? It is low lying, incomplete, complete. Can you see it is reaching up till the os? It is not covering the os. It is reaching up till the os. It is marginal. Okay. So these are the questions that have been asked on placenta previa. Okay. Now the other common cause, that is, Dr. Tawfiq, you have asked a question. Level 2 scan, ideal time for diagnosis of the placenta previa. Then that's when you diagnose the placenta previa. 18 to 20 weeks or 18. What is this 18 to 20 weeks? In what respect you are asking? Can you just let me know this? So abruption. What is abruption? A normally situated placenta has separated before a time. So it can be concealed, it can be revealed. External hemorrhage means the bleeding is coming out. It is less dangerous. More dangerous is concealed. Bleeding is not coming out. Uterus will keep on increasing in size. So first of all, the diagnosis will be late. And since the blood is getting collected behind placenta, it will slowly separate the rest placenta also. Also, there will be more chances of DIC. DIC का सबसे common cause क्या होता है in pregnancy? Abruption. क्यों होता है? Because the thromboplastin in maternal blood, this is maternal blood. ये abruption का जो blood है, ये maternal blood है. Spiral vessels जो पढ़े थे हमने, we write spiral arterioles, they rupture and bleed to this blood. So thromboplastin goes into the maternal blood leading to DIC. When it is concealed, the pressure is so high that a lot of thromboplastin is pushed into the maternal blood system. As a result, the chances of DIC are more. ठीक है? So how the question will give you scenario now? It is sudden vaginal bleeding with pain and uterine tenderness. Tenderness means when you are touching, it is painful. It is uterine tenderness with pain is abruption. Back pain भी होगा. 60% of time fetal heart rate is abnormal. So question will give you majority of time that fetal heart rate is abnormal. They can give you even that it is not, but 60% of time FHR is abnormal in abruption. ठीक है? What is the risk factor? Why the placenta will prematurely get separated from its place? Increasing age and parity, smoking, or cocaine also, recreational drugs. So Dr. Tawfiq has asked what is the ideal time for checking anomalies. It is the 18 to 20 week scan, right? Not 18 to 24. It is 18 to 20 week scan. Okay. Smoking, hypertension. Abruption is very common in hypertensive patients. Twin and prom. They are the risk factors for abruption. It is the most common cause of consumptive coagulopathy, leading to DIC. And risk is more when it is concealed. That we have discussed. How will you manage this patient? This patient has bled already. बाहर से आपको दिखा कि bleeding थी, but now it has stopped. will you send her home? She can bleed again. Uski placenta has started to separate, it will separate more. First of all, if the bleeding was less and the fetal heart is normal, you will admit every patient. You will admit her till 37 weeks. Abruption patient को आप 37 weeks तक admit करोगे, she can again bleed and the fetal heart will drop. You will not even know. So you will admit till 37 weeks. And then you will deliver by, you will try for vaginal always. Why? Because there is risk of consumptive coagulopathy, DIC. So I will always try delivering her vagina. Now if suppose patient comes to me, she is bleeding and she has abruption, I cannot put her in conservative treatment, I have to deliver. Okay, she is bleeding, I have to deliver. What will be my mode of delivery? Vaginal. In abruption, you remember that vaginal delivery with minimal manipulation is the term which is written in book. Okay, do not apply instrument, try avoiding episiotomy. Because abruption hai, she can be in DIC. You will be able to deliver the baby. She will bleed so much from episiotomy, you will not be able to control. So with minimal intervention, vaginal delivery is the treatment of choice. Unless, अब ये patient अगर hypotensive, if the question gives scenario, patient is in shock, the fetal heart rate is severely deteriorating, obviously you cannot go for vaginal therapy. Then the obvious answer is LSCS. Whenever the mother is very unwell, baby is very unwell, in any condition, answer is LSCS. But if as such abruption है, bleeding है, but the fetal heart is normal, mother is not in shock, always go for vaginal. ठीक है? This much is clear? So, एक G2 para 1 patient है with abdominal pain, bleeding per vaginum. Okay, abdominal pain and bleeding. Loss of fetal movement. Okay, she occasionally smokes. So, हमारे पास we have 2-3 things. On examination, BP is also high. Abdomen is tense. So, this is to leading us on to the answer. What is it? Abruptio. Right? So, hypertensive patient present with abdominal pain and bleeding, loss of fetal movement. What is the most probable diagnosis? Abruption. So, you can see how many times by changing the scenario they ask the questions. The same question. What is the most common cause of consumptive coagulopathy? Abruption. Remember, they all are the causes of consumptive coagulopathy. They all can cause DIC. All of them. But the most common cause is abruption. That is why you are always trying to have vaginal delivery. Okay? So this is about, so this is about abruption. Now APH may we have read previa, jitna we need to know, we have got to know. And about abruption, one thing is left is placenta accreta spectrum. What is placenta accreta? When the placenta has to attach on the decidua. Decidua kya hai? Endometrium. When instead of attaching to decidua, it goes and attaches to the myometrium, invades the myometrium, goes outside uterus. It is accreta, increta, percreta, and together called as PAS, placenta accreta spectrum. Why it is? What are the risk factors if the patient has placenta previa? So whenever the placenta is implanted on lower segment, chances are there that it might reach up to the myometrium, especially if it is a scarred area. Caesarean. Caesarean is done at what site? Lower uterine caesarean कहते हैं ना, lower segment caesarean section, because we put the scar in the lower segment. So when the scar is there on the lower segment, either due to multiple DNC or due to the caesarean, the chances of accreta spectrum is high. ठीक है? And okay, so just give me a second. I think on this, no, I have. Yeah. So we have discussed the risk factors. इसके अलावा the question has been asked that there is absence of what? Why it is going up to the myometrium? Because generally between the placenta and endometrium there is a layer of fibrinoid degeneration which stops the invasion. ये fibrinoid degeneration की layer, it stops the excessive invasion of placenta. This is Nitabush layer. So when the Nitabush layer is absent, the placenta accreta can happen. ठीक है? So many, if it has been diagnosed after delivery, suppose आपने deliver कर दिया, they tell you that placenta is very much athired, it is not coming out. Then what will you do? Placenta is not being delivered. Will you try pulling it? No, it will never come out. The answer is hysterectomy, always. Whether you diagnose it antenatally or you diagnose it after delivery, your answer is always hysterectomy. You cannot remove this placenta. You have to remove the uterus with placenta still attached. When will you terminate this pregnancy? At 37 weeks. I will terminate this pregnancy at 37 weeks. Okay? So this much about the placenta accreta spectrum is enough. Now comes multiple pregnancy. What is the question that has been asked in multiple pregnancy last year? If the division in zygote occurs between 9 to 12 days, which of the following twin is expected? In 9 to 12 days. So days have been enough. वो मतलब it is a long days. After so many days they are being separated. We will have monochorionic, monoamniotic. How to remember? See, देखो, जब dizygotic pregnancy है, means there are two zygotes and there are two zygotes formed because two sperms have fertilized two ovum. Then there is no problem. Dizygotic will always be diamniotic, dichorionic. They will have different sac, they will have different placenta. Problem कब है? When it is monozygotic. The zygote was one, eventually it got separated into two. Then how will we know कि भी वो monoamniotic है, diamniotic है? How will we know? See, when two people are living together for a longer time, if you will separate it after long time, it is difficult to separate them. Earlier you separate them, easier it is. So in these two zygotes, if they are separated in the early gestation, then they will be, you can separate them very easily. So suppose this cleavage happened in day 1, 2, 3. Day 1, 2, 3 means as soon as they came into power, you separated them. Not you, they were separated. So they will just totally be separate. They will stay in different house and different room. So remember the house here, house is the placenta. It means chorion. And the rooms are, okay, I think this is not working. So house is chorion and the rooms are amnion. So if they have separated early in gestation, they will stay in different house in different room. Diamniotic, dichorionic. Suppose they are separated after 3 days, 4 to 8 days. So now it is difficult to separate them. So what the fetus do? They say कि भाई we will stay in separate room, but we want same house. So we will stay in the same house since we have become close friends. We will stay in different room. It means diamniotic but monochorionic. Between day 4 to day 8, diamniotic, monochorionic. Agar if the separation happens after day 8, now they are inseparable. They said we will stay in the same house in the same room. Monoamniotic, monochorionic. Same house, same room. After 13 days, now they are joint. Now you cannot separate them. It is conjoint. That is how you can remember. ठीक है? Easy? Right? So basically, what is dichorionic, diamniotic? How can you diagnose it? You can diagnose it on ultrasound. Best time of diagnosing this chorionicity is 11 to 14. When you are doing that, remember first week scan, level 1 scan. My pen is not working. I'm so sorry. So at this gestation, you can diagnose कि वो diamniotic, dichorionic है या फिर monochorionic है. So chorionicity you can do by ultrasound. So if you can see these two separate layers, can you see this thick membrane here? It is twin peak sign. It is showing कि भाई though there are two placentas, it is dichorionic. But if it is such a thin layer, it is monochorionic. Okay, amniosity you cannot tell, but you can tell chorionicity. Placenta you can tell. So this is dichorionic and twin peak sign, T sign is monochorionic. Best time is 11 to 14 weeks. To diagnose dichorionicity, yes, lambda sign, correct. So lambda sign is the another name for twin peak sign, Dr. Nandini, right? And T sign is for monochorionic. Best time to diagnose is 11 to 14 weeks. Is it important to diagnose it this way? Yes. When they are sharing their placenta, when they are monochorionic, the complications are more. When they are staying together, they tend to share the vessels. So the complications are more. So at early gestation, if you can diagnose, you can monitor it well. So what are the complications? Complications that can happen in any twin. Monoamniotic, dichorionic, dizygotic, any twin. That is happening because they are sharing the nutrition. So what can happen? IUGR, discordant twin, one twin will grow more, one twin will grow less. Interlocking, they can have interlocking, difficulty in labor. And as such, chromosomal anomalies are also more in twins. But specific to monochorionic, Why are you so worried कि भाई monochorionic and dichorionic? Because there are some complications which can even lead to twin death in monochorionic. That is twin to twin transfusion. One twin gives whole of the blood to another twin. One is polyhydramnios receiving the blood, one is oligohydramnios. And you know who will die? The one who is giving the blood or one who is receiving the blood? Which twin has a higher chances of dying? This. The one who is receiving the blood, he will have so much blood that lead to cardiac failure. So twin to twin transfusion, right, you have to know. इसका थोड़ा सा milder form is twin anemia polycythemia sickness. Means blood is being transfused but it will just leading to anemia in one and polycythemia in another. ठीक है? So as soon as I did a 11 to 14 week scan and I saw my pen is stopped working, I don't know, and I saw कि भी monochorionic है. How will I monitor? I will do ultrasound every 2 weeks from 16 weeks. So see how many ultrasound this lady will need. 16 week, 18 week, 20 week, 22 week, every 2 weeks I am doing ultrasound. Because to rule out twin to twin transfusion. Because if I'll see कि twin to twin transfusion हो रहा है, either have to deliver early or I have to ligate the vessels. So I will do this. ठीक है? Other question that can be asked is when to deliver the twins. DCDA, ये तो theoretical है, you have to remember. DCDA is a simple twin. It is like just two different babies in a uterus. Deliver at 39, no problem. Now these readings are different from Datta. Datta में gestation which are given, that are the older gestations. So monochorionic diamniotic 38 पे deliver करते हैं, monochorionic monoamniotic को 32-34 पे deliver करते हैं और triplet को 35 पे deliver करते हैं. ठीक है? What is the mode of delivery? If both are kyphlic, vaginal delivery. If first is kyphlic, second is breech, transverse, doesn't matter. First is kyphlic, vaginal delivery. If first वाला matter करता है हमेशा. The first twin means the one which is close to cervix. That is your first twin. First twin non-kyphlic है. तो it doesn't matter second twin क्या है, कोई फर्क नहीं पड़ता. First twin non-kyphlic, cesarean. So this is the mode of delivery, and this is the timing of delivery. ठीक है? चलो next question. So this was all about twin, you have to remember. Next is an 18-week gestation complaints of draining PV for past, okay, complaints of parvaginum fluid draining from 4 hours. On examination membranes are ruptured, uterine contractions भी हैं. So it looks like she's in preterm. Transvaginal ultrasound shows short cervix and funneling. So what is the diagnosis? So funneling हो गई है and membranes are ruptured at second trimester. So what is the diagnosis? Cervical incompetence. It cannot be placenta previa. There is no bleeding. Abruptio, no bleeding. Traumatic injury, no. It is cervical incompetence. So if we just give me a second, I just need to correct this spine. I don't know why it is not working. So preterm labor can be of two types. So there are two types of ladies in preterm labor. One lady is diagnosed case. She is in preterm labor. Another lady comes to you. She is not in preterm. उसको कोई contractions नहीं है. उसका uterus is not, cervix is not open. She is at risk of preterm. And how do you know she is at risk? By her history. So the management is different. A one who is in preterm, जैसे अभी question में था, in the last question, who is in diagnosed preterm means she has either contractions or cervix is open more than 4 centimeter, or contractions है, cervix closed है, then also she can be in preterm. How will you know? If a patient comes to me at 28 weeks, she tells uterus, I am having lot of pain, cervix is closed. Will I not investigate her further कि preterm तो नहीं है? How will I investigate? By doing ultrasound. So ultrasound में cervix is small और fetal fibronectin is high. Any two of these show me कि भाई she is in established preterm. So a patient who is in established preterm, जिसको contractions आ रहे हैं, who has contractions, उसके treatment में there are 3 prongs treatment. Tocolytics दो उसको. The choice of tocolytics is nifedipine. जो क्वेश्चन आया था राइटोड्रीन पे, राइटोड्रीन इज अ बीटा 2 एगोनिस्ट दैट इज नाउ नॉट एट ऑल यूज्ड इन प्रीटर्म लेबर मैनेजमेंट. सो बुक से टोकोलिटिक्स में आइदर गिव निफिटिपिन और ऑक्सीटोसिन एंटागोनिस्ट. डोंट गिव राइटोड्रीन बिकॉज ऑफ लॉट ऑफ साइड इफेक्ट्स. स्टेरॉइड्स देना है, प्रीटर्म है ना, सो एट लेस देन 34 वीक्स वी विल गिव हर स्टेरॉइड्स एंड वी विल गिव हर मैक्स सेल्फ एट लेस देन 30 वीक्स. So steroid and Maxelf and tocolytics will be her treatment. Cerclage will not be given in her. She is in preterm. उसको contractions आ रहे हैं. She is in pain. If you will tie cerclage in this, it will rupture. So her treatment will be this: tocolytics, steroids and Maxelf. ठीक है. एक patient है वो she comes at 12 weeks. She is not in pain, but she is giving me some history. Now she is at risk patient. इसका treatment different होगा. So preterm labor का क्या treatment पढ़ा हमने? Tocolytics, in which the choice is nifedipine. Second choice is oxytocin antagonist. इसके अलावा steroids at less than 34 weeks. इसके अलावा Maxelf at less than 30 weeks. And now a lady comes, she is not in preterm. She gives me a history of cervical trauma. Sorry. She gives me a history of cervical trauma or preterm rupture of membrane. Like in question, sorry. So like in question, she has preterm rupture of membrane or cervical trauma. And on ultrasound, cervix is short. So she is at risk. अभी वो preterm में नहीं है. She has no contraction. What will I do? Cerclage. Here the answer will be cerclage. Similarly, I have got a history of previous preterm or previous one mid-trimester loss. Cervix is short. So here also I will give cerclage. Exactly, दूसरी history, a patient is giving me history of 3 previous preterms. 3. If she has history of 3 previous preterms, I don't need ultrasound. मुझे ultrasound की ज़रूरत ही नहीं है. This history is so significant. She has lost 3 babies to preterm birth. I will straight away give cerclage. In above 2, when there was just one history of preterm loss, just history of cervical trauma, I was doing cervix length. But in this patient, I am not doing cervical length. She has more than 3 preterm loss. I am not doing cervical length. I am straight away doing cerclage. Okay, so this is the treatment for a woman at risk. And woman who is in preterm, the treatment was tocolytics, steroid and Maxelf. I hope this is clear. Similarly, what is the treatment for preterm rupture of membrane? Preterm rupture of membrane patient is at risk of infections. So you will induce her, but after 37 weeks. Remember, preterm rupture of membrane, you try to pull her till 37. पहले ये term 34 थी. So now the guidelines is 37 weeks. So meanwhile, membranes rupture हो गई हैं. She is exposed to outer infection. What will you do? You will give her antibiotics, erythromycin. ठीक है? You will give the steroids for fetal lung maturation. You will give her Maxelf. Will you give tocolytics in this patient? जिसकी membranes rupture हो चुके हैं? No. If she has to go in labor, she will go in labor. You will not stop her. So if the membranes have ruptured, I will not give tocolytics. I will just give antibiotics. I will just give steroids. And I will monitor her for infection using CRP and WBC. Till what gestation I will monitor her? I will monitor her till 37 weeks. So ये जो, please pardon my marks, my pen is, I don't know why it's not working. So till 37 weeks, I'm gonna monitor her. And till then I'll give her antibiotics and I'll give her steroids. Is this clear to everyone? So this was the question. Rytodin, which prevents preterm labor. Basically, Rytodin is not used at all. Causes all the following complications except tremors, tachycardia, hypoglycemia, pulmonary edema. What will it cause? Tremors is the most common complication of Rytodin. So what will it not cause? Hypoglycemia or pulmonary edema? Hypoglycemia. Beta 2 agonist क्या करते हैं? Hyperglycemia करते हैं, right? So that is the answer. ठीक है? चलो. I don't know what has happened to my pen. A 34-year-old woman has history of past cesarean section and dilatation. Presents to emergency with hypotension, tachycardia, severe pain. Okay, now she has severe pain, but इन्होंने bleeding नहीं लिखी है. Hypotension and tachycardia. Fetal parts are palpable. Only condition when fetal parts are palpable in abdomen means the fetus has come into the abdomen. Any condition, be it placenta previa, be it abruption. So Dr. Nandini has asked a question. Sorry, let me take it. Dr. Nandini has asked that cerclage is only recommended for multiple history of rupture. No, no, bache. Cerclage is recommended for 3 or more than 3 preterm or mid-trimester loss. If it is 1, then also you give cerclage, but you need additional finding that cervix is short. In this pregnancy, she has come to me at 11 weeks. She gives me history कि मेरे को पहले एक preterm birth हुआ है या पहले 1 mid-trimester abortion हुआ है. I'll do ultrasound. If cervix is short, then I'll give cerclage. She gives me history कि मुझे 3 premature rupture membranes हुआ है. Previous 3 mid-trimester abortion हुआ है. I will not do cervical length. I'll straight away give cerclage. So these are 2 conditions. Okay? So if the fetal parts are palpable in abdomen, the only conditions when they are palpable in abdomen is when the fetus is in the abdomen. It means the uterus has ruptured. Have they given us some risk factor? They have. They have given us it's cesarean section, dilatation and curettage. Her uterus is already weak. So it is uterine rupture. Oligohydramnios is associated with which of the following? We have read already the oligohydramnios and polyhydramnios. I told you what is the most common cause of oligohydramnios. The most common cause I told you was, what was the most common cause of oligohydramnios? Which I told you. Yes, it was rupture of membrane. My pen is not working, I don't know what. Let it be. So preterm rupture of membrane is the most common cause of oligohydramnios, right? इसके अलावा IUGR, placenta is not working, by baby is not getting blood, how will baby produce urine? जैसे हमें भी, if we are not getting water from outside, we will not produce enough urine. We will be dehydrated. Same, baby is not getting blood, how will baby produce urine? So oligohydramnios का another cause is placental insufficiency. And all the, Dr. Tawfiq, very good. So, and all the renal anomalies. I told you all the renal anomalies. Urine is the source of liquor. So, all renal anomalies produce oligohydramnios. All GIT anomalies, क्या दिए हैं इसमें? Esophageal atresia will cause polyhydramnios because baby को absorb करना था. Baby was supposed to swallow the amniotic fluid. Now esophageal atresia हो गया. ठीक है? So, it will not swallow. The fluid will be too much. So, what will be the answer here? Renal agenesis. Neural tube defects. Whenever the membranes are exposed outside, they will leak fluid. It will lead to polyhydramnios. ठीक है? Okay. So we have read about we have already read about amniotic fluid, right? Okay. So we have covered the complicated labors. We have covered APH, twins. We have covered RH negative, preterm labor, and medical में diabetes and hypertension. Now we come to labor. It is almost the last topics which we are covering now. Soon we will finish the obstetrics. Then we will have a short lunch break and then we will start gynecology. ठीक है? Identify the pelvis. Can you see the inlet? So beautiful, circular. Whenever anything is beautiful and circular, it is gynecoid. It is female, right? So जो pelvis की shapes हैं, that is based on the inlet only. Inlet की shape कैसे है? उसके base पे there are different 4 categories. So when you see this beautiful rounded shape inlet, then it is gynecoid pelvis. Okay. So maternal pelvis को let's discuss a little bit. It is like a container. It has an inlet, it has a cavity, it has an outlet. ठीक है? So inlet is more of a circular shape. But if asked what is the largest diameter, it is not exactly circular. It is more in the transverse diameter, right? So transverse diameter is maximum, which is 13 centimeter, then oblique is 12, and then the AP diameter is 11. ठीक है? Can you अभी यार सबसे important है inlet. If the inlet is small, baby will never enter the pelvis. Eventually baby एक बार inlet में enter हो गया, cavity को it can traverse, but inlet में enter होना is important. So can you measure if somebody can tell me what is the AP diameter? AP diameter smallest है. So सबसे important that diameter is for me. Be vertical, transverse diameter is as such also is huge. Can I measure the AP diameter of inlet? It is from upper border of pubic symphysis to sacral promontory. I cannot. What diameter I can measure of inlet? Diagonal conjugate. It is from lower border to the sacral promontory. I can measure from sacral promontory to lower border using my hand. And in this diagonal conjugate, my pen is just not writing. I am so sorry. So just listen. So if I subtract 1.5 to 2 centimeter from diagonal conjugate, what I get is obstetric conjugate, which is the diameter of my inlet. This. This is my obstetric conjugate. How am I getting? Diagonal conjugate minus 1.5 to 2 centimeter. Very important question. So which is the only diameter that can be measured in inlet? Diagonal conjugate. Okay? So this was the inlet, circular, a little wider in the transverse diameter but more of a circular. What about the cavity? Cavity एकदम change हो जाती है. You remember when you learn the steps of labor, क्या होता है? Descent, flexion and then internal rotation. Rotation क्यों होता है cavity में? Because the diameter change. अभी तक the vertical diameter was largest. As the baby enters the cavity, now the AP diameter is the longest, this one. So baby has no option, baby has to rotate. So that is why internal rotation is happening. Ki suddenly baby has come from this diameter to this diameter. That is why as soon as the cavity comes, जहाँ पे levator NI है, that is the cavity. It comes flexion and internal rotation to bring the head into the largest diameter. Cavity का largest diameter होता है AP, antero-posterior. What about outlet? So outlet is diamond shape, transverse and AP diameter both are more or less equal. ठीक है? So variation in pelvis को classify किया है Caldwell-Molloy classification से. It is variations in the basically shape of inlet. एक बार inlet traverse हो गया, then we can think of a head. So once the inlet is not even crossed, the steps of labor doesn't matter, right? So when we are talking about gynecoid pelvis, it's a female pelvis where the inlet is circular and everything else is good. Ischial spine, can you see they are not prominent? Sacrosciatic notch, can you see how wide it is? They are not deep. This is deep. Arey yaar, I cannot. So this is deep. So they are wide. They are not deep. Ischial spine are not prominent. This is gynecoid pelvis. Okay, pubic rami are also short and they are wide. But another pelvis is anthropoid pelvis, ape-like pelvis, where the inlet is oval. ये oval हो गया. Instead of being like this, it is oval now. So there is tendency that head, instead of going into occipito-transverse, most common presentation क्या होती है? What is the most common presentation of head? Occipito-transverse. But in an anthropoid pelvis, there is tendency of occipito-posterior. Because it has no space to rotate. वो rotate ही नहीं कर सकता. AP diameter सबसे लंबा है. AP diameter is longest of the inlet. So as a result, what will happen? It will be occipito-posterior. ठीक है? And see, in the female pelvis, it was just so much space. Below the pubic rami, space was so much. It is shallow. It is not spacious. The pubic rami are long. ठीक है ना? Then comes android pelvis. Android pelvis has anterior beaking. It is heart shaped. Anterior beaking है. So again, that rotation step that had to happen, that will not happen. The most common pelvis which will have occipito-posterior position is anthropoid, not android. Second most common pelvis with occipito-posterior is android. And why it is happening? क्योंकि वो जो labor का step था, internal rotation, to bring the occiput anteriorly, that is not happening. There is no space for rotation. So this heart-shaped is android pelvis. So see, ischial spine are so prominent, sacrosciatic notch are so deep. This is also so deep. So nothing is good. Delivery can happen, but it is occipito-posterior position. And the platyploid is a flat pelvis, a very rarely found pelvis. Okay? Now the question. A radiological assessment of pregnant women reveals AP diameter oval. So we just discussed. According to Caldwell-Molloy classification, what is this pelvis? When the AP diameter is oval, what was it? Anthropoid. What will be the, again, a baby comes in, enters the pelvis in direct occipito-posterior. Occipito-transverse is the most common, but it is entering in occipito-posterior and it is in the occipito-posterior in cavity also. What is the pelvis? It is anthropoid. That is why it is in occipito-posterior. It is not able to rotate. Okay? So this was about the pelvis. Now the questions which can be asked, I think these are important, is Leopold exam maneuvers. I don't have the question for that. I have only 4-year questions, but they can be asked anytime. So abdominal examination mein Leopold maneuvers are very important. This is the first grip where you are putting your hand on fundus. Can we call it a fundal grip? Yes. What are you trying to know in this fundal grip? I am trying to know ki fundus pe what is the part. If it is soft part, it means my head is down. It means my presentation is kyphlic. So I'm trying to know the presentation. I'm trying to know whether the baby is longitudinal or not. This is the first grip. I'll bring my hand a little down around the umbilicus. That is the lateral grip. What I'm trying to know, where is the back? Where are the limbs? Why? Because जहाँ पे back होगी, see where the back, there is the occiput. The side where the back is, that side only is the occiput. I am trying to know whether it is right occipito-posterior, right occipito-transverse or left. So here I am trying to know the position. In first grip, I was trying to know the fetal lie and presentation. Here I am trying to know the position. Means occiput right है या left है. Then this is pollic grip. Third pelvic grip is pollic grip, where I am trying to hold the lower segment and trying to see again the same thing which I was seeing in first grip. Head है या soft है. Means presentation. ठीक है? And when I'm turned towards the female pelvis, now I have turned towards the pelvis and I'm trying to see whether the head has entered the pelvis or not, then I'm talking about what? This is the fourth grip called as pelvic grip. So fourth grip is called pelvic grip because now I'm talking about pelvis, whether head has entered into pelvis or not. So these are the four Leopold grips which I feel are very important. They can be asked. Another question that can be asked is the position. What is the most common fetal position? Occipito-transverse. Can you identify this? Can you identify this? This triangle is occiput. This bregma is diamond shaped. So whenever I am seeing the triangle, that is my occiput. This is diamond shaped, that is my anterior frontal. So it is always mirror image. Okay, so this is my right side, this is actually left side of the patient. Yeah, my pen is just, I don't know why it is not working. So this is right side and this is left side. So just remember mirror images होते हैं, ठीक है? So this is what position? Left occipito-transverse. This occiput is in the left side of the patient. Left occipito-transverse is the most common position. इसके बाद which is the most common position? Occipito-anterior में. Now rotate it anti-clockwise. Anti-clockwise घुमाओ. So left occipito-transverse के बाद more common is left occipito-anterior. It is more common than right occipito-anterior. फिर से move it anti-clockwise. Occipito-posterior में which is more common? Right occipito-posterior. ROP is more common than left occipito-posterior. Okay? So what is more common? Left occipito-transverse is more common. Okay. Now another question was asked on. Okay, so Dr. Gautam, you want to know about the fetal positions? You were not able to. Okay, I'll just repeat it. Okay, just give me. Basically, my pen is not working. If it would have been working now, you would have understood easily. I don't know why. See, it is just I'm not able to write R, L, anything. So, पहली बात, you have to identify this. Remember where my triangle is. This is the fetal triangle. This is what? Occiput. तो ये मुझे समझ में आ गया that occiput is in the transverse diameter. It is not antero-posterior. It is not a diagonal. It is in transverse. Now, whether it is right or left, it is always mirror image. Patient is lying in front of you in lithotomy position. You are looking the patient from down below. नीचे से करते हैं ना PV. You do it from down below, so you are looking from the vaginal side. Patient is in front of you. So when somebody is in front of you, it is mirror image. So occiput is lying in the left side. This is the left side of the patient. So it is left occipito-transverse. ठीक है? When question give me this. So again, what is this position? I'll see, okay, this is the occiput. Now I'll see, okay, ये oblique में है, transverse में तो नहीं है. It is not in transverse. Whether it is right or left. So I will say occiput is anteriorly. See, this is pubic symphysis. You can identify this is sacrum. So it is occipito-anterior, right or left? Right occipito-anterior. It's mirror image. ठीक है? So patient is in front of you in lithotomy. Now the question has been asked, what is the other name for outlet forceps? A lot of questions have been asked on the forceps. So whatever I'm telling you in labor and everything, ये 4 साल के questions हैं. We can read a lot of things about all this. But the thing is, we have to read what is important. Exam is just coming by, we cannot read everything. So we will read only what is important. So when we come to forceps, so outlet forceps का दूसरा नाम क्या होता है? Pipers, Wrigley's, Das, Keel and forceps. It is Wrigley's. ठीक है? पहली बात इंस्ट्रूमेंटल डिलीवरी के व्हाट आर द इंडिकेशंस? व्हाई विल यू अप्लाई इंस्ट्रूमेंट व्हेन यू वांट टू कट शॉर्ट द सेकंड स्टेज? फर्स्ट स्टेज नहीं, सेकंड स्टेज. सेकंड स्टेज क्या होती है? फुल डायलेटेशन टू डिलीवरी इज सेकंड स्टेज. यू कैन अप्लाई इंस्ट्रूमेंट ओनली व्हेन शी इज फुल डायलेटेड. उससे पहले you cannot apply instrument. So when the first stage is crossed, now the cervix is fully dilated, but the delivery is not happening. This is what stage? Second stage. So what I am trying to cut? Second stage of labor. Why will I do it? Either it is prolonged. Now tell me the definition of prolonged second stage of labor. What is the definition of prolonged second stage of labor? When will you call it prolonged? In a primary and in multi. So पहले primary में बताओ. When will you call it prolonged in a primary patient? Type it. Anyone? When do we call it prolonged second stage in a primary patient? I'm waiting for the answer. Why am I not getting answer? Because so when do we call it prolonged second stage of labor? It is the 2 hours limit. I cannot write. So when it is more than 2 hours in primary, more than 3 hours in multi, I call it second stage. If epidural is being used, I will add 1 additional hour. Right? So more than 3 hours if the epidural is being used. If epidural is not being used, more than 2 hours in primary, more than 3 hours in multi. That is the... So somebody has replied 3 to 4 hours. What is 3 to 4 hours? There has to be a limit. There is nothing like 3 to 4 hours. Either it is 3 or it is 4. Right? So it is 2 hours in primary and 3 hours in multi. ठीक है? Right? So that is the prolonged second stage. As soon as it is prolonged, you have to know the duration. Because as soon as it is prolonged, you have to apply the instrument. Right? Or cervix fully dilated, baby is about to come, but the fetal compromise is there. So will you take her for cesarean or you will just apply instrument and deliver? You will apply instrument. That is another indication. Or you deliberately want to cut short the second stage. जैसे कि heart disease or hypertensive crisis, cerebrovascular disease, many retinopathy, myasthenia gravis. In all these, you deliberately want to cut short second stage and then you apply instrument. Okay? What are the prerequisites for instrument? Cervix fully dilated, membranes have to be ruptured. Okay? They cannot be applied on an intact membrane. Fetal head has to be engaged. It means station less than 0. Less than 0 is engaged. Sorry, more than 0. It has to be +1 and more. And no fetopelvic disproportion, obviously. Okay? Then any contraindications for instrumental delivery? Very good. Dr. Alia has mentioned it correct. So primary more than 2 hours is prolonged labor. Good. So contraindications, absolute contraindications, कोई भी prerequisite is not being followed. Patient is not giving you consent, fetopelvic disproportion है, baby big है, cervix is not fully dilated, there are some relative contraindications like fetal bleeding disorder or anomalies. Important जिस पे question आया है, contraindication for vacuum delivery. On this the question has been asked. So vacuum cannot be applied if face is there. A face पे you cannot apply vacuum, it will lead to injury. So in face presentation and in a preterm baby, you will not apply vacuum, because in a preterm baby if you will apply vacuum, the scalp is so soft, the vacuum will suck it, they will lead to cephal hematoma. So contraindication for vacuum, important because the question has been asked, is preterm and face. इसके अलावा even if any prerequisite is not being followed, then if any prerequisite is not being followed, then also it is a contraindication. ठीक है? So this is what the forceps is. Basically questions have been asked many times on identification of forceps. So forceps can be of 3 types: outlet, low and mid forceps. High forceps is not there. Outlet, low and mid forceps. क्या होता है? Outlet means the head is just at the perineum. It is almost, the station is +4 and you can see the head even without separating the labia. So this is how it looks like. Can you see? The head is somehow stuck, it is not getting out, but head is being visible without even separating the labia. It is outlet forceps. Low forceps means head is low the station is +2 से नीचे, it is +2 or +3, but it is still high. Can you see the +2 is here? It is not on the perineum. It is not visible like this. If it is visible like this, it is outlet. If head is below +2 or at +2, it is low. Mid forceps क्या है? Station 0 से लेके +2 is mid forceps. Station 0 से ऊपर तो we cannot apply forceps. Head has to be engaged. So 0 से +2 is mid, 2 से +4 is low, and at 4 or at perineum is outlet forceps. ठीक है? Now these are the types of forceps. You can tell by just by looking at them. So see the small blade. So this is your handle. This is your handle where you hold. This is your shank, and these are your blades. So when there is a small shank and small handle, it means outlet forceps. Baby is just on the outlet. You just need to pull. So small forceps is outlet forceps. Wrigley's. Now can you see this one? It has a long handle and a long shank. It is a low forceps. Simpson's forceps. ठीक है, और Das forceps. Now can you see it is this third one is visibly very different. How? First, when the forceps are locked, in these two handles are approximated. Can you see handles approximate हो रहे हैं, but the shanks are separated. But in this forceps, third one, handles are separate and the shanks are in contact. It is reverse. Handles दूर है, but the shank is approximating each other. What is this forceps? Key lengths. So you can identify key lengths by this. That when the forceps blades are locked, then the shanks are in touch with each other, but the handles are separate. It is key lengths. Another thing, can you see the knobs, small knobs here? Can you see these small knobs? These two. इनका पर्पस क्या है? When your key length is a rotational forceps, occipito posterior है, you are rotating the head. How will you know the head has rotated? These knobs will tell you. If these knobs has rotated, the turn has happened, then the other side does not has knob. So in knobs का purpose क्या है? To tell you whether the rotation has happened or not. So this is key length forceps. One more forceps is there, Piper's. See, it is completely different. Here also the handles are approximated, the shanks are separate. But can you see this curve? Can you understand why the curve is there in shank? Here the shanks are straight. This shank has curve. Because you are applying it in an after coming head. So when you are applying it in a breech, आपका head नहीं आ रहा, पूरी body has come out, the head is not coming out. You have lifted the baby up and now you apply the forceps. So that is why it is curved, because you need to give space to this baby. That is why shank is curved. So Piper forceps, whenever you see curved shank, it is for after coming head of breech. You got it? So key length forceps में how will you identify? By shank and the handle and the knobs. छोटा सा forceps है, outlet है. थोड़ा बड़ा है, it is cavity. Sorry, it is low forceps. Shank is curved, it is Piper forceps. Right? See, identify the instrument used by the obstetrician. It is what? Piper से no, key lengths no, outlet forceps है ना, small forceps. Right? In which of the following situation ventouse is not used? Prolonged second stage, maternal exhaustion, fetal distress या premature? Premature. Why are we not using? What are we scared of in premature? The scalp is soft, so we are scared of it will suck the scalp, cephal hematoma and intracranial hemorrhage. Right? Chalo. Okay, now next question is which of the following is not an indication for cesarean section? So see, cesarean section का as such कोई contraindication नहीं होता. You can do cesarean in anybody except the mother has bleeding disorder or abruption, as we discussed. Cesarean section can be done in anyone. The question is not an indication for cesarean means in which patient you do not need to do cesarean. आप कर सकते हो, but it is not needed. So is absolute cephalopelvic disproportion cesarean needed? Yes. In central placenta previa is cesarean needed? Yes. In advanced carcinoma cervix? Yes. Previous history of macrosomia, is it needed? No. You can do, but is it an indication for cesarean? No. Previous history macrosomia की थी तो क्या हुआ? You can try here. You can try for normal vaginal delivery in this pregnancy. So this is B is the answer. So if we are talking about cesarean, what are the indications? Maternal indications means repeat cesarean. एक बार उसका cesarean हुआ है. Now she is bound to have cesarean. What kind of cesarean? I am talking about classical. So classical cesarean section is an indication for repeat cesarean. She cannot have vaginal birth after cesarean in classical because uterine rupture risk are very high. ठीक है? इसके अलावा कोई obstructive lesion है नीचे, vaginally the baby cannot come, pelvic abnormalities हैं, और certain conditions where आप Valsalva नहीं कर सकते. When the patient is in labor, she has to do Valsalva. It means she has to control her breath and push the baby. So in heart disease you cannot allow her do that. So then that time cesarean is an indication. Fetal indication सबसे common indication होता है non progress of labor. Progress नहीं हो रहा, it is the most common indication for cesarean. इसके अलावा mal presentation, transverse lie है, cesarean करना पड़ेगा. Then infections. When I am saying infections, कि there are certain infections in which I cannot do vaginal delivery. What infection am I talking about? ऐसा कौन सा infection है जिसमें I am not letting my patient deliver vaginally? Okay, so one I have answer I have got HIV. Another answer? Some other person saying something else? Come on, just write any answer yaar. HIV में हम cesarean. Now tell me honestly, इतनी बार HIV has been discussed. Is HIV an indication for cesarean? Is HIV an indication for cesarean? HIV में cesarean is not done unless भी patient को malpresentation है और all these things are there. We are not doing. Only infection I am talking about is herpes, primary herpes. When patient has primary herpes, इतना ज़्यादा transmission होता है, 90% chances है that the baby will deliver vaginally, baby will have herpes, and which is very dangerous herpes. Neonatal herpes बहुत dangerous होता है. HIV में cesarean is not done. So HIV में mother to parent child transmission की NACO guidelines क्या कहते हैं? Start ART, start the patient ART, TLD, tenofovir, lamivudine, dolutegravir at any time she has come. ठीक है? Then do a viral load at 32 weeks to see कि भी patient high risk है या नहीं, and deliver her normally. You don't have to deliver by cesarean HIV patient. What about cord clamping? Delayed cord clamping होती है HIV में. It is not early cord clamping. Delayed करते हैं like any other patient. Milking नहीं करना है. Breastfeeding, the baby can exclusively do the breastfeeding. Absolutely no problem. ठीक है? Exclusively breastfeeding, but baby has to be given some prophylaxis, zidovudine and nevirapine. So if the viral load which you did at 32 weeks, remember, if the viral load is high, you give the baby 2 syrups. If the viral load is low, you give baby 1 syrup. But cesarean has no role in HIV. Only infection where you do is primary herpes. ठीक है? चलो, coming back to the cesarean, fetal distress is another indication, right? Abnormal placenta, which जो हमने भी पढ़ा था, and cephalopelvic disproportion. So next question is, which of the following is not an indication for inducing labor? Inducing labor means patient was not in labor and you induced. Like many conditions, hypertension में we were inducing at 37 weeks. We were inducing labor in diabetes at 39 weeks and 38 weeks. So which is not an indication? Prom, hypertension, placenta previa, oligohydramnios. In which of these we will? So in prom, were we not inducing the labor at 37 weeks? We were. In hypertension, we were inducing at, again, severe है तो 37 पे करेंगे induce, severe है तो 34 पे, non-severe 37. Oligo में, yes, if it is IUGR, placental insufficiency है, we will induce. Placenta previa में क्यों करेंगे? She is an indication for cesarean. Anything, any person whom we cannot deliver vaginally, we will never induce labor. So answer is placenta previa. Very good. All of you have marked it correct. Very good. Identify the maneuver. What is this maneuver? What is this maneuver? What is this maneuver I am talking? Yes, it's Ridgen's maneuver. ठीक है? What is Ridgen's maneuver? So it is just a maneuver done in every patient, not in a high risk patient. In every patient, when the baby is coming out, the baby's head is flexed. Flexed head is the smallest diameter. ठीक है? No, it's not Pinards, it's Ridgen's. I'll just show you what is Pinards. So when head is flexed, so what does the WHO says? It says when the baby's head is come out, as soon as the baby has come out, it has tendency to extend. क्यों? क्योंकि flex क्यों था? Why was the baby's head flexed in the pelvis? Because of levator ani muscle. As soon as baby come out, ये muscle गया, baby will extend. As the baby will extend, there is chances of perineal injury. So when the baby's head is come out, you have to keep it flexed, and that's what do in Ridgen's maneuver. You keep one hand on chin, you keep another hand on the head, and you try to flex and take it out. Immediate deflection you avoid. You take it out slowly, maintaining the flexion. That is the Ridgen's maneuver. So Dr. Alia has said that if viral load is more than 50 copies, beta remember NACO की 2022 की guidelines है. In HIV, viral load, HIV RNA doesn't matter, CD4 count doesn't matter. You don't do cesarean. For preventing transmission from mother to child, cesarean no. Because पता है क्यों? Why they so? They say कि as soon as patient comes to you at any gestation, if she has taken TLD, tenofovir, lamivudine, dolutegravir, the chances of transmission decrease. Also, as the baby has delivered, you are giving nevirapine and zidovudine. The transmission has decreased. Do not do operation just for preventing that transmission. So this is especially NACO means the Indian guidelines. So in our country we cannot go on doing surgery for everyone, right? So we have said कि by giving ART and by giving prophylaxis to baby, we have reduced the risk to 2%. अब cesarean की ज़रूरत नहीं है, you don't need to do cesarean, ठीक है? चलो, this is Ridgen's maneuver done just to prevent the perineal injury. Let's see other methods. ये Pinard's, Lofset, Zavanelli, जितने भी maneuvers है ना, generally they are done in breech pregnancy. Breech में बहुत सारे maneuvers करते हैं at every step. Suppose a breech baby is being delivered जिसके legs extended means frank breech है. So legs are extended, they are not coming out. To bring the legs down, the Pinard's maneuver is done. Pinard's is to bring the legs. You'll see breech में in every point we have to do some maneuver. To bring the leg down, Pinard's maneuver. Suppose head extended, legs बाहर आ गए, legs have come out, but now the hands are extended. So to bring the hand down, Lofset maneuver. Can you see? Legs have come out, but these hands are not coming out. Why? Because the baby's hands are extended in the uterus. So you try to rotate it so that it is stuck behind symphysis pubis. If you rotate, it will come below the symphysis pubis. So Lofset maneuver is for delivering the arm. Pinard's maneuver is for delivering the legs. Now suppose arms भी बाहर आ गए. अब क्या रह गया? What is left of the baby? Head. So for delivering the head, now different maneuvers are done. This is what? So legs have come out, arms have come out. Now head is stuck. Marius-Semmelweis. This is Marius-Semmelweis maneuver for delivering after coming head of breech. What is another method that through which we can deliver the head? This. Right? So I don't know how I forgot the name. This maneuver. Just give me a second. So this is a very famous maneuver. I just can't remember the name of this maneuver. Can just someone tell me what is the name of this maneuver? So this is Pinard's, this is Lofset, this is Marius-Semmelweis, and this is one more method. Just let me know what is the name where we extend the whole body and we take the baby out. Okay? And last way of bringing the baby's head out is, we have just read, forceps. Which forceps I am talking? Pinard's forceps. Okay? Got it? So these are the methods. Generally when we are talking about any maneuvers, we are generally talking about, yes, very good, burn Marshall. I don't know why it was coming in my mind, burn Marshall. So whenever different maneuvers are being talked about, generally all of them are done in breech. So these are, remember these pictures, Pinard's, Lofset, Marius-Semmelweis, burn Marshall, and this is Piper forceps. And the question was on Ridgen's maneuver when we were bringing out head. Okay? Now this is primary gravida. Now continuing with the labor, the rate of labor. In a primary gravida, what is the satisfactory dilatation rate? In a primary gravida, what is satisfactory dilatation rate? It is 1.2. So in a multi dilates faster. So in a multi it is 1.5 and in a primary it is 1.2. It is the rate of dilatation is 1.2 in a primary patient and rate of dilatation is 1.5 centimeter per hour in a multi patient. Okay? This is the minimum that has to be there. So let's discuss quickly about the prolonged phases of labor. Prolonged latent phase क्या होता है? What is latent phase? From painful uterine contractions to how much? 5 centimeter. According to WHO, 5 centimeter is the latent phase. So what do we call it prolonged? When it is more than 20 hours in primary, more than 14 hours in multi. But do we do anything? Suppose it gets prolonged. So latent phase is a preparatory phase. When the uterus is preparing so that as soon as it is dilated more than 5, it can push the baby out. So when it is preparing, it is taking time, let it take time. So what does book say? कि management क्या है of latent phase? Remember, till the cervix is 5 centimeter, how will you manage even if it is prolonged? You will do nothing. If the fetal heart is normal, you will do nothing, observe. Why? You know why? Because many times patient was actually not in labor. You misdiagnosed, 10% patient were actually in false labor. This pain will subside in 10%. And those who are in true labor, they will progress by themselves. So whenever question comes, it has come that cervix is 1 centimeter, 2 centimeter, how will you manage? You will do nothing, send her home. If it is false labor, pain will subside. If it is true, she will dilate by herself. So observe is the main treatment. Sedation is given when the mother is very bothered of pain. Suppose mother has a lot of anxiety, she is having pain, then you sedate. Only 5% may you will need oxytocin. So the main treatment, remember, anybody in latent phase, fetal heart normal, mother normal, observe is the treatment. You do not do ARM, you do not do cesarean. भाई if you did ARM, suppose आपने ARM कर दिया और suppose वो false labor में थी, suppose she was in false labor and now the pains have stopped, then आपने तो membrane ही rupture कर दी. So you do not do anything in latent phase of labor. What you do in active phase? Active phase क्या है? More than 5 centimeter. Books write 6 centimeter, WHO says 5. ठीक है? So prolonged active phase means, how do you describe prolonged active phase? इसको we do not describe in hours. We describe in rate of dilatation. जैसे prolonged latent phase में we said more than 20 hours and 14 hours. Here we describe in rate. The question was asked. So protracted means slow dilatation. So dilatation less than 1.5 centimeter hours in multi and less than 1.2 in primi is slow dilatation. Similarly, descent less than 1 centimeter in primi and less than 2 centimeter hour in multi is slow, protracted dilatation. So Dr. Tawfiq, 4 centimeter नहीं है बच्चे active phase. 4 centimeter was a very old definition. Partogram is started at 4, I agree. But the definition of active phase is 5 centimeter by WHO now. And books आ चुके हैं 6 centimeter पे. ACOG says 6 centimeter. 4 centimeter तो everywhere it has been removed. ठीक है? So this is the rate in active phase. What is arrest disorder? This is also a repeat question of FMG. What is arrest? Arrest means slow नहीं है. There is nothing happening. When will you call arrest? There is no change. For how long? 4 hours. For no change in dilation and descent for 4 hours, you call arrest. Arrest हो चुका है. Now will you manage? Latent phase को we said we will not manage. We will send her home. Now we will not send this lady home. She is already 5 centimeter. Here, if the protracted dilatation is happening or arrest is happening, we have to do something. What? First, rule out CPD. कि disproportion तो नहीं है. Is pelvis adequate? Now rule out CPD. If you see the uterine contractions, if uterine contractions are not good, start oxytocin. Even when doing this, still the arrest is there. Do LSCS. Instrument लगा सकते हैं? Unless it is fully dilated, we cannot apply instrument. Second stage में instrument लगाते हैं. We cannot apply instrument in first stage. Right? So LSCS. These are the steps you have to do in active phase. What do you have to do in latent phase? Nothing. So primary gravida comes to labor room. She comes at 1 p.m. with 5 centimeter cervix. 4 p.m. This is last year question. After 3 hours, at least 1.5 centimeter तो होना चाहिए ना dilation. She is only 1 centimeter dilated. Is she in active phase? Yes. So what is your next step? Will you wait for spontaneous? She is in active phase. You have to do something. Induced labor or intervention? Induced labor का क्या मतलब होता है? Person was not in labor, you induce. Like कोई pre-eclampsia है 36 weeks पे, you induce. She is in labor. You need to augment. Augment होता है when she is in labor, you want to give it a push. That is augment. Induced labor नहीं करते हैं. Intervention is needed. Means augmentation is needed. either give oxytocin, rule out CPD, still no change, do cesarean. ठीक है. Now see, this is 2021 question. 37 weeks mild pain for 20 hours. ठीक है, 20 hours हो चुके हैं. Cervix is persistently 1 centimeter. What will you do? Mild pain है 20 hours से 1 centimeter cervix है. What will you do? Sedation and wait, augmentation, cesarean section या amniotomy. In which phase of labor she is? Latent phase. 20 hours या कुछ भी हो, if the fetal heart is normal, she is also normal, why will you do anything? Send her home. So what will you do? Sedation and wait. अगर एक option, if the option would have been just wait, I would have marked just wait. I would not have marked even sedation and wait. The option best here is sedation and wait. Okay? Correct. So all of you have marked A. Good. So last is no. Dr. Tawfiq B नहीं करेंगे बेटा. Why are you augmenting with oxytocin? She is in latent phase. I told you latent phase में the uterus is preparing. Let it prepare. You will not, even if it is prolonged, you are not managing the latent phase. You will not do anything because you don't know. She might be in the false labor. Okay? चलो. Obstetric emergencies. चलो जल्दी से करके we will just finish it. Then we will start with gynecology after a small break. Which of the following is the process of breaking clavicle during delivery? Which of the following you bring the clavicle? Threadotomy. So why are you breaking clavicle? क्यों बच्चे की clavicle? Because you are trying to smaller this diameter. This diameter, if you are trying to shorten it, then you are breaking the clavicle. So it means what case we are talking about? Shoulder dystocia. So shoulder dystocia का सिर्फ management पढ़ लेते हैं. Shoulder dystocia means when the anterior shoulder is stuck behind pubic symphysis. So first step, as soon as I saw head has delivered, but the shoulders are not coming out. First step, gentle traction in the axial line. In the axial means, axial traction means in the axis of the baby. Remember, this is again FMG question कि axial traction देना या lateral. That is why I am mentioning it. In the axis of the baby, I will try to give the traction. I'll see whether it is coming out or not. It is not coming out. What will lateral traction I will not give. Why? Because there is something here I might injure. Brachial plexus. So it is axial traction. Not working. Now I'll start with the maneuvers. First I'll start with maternal maneuvers. Achha, Dr. Ayush is saying that you have not, where will get the PDF? For, oh, you have not got the PDF. Bache, I have to talk for that to the authority. Don't worry, I'll just sort out something. And within a week, I'll try to arrange for the PDFs. At least I'll try for my PDF. Okay? So I'll talk to the people who can provide you with that. Right? Okay. So I'll do maternal maneuvers first. Means I'll try to manipulate the mother. Baby के अंदर going inside and doing fetal maneuvers से पहले I'll do maternal maneuver. First step, Mac Roberts and suprapubic pressure. Yes, very good. All of you have done it correct. Extension नहीं होता है, flexion of thigh. Dr. Abhijit, it is flexion of thigh, not extension. So Mac Roberts and suprapubic are done together. So one who is giving Mac Roberts, like this nurse, will also give suprapubic. Still, if it is asked, what is done पहले इन दोनों में से? Mac Roberts is done पहले, then you do suprapubic. Okay, so what I am doing by Mac Roberts, when I am flexing the thigh, the maternal sacrum becomes flattened and it lifts upward. So space is created and the shoulder will come out. Okay, if this is not working, Gaskin maneuver can be done. It is not the next. It can be done, or you can straight away go to fetal maneuver. It is mushkil. It is tough. A woman who is pregnant with all IV cannula, turning it in all four position is tough. But yes, Gaskin maneuver is one of the maneuver you can do for shoulder dystocia. But my first step is traction, followed by Mac Roberts, followed by suprapubic. Okay? Yes, Dr. Gautam, flexion and abduction of thigh is Mac Roberts. So Gaskin maneuver was one of the option in FMG. So this is all four position. If these are not working, these are all maternal maneuvers. I'll do the fetal maneuvers, also called internal maneuvers. What will I do? The anterior shoulder is not coming out. If I can feel the posterior shoulder, I'll take the posterior shoulder out. Call it sweeping out of posterior shoulder. If it is not working, I'll try to rotate the baby now. ठीक है, I'll try to rotate. इसे हम कहते हैं rotational deliveries. So if I am rotating by only 90 degrees, it is called Rubin's maneuver. If I am rotating by whole 180 degrees, it is called Wood's corkscrew. Same hai, nothing different. Sometimes if we rotate a little bit, the shoulder will come out. Sometimes we have to rotate it total 180 degree. That is Wood's corkscrew. They both are rotational maneuver, right? In the last, if this is also not working, expect ki baby would have already got hypoxia. You have to deliver within 5 minutes. In shoulder dystocia, head has delivered within 5 minutes if you can deliver good. Otherwise, baby has got hypoxia. What you can do next is deliberate fracture of clavicle. Okay, clitotomy. This will decrease this bisacromial diameter. And last is Zavanelli. Push the baby inside, do the cesarean to take the baby out. Okay. So what was the question asked last year? Mac-Roberts maneuver failed in patient. What will you do next? Suprapubic gaskin, Wood's corkscrew. अच्छा 2 बार gaskin आ गया, sorry. The last option was actually lateral traction. So what will you do? Lateral traction नहीं करना है, axial traction करना होता है. So answer will be suprapubic traction. ठीक है? So obstetric emergency में we discussed shoulder dystocia. Next is PPH. Female patient with PPH has been given ergometrin and oxytocin. Bleeding is still happening. Which prostaglandin can be given now? So you have to know the drugs for PPH. क्या क्या दे सकते हैं? Oxytocin, ergometrin. What all? Dinoproston. Dinoproston is for induction of labor. Misoprostol, yes, a very good drug. Latanoprost or carboprost. So which prostaglandin can be given in this condition when she is having PPH? Misoprost or carboprost? So if it is not being controlled, misoprost takes time to act. It takes almost 30 minutes to act. So answer better is be carboprost. Carboprost will be the one which will be given if it is not acting. Misoprost generally कब देते हैं? When oxytocin is not available. जब वो available ही नहीं है, then we give misoprost. In periphery, जहाँ पे refrigerator नहीं है, oxytocin needs to be refrigerated. वहाँ पे people keep misoprost. If they don't have oxytocin, they give misoprost. Is it a drug for PPH? Yes. PPH prevention and management दोनों में देते हैं. But when it is not being worked by 2 medications, you need the best one, carboprost. Okay? So management of atonic PPH. सबसे पहले क्या होता है? What do you do first? General management. Means IV cannula, put IV cannula, call for help, the first step. And then, okay, start the crystalloids, arrange blood. This is general. Then comes the uterotonics. We have a list of uterotonics drug. We will just discuss. If the uterotonics are not working, you will, before going to surgery, you will do certain non-surgical procedures. We will see the images just. कि क्या क्या images हैं, what are the non-surgical procedures. In the end, the surgery. So about drugs, first choice for preventing PPH, for treating PPH is oxytocin. Preventing PPH मतलब patient has just delivered, उसको PPH नहीं हुआ है, active management of 3rd stage of labor. That's what I'm talking. The drug of choice is oxytocin. ठीक है? 10 to 20 units. Then, what is the only side effect of oxytocin? Oxytocin is a hormone from posterior pituitary. So it has a structure very similar to vasopressin. So it has the structure and function very similar to it. So only side effect is water intoxication. Okay? Next drug we can give is ergometrin. Ergometrin is a very strong vasoconstrictor, very strong. So very rapidly acting drug, very good. But it is very strong vasoconstrictor. You cannot give. Remember this in hypertension, in heart disease, in preeclampsia, in asthma. Remember these common contraindications: hypertension, heart disease, preeclampsia, and asthma. Next is misoprost. Misoprost can be given, but they are basically a little long acting, and they are very good drug because they can be used in a periphery district hospital. They do not need refrigeration. Dose याद रखना है. Treatment dose of misoprost. Treatment means PPH हो चुका है. PPH has happened. What is the treatment dose? 800 microgram sublingual. Sublingual route is very fast to act. But what is the prophylaxis dose? Means in active management of 3rd stage of labor, अगर oxytocin नहीं है, what is the prevention dose? 600 mcg oral. अगर मैं treatment कर रही हूँ, I will give it higher dose through a faster route. If I am giving prophylaxis, I will give a lesser dose through oral route. ठीक है? Next is carboprost. Very effective, very rapidly acting. Maximum doses you can give is 8 ampules. 2 milligram is the maximum dose. It cannot be given in asthma and heart disease. Again, this contraindication. Okay, carbetocin is a very new analog in prevention of PPH. It is not for treatment, it is prevention of PPH. It is an oxytocin analog, very rapidly acting and long acting. Dose has been asked in NEET-PG basically. So you don't remember, let's say it is easy. 100 mcg IM or IV is the dose for prevention of PPH. Don't remember its contraindications. What you have to remember is, इसमें क्या क्या important है? Carboprost की maximum dose is 2 milligram, that is important. Contraindications of ergot alkaloids is very important. Side effect of oxytocin, water intoxication is very important. ठीक है? So what is the complication of IV bolus of oxytocin? So when the water intoxication happens, what happens? The vessels dilate. When the water intoxication is happening, vessels dilate, it lead to sudden hypotension. So whenever oxytocin हम कैसे दे रहे थे? IV infusion. Infusion means I will dissolve the oxytocin in 500 ml NS and then I will give. Because अगर मैंने उसे bolus दिया, means directly syringe से if I pushed, it will lead to sudden hypotension. Okay? So what are before going to surgery, अगर my medical management is not working, before going to surgery, what will I do? Some conservative management. Balloon tamponade and uterine artery embolization. Just see the image. Balloon tamponade means using a Foley catheter balloon, I'll insert it inside the uterus and the bleeding will stop. So this is a conservative method. Again, another one is uterine artery embolization, that can be done, but it is not commonly done. It is done by radiologists in very good centers. ठीक है? Surgery में क्या क्या कर सकते हैं? Compression sutures. Can you see Beeline sutures? Compression sutures, what is the purpose of doing compression sutures? You are approximating the anterior and posterior wall of uterus. Medicine is not working, nothing is working. Why not just stitch them together? Stitch them so tightly that once they are approximating, the bleeding will stop. Another is in uterine artery ligation. So vessel ligation. What vessels we ligate? Uterine artery, ovarian artery and internal iliac. 3 vessels. Uterine, ovarian and internal iliac. Okay. Third is uterine artery embolization. It is a non-surgical method. It is not surgical. इसमें we just put an incision near the inguinal canal. Inguinal canal के पास दो femoral artery से we go to the uterine artery and we impart the embolizing agent and we embolize it. Done in very good centers only. So this is all about PPH. And last is hysterectomy. ठीक है? So now another question. During normal delivery of a primary patient with polyhydramnios, intern prematurely remove the placenta. ठीक है? Intern ने prematurely remove कर दिया placenta even when it was not separated. So examination reveal intact placenta and uterus is outside the introitus. So it is what? Uterine inversion. Placenta is in shock. Sorry, the patient is in shock. What is your diagnosis? Uterine inversion. Okay. So again हमने obstetric emergencies are very important. What are obstetric emergencies जो हम discuss कर चुके हैं? We have discussed shoulder dystocia, PPH, and now we come to the uterine inversion. So how the patient will present? Question will give you scenario PPH and shock. This shock is way more than the PPH. Why? Because shock का reason, maternal shock का reason PPH नहीं है. उसका reason है that there is so much traction when the uterus has come out. The traction on the ovaries will not come out. They are hanging through the pelvic wall. They will not come out. So the traction on ovaries is so much that the women will go into neurogenic shock. So shock, much more than actual blood loss, is actually uterine inversion. And the question will give you your uterus is not felt per abdomen and there is a boggy mass like this seen coming out of vagina. So this kind of scenario is uterine inversion. How will you manage? Immediately call for help. Yes, neurogenic shock. Call for help. Stop oxytocin. Why? Now uterus has come out. You want to reposit it. For that you want a relaxed uterus. If you are starting oxytocin and uterus is contracted, you will never be able to reposit. So stop oxytocin. इसके बाद IV line fluids, that's okay. Then do not remove the placenta. You are trying to remove placenta, that is why the uterus came out. Do not remove it. With placenta intact, push the uterus inside. So remember, push the uterus inside where? In OT or in labor room? Patient is in shock. You don't have time to take her to OT. Then and there, where the inversion has happened, there only you will push the uterus inside. If the patient has delivered at home, there the inversion has happened, you will push the uterus inside at home. You will not take her to the hospital. So what does the guideline write? Reposit the uterus immediately in labor room itself. You do not take her to OT unless your reposition has failed and you need anesthesia. Tab tak you will not take her to OT. Got it? Stop oxytocin. Yes, Dr. Abhijit. Labor room mein you reposit. Stop oxytocin. Do not remove placenta. Push it inside in the labor room. How can you push? Either using hand, जिसको हम कहते हैं Johnson maneuver. Use your hand and push it inside. ठीक है? And then another method is saline, जिसे हम कहते हैं O'Sullivan method. If these two do not work, then you take her to OT and you do surgical methods. Okay? Clear hai? So we have crossed. I was expecting to finish it 1 o'clock, but it has not finished. We will just immediately, I think, finish. Just purparium is left. Yes. Now, so we have covered medical complication. We started from placenta to abortion to ectopic. We covered medical complications. Labor हो गया. Now we have come to purparium. ठीक है? Postpartum. So immediately post delivery, the uterus is where? It is a very theoretical question. जैसे ही uterus deliver होता है, it comes immediately up till the umbilicus. ठीक है? It is 20 weeks. Upper border of umbilicus पे. Right? So it is now the involution start. Means involution का क्या मतलब? What do you mean by involution? Coming to the pre-pregnant state, which takes almost 4 to 6 weeks. अच्छा, Dr. Abhijit has said, please explain the O'Sullivan method. Sure, definitely. ये रहा O'Sullivan. So here you have used your hand. Okay, you are using your hand and pushing it inside. Once it is pushed inside Johnson's, then you start the oxytocin so that the uterus contracts and then you remove your hand. In O'Sullivan, what do? You inject the saline. Using what? Using Ventouse cup. You use Ventouse cup and you use normal saline. You keep it at a good height. You keep it at a good height so that the fluid can pass forcefully into the uterus. Why are you using Ventouse cup? Because Ventouse cup will cover whole of the vagina. So whatever the fluid is coming, it will push inside the uterus and it will not come out. So that is why you are using Ventouse cup. And once it has reverted again, then you will start the oxytocin. When the uterus is contracted, then only you will remove the vacuum. Okay? So that's what we were discussing. Oh yes, sorry. So the umbilicus, it is up till 20 weeks immediately post delivery. Who has told me this? Dr. Gautam. It is the lower border of umbilicus. Correct. Lower border of umbilicus. So involution we were talking about. Involution means coming to pre-pregnant state. So what is happening in involution? First and foremost changes are happening in the uterus. Everything changes, but the most important changes has to happen in uterus. All the decidua which was developed because of pregnancy, that will get necrosed, that will shed off, but the basal layer will not shed off, because basal layer is the source of new endometrium. When the endometrium is shedding off, what are we getting? We are getting lochia and we are getting after pains. So lochia will start after 48 hours because it is nothing but the shedding of the endometrium. So what is the sequence of lochia? That has been asked in question. Lochia rubra, serosa and then alba. Rubra is when there is a lot of blood, when there is a lot of red blood cells, that is rubra. Serosa is a lot of white blood cells. So all the blood has gone out now. Now the epithelial cells and white blood cells come. And in the last we get pale white colored alba. So this is the sequence. Rubra, serosa and alba. Okay? So what is the level of uterus immediately after delivery? Just below the umbilicus. Okay? Which is the correct sequence of vaginal discharge during purpurium? सबसे पहले red आएगा rubra, then आएगा serosa and then alba. ठीक है? Now what is the average duration of the lochial discharge? it is 36 to 42 days. It can go up till months. So it is 36 to 42 days your local discharge happen. Okay. Now this is the question. So we will just discuss postpartum में the questions that have been asked. ठीक है? A woman day 5 postpartum presented with tearfulness, mood swings and occasional insomnia. What is her diagnosis? So see, she is tearful and she presents very early. When it is present so early and no major symptoms are there, it is just mood swings and occasional insomnia is there. She is basically tearful. It is postpartum blue. So I can explain you with a very good video of my Insta video. I really like this one because I have explained it using some Bollywood example. Oh, it is not playing. Into it. I'm not able to play this. Yes, here. Into it. So this is somehow blues look right. So this is a lady. What is happening? So you saw that lady. She is very tearful. She is very upset. But if you will take her to party, you will take her to shopping, she will have fun. So a lady who is enjoying the things she previously used to enjoy, but she is very tearful and tired, that is postpartum blue. It is a self-limiting condition which presents within 4 to 5 days of delivery and it does not stay for more than 48 hours. It is self-limiting. You do not treat this condition with any medication. Now, something which comes after 10 days is into it. She previously used to enjoy, but at times she becomes really and is crying a lot. It's a self-resolving condition in which patient does not need. Now this condition, so postpartum depression is a condition. I don't know whether where the touch with the reality is very well maintained, but patient is not able to enjoy any she previously. So this kind of condition. So now this is depression. So postpartum depression is a condition where the touch with the reality is very well maintained. So depression is, she has significant insomnia, she is tearful, but if you take her out, she will not party, she will not shopping, she will not enjoy anything which she was previously enjoying. But her reality with the touch is very well maintained. That is postpartum depression. That presents after 10 days and you have to treat this condition with the drug of choice is SSRI, fluoxetine. So what is the difference blues and the depression? In blues she is tearful and tired, but she will enjoy if she does something which she previously used to do. Depression, she will not enjoy anything. How will you separate it from postpartum psychosis? In psychosis, the touch to reality is gone. She will have hallucinations. She will have suicidal thoughts. She is harmful for the baby and for herself. So postpartum psychosis, when the reality touch is gone, it is psychosis. It presents late, but the thing is, it is an emergency condition. You have to immediately separate this mother from the baby, admit her, and the treatment of choice is lithium. I know lithium is teratogenic. Lithium cannot be given in breastfeeding, but here saving the life of mother is important, so treatment will be given will be lithium. Okay? Clear? Right. Now, what is the cause of lactational amenorrhea? Why the lactational amenorrhea is happening? Is it because of increased progesterone, increased prolactin, decreased prolactin, or increased GnRH? So lactational amenorrhea is happening because there is high prolactin levels. As a result, GnRH secretion is inhibited. So when the GnRH secretion is reduced, the FSH and LH level reduce. As a result, neither ovulation occur, neither follicular maturation occur. And that is leading to lactational amenorrhea. About lactation, you need to know 2 to 3 things. So colostrum is something which is the initial milk secreted from day 2 to 2 weeks. The transition to mature milk from colostrum happens by 4 to 6 weeks. So by 1 month, the colostrum decreases and mature milk starts rising. Colostrum is the one which has high number of antibodies, and the mature milk is the one which has high number of carbohydrates. What are 2 ingredients which are absent in breast milk? vitamin K and vitamin D. So if somebody asks what vitamins are absent, K is absolutely absent and vitamin D is very less in breast milk. Lactation endocrinology can be remembered by 4 steps. Asked again. Last year also they asked, usse pehle bhi they have asked multiple times. So first step that happened in lactation is mammogenesis. Mammogenesis is step of breast preparation that happens throughout the pregnancy. So mammogenesis means breast is being prepared, the lactiferous ducts and lobules are preparing for the lactation. It is happening during pregnancy, and because of estrogen, progesterone, all these hormones lead to mammogenesis. What is lactogenesis? Lactogenesis means milk synthesis. Milk synthesis happens because of prolactin. That is lactogenesis. Galactokinesis, milk ejection. So remember my name. Galactokinesis is milk ejection. Why is the ejection happening? So prolactin has prepared the milk. Now breast has milk. Why will the milk be ejected? When the baby is suckling the milk, which hormone is released? Oxytocin. So galactokinesis is because of oxytocin. Because oxytocin is there, so even thinking about the baby, even listening the crying of the baby will lead to high oxytocin and ejection of breast milk. Galactopoiesis, maintenance of milk. So lactogenesis ho gaya, galactopoiesis means now you have to maintain that lactation, again a role of prolactin hormone. So again questions have been asked many times that what step is being regulated which hormone. So mammogenesis is work of estrogen progesterone. Lactogenesis is work of prolactin hormone. Galactokinesis, ejection of milk, is the work of oxytocin. Right? So match the sequence. This is the last year question. Kya sequence rahega? First the breast will prepare, mammogenesis will happen. Then the milk will be prepared, lactogenesis. Then milk will be ejected, galactokinesis, and then it has to be maintained, galactopoiesis. Okay? So we have finished our obstetrics and we will meet. So everything is clear. Any doubt up till now? If it is there, you just mention in the chat box. Once we'll join, I'll just try to resolve all the doubts. And we will meet, I think, after 15 minutes. Will that be okay if we meet after 15 minutes? You can have lunch and then we'll join in. Right? So I'll just write down. Yes, let me see if I'm able to write down. 15 minutes break. My pen is not working. Okay? Whatever. Okay, bye-bye. Hi everyone. So I hope you all had a chance to have the lunch, and let's start this session now. Okay. Just give me a thumbs up if I'm audible. If I'm audible, please let me know. चलो ठीक है. Let's start with gynecology now. Okay, we'll try finishing it 2 to 2.5 hours, but so important is that we are able to cover all the important points, right? We should not rush it too much, but yes, it should not be very slow. We'll start with amenorrhea first. So a girl presents with complaints of irregular periods. Okay, so just give me a second. I think let me just attach. Right. Okay. So, yes. A girl presented with complaints of irregular periods, acne, and increased facial growth. Right? So, she has irregular periods, acne, and growth. We can think what the question is talking about. Ultrasound show multiple ovarian follicles. Which of the following will be increased in this patient? So, now since she has irregular periods and follicles, what are we talking about? We are talking about PCOS, right? So what will be increased in this patient? FSH-LH ratio, FSH, serum testosterone, or sex hormone binding globulin. The serum testosterone. So basically PCS mein what is the problem happening? The androgens, correct Dr. Alia. When the androgens not on and only not just testosterone, all other kind of androgens in the body, which is DHEA, DHEAS, they are also androgenic. All of them increase. That is why she has facial hair growth and acne. But remember, testosterone is not very high. It is always less than 80. Okay. No, in fact, see, 80 is the normal value. It is 80 to 150. This is the range in PCOS. Whenever it is crossing the 150 range, then such a high androgen, you have to think of something else, like an androgen producing tumor. So androgen is raised but not very high. FSH-LH value, LH-FSH ratio is high. So FSH is slightly reduced, LH is high. That is what is happening in the PCOS patient. So let's discuss PCOS. It is the most common cause of anovulation. So after pregnancy, it is the most common cause of secondary amenorrhea. What is the diagnostic criteria? Rotterdam criteria is used. We need any two, like in the question, either clinical or biochemical hyperandrogenism. Clinical means hyperandrogenism ke features are there in the patient. Increased facial hair growth and acne is clinical hyperandrogenism. Suppose clinical nahi hai, biochemically we see the testosterone level is high. Along with that, either oligo-ovulation or anovulation. How will we know oligo or anovulation? Patient will have oligomenorrhea. Patient will have infertility. That's what is telling you ovulation is not happening. And polycystic ovaries. Any two of them will indicate PCOS. That is why in last question our diagnosis was PCOS. This is clinical hyperandrogenism, increased facial hair. And this is the ultrasound of the ovary of PCOS. Can you see? So the follicles are small but are multiple in number. So follicles are more than 12. So remember, very small multiple follicles. So follicles will be 2 to 9 mm means small, but multiple means more than 12, and ovary size will be increased because of lot of follicles. And what are these follicles? These are those unruptured ovarian follicles which have not ruptured. That is why anovulation is happening. They are not corpus luteal cyst. Corpus luteal cyst forms after ovulation. These are those follicles which have not ruptured. So they are unruptured follicles. This is called characteristic string of pearl appearance. Other than that, what is there? There is insulin resistance. So these are not the diagnostic criteria, but they are additional findings. And high LH-FSH ratio. And obesity is also a clinical associate of PCOS. Now there was another question. A nulliparous lady with BMI of 23 present with hirsutism. Ultrasound shows the same image. Can you see the ovary multiple cysts, but they are small cysts. If you can remember theca lutein cyst, they were big cysts like this. Theca lutein cysts are huge, but they are small cysts in the periphery. So what is it? It is polycystic ovarian syndrome. Ovarian drilling is done in which of the following conditions? So ovarian drilling is management of polycystic ovarian syndrome. That's we'll see. Chalo management pe aate. So we see how the PCOS is diagnosed, right? So what is the treatment? General treatment which is done in everyone. Everyone who has got PCOS, she has insulin resistance. As she will reduce weight, her insulin resistance will get better. PCOS symptoms will get better. So before starting any medication, the general management in a PCOS patient is reduce weight, exercise and diet. It is done in all. Don't say कि मैम अगर obese ना हो तो बेटा it doesn't matter. She is PCOS, she has insulin resistance. It will be suggested in everyone. इसके अलावा now the treatment part comes. So treatment of PCOS depends on what the symptom she has. Whether her problem is menstrual, whether her problem is acne, whether her problem is infertility, then that will be treated according to the symptom she has. If her problem is menses, means her menses are irregular, they come in a gap of 2 to 3 months, they are heavy because it is anovulation. How an anovulation bleeding presents? For 2 to 3 months there was no ovulation, patient did not bleed. As a result, endometrium became thick, and after 3 months the endometrium started bleeding, and it was heavy, painless bleed. That is characteristic of anovulatory bleeding. How will you manage? Whenever there is menstrual irregularity, anything, first line is always OCPs. So OCPs will not correct her PCOS. PCOS is like diabetes. It will not get corrected, but you can control the symptoms. So for menstrual irregularity, OCPs are the first line medications. इसके अलावा you can give her Mirena and progestins also. Hyperandrogenism, suppose she is not worried about her menstrual problem. She said, I have excess facial hair growth. Then what will be the management? For hirsutism, the management of choice is again OCPs. So estrogen, progesterone, anti-androgens नहीं देते हैं. We don't give anti-androgens. We give estrogen progesterone pills. What does estrogen progesterone pills do? They decrease the level of androgens by increasing sex hormone binding globulin. When the sex hormone binding globulin increase, no doubt that testosterone is in excess amount. It will bind to this, so the free testosterone will be very less. That is how I act. So what is the treatment of choice for hirsutism? Estrogen progesterone pill. And progesterones are little androgenic hormones. They have little androgenic action. So we take care what progesterone we are using. Progesterone are mainly which are used are cyproterone acetate and drospirenone. They are non-androgenic progesterones. So they are preferred in case of hyperandrogenism. ठीक है? इसके अलावा suppose OCPs are not helping her, then you can use anti-androgens. Anti-androgens are not straight away used in a reproductive age female, because if she gets pregnant, they can lead to ambiguous genitalia, which is a very big thing. So anti-androgens will not be straight away used in her. It will be used only if patient is not responding to OCPs. So what are anti-androgens? They act locally on the androgens, like spironolactone, flutamide, finasteride, L-ornithine. They can also be used. But what is the drug of choice? OCPs. Now comes the infertility. So why the infertility is happening? Because of anovulation. Ovulation is not happening. Why? Because by LH level, which had to peak and then FSH has to slowly rise, these variations have gone. LH is at constant high level, FSH is at constant low level. That is why ovulation is not happening. So what will you give? You will give ovulation induction drugs. Drugs which can induce ovulation. Your first line is letrozole. So letrozole is the first line, second is clomiphene citrate. They both are ovulation induction drugs. So if the question give us in what pathology we use clomiphene citrate, we use it in PCOS. Suppose clomiphene and letrozole are not working, then we give gonadotropin injections. We directly give FSH-LH injections. We directly give FSH and LH injections. and then comes laparoscopic ovarian drilling. That is, since it is invasive, laparoscopically you go inside and you make holes on the ovary. You know what it does? When you make holes on the ovary, you remember periphery पे what was located? These follicles. You know what is the source of this excess androgen? ये excess androgen कहाँ से आ रहा है patient में? These follicles are producing excess androgen. As such, they were supposed to produce estrogen, but because ovulation has not happened, the physiology has changed, they are producing androgen. So when you are drilling this hole, you are drilling these follicles, you are rupturing these follicles. They are in the periphery only. So as a result, when you are drilling, the follicles will rupture and the androgenic environment will decrease. Because the source of androgen, you are rupturing them. But why are they not the first line? Because it is an invasive procedure. You always start with oral medications first. So laparoscopic ovarian drilling is a second line medication for anovulation. Okay, you make holes. So that was the question. And last, if nothing is helping, IVF. Okay, so what did we do? Remembered in PCOS, we remembered it is the most common cause of anovulation. After pregnancy, it is the most common cause of secondary amenorrhea. Then how do we diagnose? If we have hyperandrogenism, anovulation and PCOS ovary. And how do we treat? Based on symptom. For menstrual problem and for hirsutism, the drug of choice is same, OCTs. For infertility, the drug of choice is letrozole, followed by clomiphene. Then laparoscopic ovarian drilling. Right? Okay? Now this question. A woman who underwent dilatation and curettage following missed abortion now has amenorrhea. UPT is negative. HCG shows this. What is it? Can you see the smooth, the dye? What are you doing in HSG? You are filling it, the uterus with dye. But it is not getting filled everywhere. There are spaces created. Why? Because there are adhesions there. Because of this dilatation and curettage, there has occurred adhesions. As a result, she is not having bleeding. She is not having menses. So what is the case? Yes, very good, Dr. Alia. It is Asherman syndrome. Perfect. Okay. So how will we basically evaluate the patients of secondary amenorrhea and primary amenorrhea? So secondary amenorrhea पहले पढ़ते हैं. So whenever a patient comes with secondary amenorrhea, secondary amenorrhea means she was menstruating abhi tak, but now she is not able to menstruate. Okay, my laptop is about to get sleep. Let it be. So abhi tak she was not able. Abhi tak she was menstruating, but now she is not. So there can be ovarian cause, there can be central cause, or there can be a chronic anovulation. एक cause है कि ovary is failed. एक cause है कि ovary is not failed, but the ovulation is not happening. It is not failed. Estrogen है body में, but the ovulation is not happening. Another cause is the central cause. The pituitary is not working, and last is the uterine cause. So how will you do? First of all, you will always rule out pregnancy. Second, you will do always a progesterone challenge test. What do we do in progesterone challenge test? We give this lady progesterone 10 tablets. Right? So when we give the progesterone for 10 days, and as we withdraw the progesterone, and we see whether progesterone, इसे कहते हैं progesterone withdrawal bleeding. Is she having that progesterone withdrawal bleeding? Suppose she bleeds, which is the most common case. It means उसका HPO axis is functioning normally, उसकी endometrium is normal. She has not one thing, progesterone. You gave progesterone from outside and she has progesterone withdrawal bleeding. So progesterone, why she is not having progesterone? Progesterone कब बनता है? When is it formed? After ovulation. It means she is not ovulating. Everything is normal. This is the most common cause, chronic anovulation. Suppose on progesterone she does not bleed. Now you give estrogen. You add estrogen with progesterone. Now she starts bleeding. It means her body was lacking what? Estrogen. And you gave it, she started bleeding. It means her body में estrogen is not there. Estrogen is not being produced. So either ovary is failed, premature ovarian failure जिसे कहते हैं, or there is some pituitary tumor because of which the FSH is insufficient and because of which the ovaries are not working properly. So how will we differentiate? By doing FSH-LH levels. If the FSH, so it is not visible there. So if with estrogen the bleeding has occurred, means body was lacking this estrogen. So either ovary is at fault or the center is at the fault, means hypothalamus and pituitary. How will I know? I will get FSH and LH levels. FSH LH low है, तो center is the cause. FSH LH बहुत high है, ovary is at fault. Suppose after giving estrogen also she does not bleed. We gave estrogen, we gave progesterone, she is not bleeding. It means the problem is not of hormones. She has estrogen, she has progesterone in her body. Because when you gave, she does not bleed. So problem is in endometrium. So no bleeding on progesterone, estrogen progesterone challenge test. Problem is in endometrium. She has Asherman. That is why even after giving all the hormones, she is not bleeding. Clear? That is how you evaluate a patient of secondary amenorrhea. Now give me just 1 second so that I can put my laptop to the charging. So my laptop is getting discharged. I'm so sorry. I'll just put it on the charging. Okay. Right. Okay, so that's how we evaluate a secondary amenorrhea. What is the most common cause? PCOS. Now comes the primary amenorrhea, a girl who has never bled. So what is the definition first of all? No bleeding and no secondary sexual characters up till 13. No bleeding but secondary sexual characters are present up till 15. So 13-15 is the new age group. So patient who has no secondary sexual characters, no bleeding, 13 pe you will evaluate. A patient who has got secondary sexual characters, you will give her some time. Ki bhai, abhi she came at 13, she had breast development. I said let's wait for 2 more years. Since secondary sexual characters aa gaye, maybe the bleeding will start. So I will evaluate her at 15 years. How will I evaluate? Whenever a patient of primary amenorrhea comes to me, what do I want to know? Whether she has estrogen in her body or not. And how will I know whether she has estrogen in her body or not? The sign of estrogen is breast development. So I'll see for secondary sexual characters. If secondary sexual characters are absent, she has no estrogen in her body. If it is present, means estrogen has been there in her body, there is some other problem. So if there is no estrogen in her body, it means either ovaries is at fault or the center is at fault. So what will I do to see? अगर secondary sexual characters नहीं है, remember, या तो center is at the fault or the ovaries. I will do hormonal profile. So primary amenorrhea with absent secondary sexual characters, my next step is always hormones. FSH-LH. FSH-LH very high, then ovary is at fault. It is called as hypergonadotropic. And if FSH-LH are very low, the pituitary and hypothalamus are at the fault. Okay? If the secondary sexual characters are present, it means ovary is working, hypothalamus, pituitary are working. Means my HPO axis is intact. तभी तो ovary is producing estrogen. Ovary is producing estrogen. She has secondary sexual characters. It means HPO axis is तो work कर रहा है. Now what is not working? There is some problem in the uterus and vagina. Either it is absent or it is present but it is non-functional. ठीक है? So next step will be a girl primary amenorrhea with secondary sexual characters. What will I think? Straight away think about uterus. So what will be my next investigation? Ultrasound. So as question gives me primary amenorrhea with secondary sexual characters, I will straight away start thinking about कि या तो cryptomenorrhea या फिर है ही नहीं, or there is MRKH. So I will straight away do the ultrasound. But if they give me no secondary sexual characters, my brain is thinking either hypothalamus or pituitary involved or ovaries involved. Let's do FSH-LH. Clear? Chalo. So let's read about primary amenorrhea. Most common cause of primary amenorrhea, gonadal dysgenesis, means gonads not working. Here ovarian failure, this one is the most common cause. So this ovarian failure is the most common cause, right? Gonadal dysgenesis means gonads have not formed at all. So what is the most common cause of gonadal dysgenesis? क्यों नहीं बने? There is always some karyotypic abnormality. There is always some chromosomal abnormality. Which is the most common cause of gonadal dysgenesis? Turner syndrome. Okay? So Turner syndrome, is it the most common cause of primary amenorrhea? Yes. Okay? चलो. Turner syndrome के में whenever patient has Turner syndrome, her karyotype will come out to be X0, and there will be other anomalies like cardiovascular, renal, autoimmune and sensory neural hearing loss. You have to evaluate for all these also. Patient will always have short stature. And how will you diagnose? By karyotype. Karyotype showing X0 is diagnostic of Turner. Suppose if patient has, so if the question gave me primary amenorrhea, no secondary sexual characters, short height, high FSH. High FSH matlab I am thinking ovary is a problem, but they say short stature. What I am thinking about? Turner syndrome. How will I confirm? By doing karyotype. Question gives me primary amenorrhea, absent secondary sexual characters, high FSH. Again I am thinking of ovary, but they give me normal height and normal karyotype, XX या XY. Then pure gonadal dysgenesis. Pure gonadal dysgenesis means there is no karyotypic abnormality. It is XX, but somehow due to some minor chromosomal aberration which we cannot diagnose, the gonads have not formed at all. That is why this girl has uterus vagina, but it does not have secondary sexual characters. Okay, that is how we will diagnose by seeing the question. Now the question give me primary amenorrhea, secondary sexual characters present. What I am thinking straight away? I am thinking about uterus vagina. What will I do? I'll do ultrasound. Ultrasound में no uterus, no vagina. MRKH means Mayer-Rokitansky Kuster-Hauser syndrome. Uterus vagina have not formed at all. Suppose uterus vagina are not there, but it is XY. It means it is androgen insensitivity syndrome. Androgen insensitivity में exactly like MRKH features होते हैं. The person has breast development. There are no uterus vagina because it's an XY boy, but breast development is there. Suppose uterus vagina are present and filled with blood, means cryptomenoria. Got it? This is how you diagnose. This is your presentation. Oops, sorry. Got it? So question has been asked last year that what all are the stigmatas of Turner. Stigmatas means whenever it is X0, there will be certain other features in Turner syndrome. Okay, this is theoretical question, but since it is the most common cause of primary amenorrhea, they expect you to know those stigmatas. What are there? First of all, there is short stature. Then there is low hairline, webbed neck, high arched palate, increased carrying angle. Carrying angle increase matlab kya hota hai? See, when you are carrying anything away from your body, God has given you this angle. Between arm and forearm, there is an angle. Why this angle has been given? So that when you are walking, suppose with something in your hand, if your hand is not having this angle, this hand will just keep on striking the body. So when you are carrying something, it should be away from your body so that it does not collide. This is carrying angle. But when it is exaggerated, it is too much to the lateral side, it is exaggerated. It is called increased carrying angle, which is there in the Turner syndrome. Shield chest and multiple nevi. This is all a feature of Turner syndrome. Got it? So this is the last year question. Turner syndrome has all the following features except webbed neck, wide nipples, increased carrying angle, mental retardation. Turner syndrome are mentally normal. They might have low IQ, but they are not mentally retarded. Got it? Now, a girl present with cyclical abdominal pain, midline hypogastric lump, not achieved menarche. It means she is primary amenorrhea. Whenever primary amenorrhea they give cyclical pain, it means there is happening something cyclically. What is happening cyclically? Every month. Menses. So menses are happening, that is why she is having pain, but it is not coming out. It is cryptomenoria. On PV, there is a bluish swelling seen. What is the condition? When it is a bluish bulge swelling, it is imperforate hymen. Transvaginal septum looks like a pink. Septum is a thick muscular septum. It is a thick pink muscle. And imperforate hymen is like a, yes, correct, very good. Very good, Dr. Ali. All the answers are correct. So imperforate hymen, it's a thin sheet. So why is it blue? Because all the blood which is collecting behind will look blue. And it is bulging because it's a thin sheet. It is being bulged by the blood behind. Whereas transverse vaginal septum is a thick muscle. It will be pink and it will not bulge. Besides blood is being collected behind, it will not bulge. It's a thick muscle. 17-year-old female presents with primary amenorrhea with abdominal pain every month. Again, we are dealing with cryptomenoria. In examination, she has secondary sexual characters. So, whenever secondary sexual characters present, I straight away start thinking about some problem in uterus vagina. Abdominal lump present, on separating the labia, bluish bulge is seen. It is imperforate hymen. But now what are they asking? Appropriate management. So whenever you see imperforate hymen, you have to remove that hymen, because whatever blood is being collected, it will keep on collecting in uterus, then it will just revert back through tubes to the peritoneum. It will lead to endometriosis and adhesions. So you have to drain all the blood. Since it's only a thin membrane, you will make a cruciate incision. Cruciate means as a plus shaped incision. This is cruciate incision. And you will open it so that the blood will drain. Excision of septum will be done in transverse vaginal septum. It is not a septum. So it is just a thin membrane. You just make a cruciate incision and open it up. Correct. Now, a mother brought her 16-year-old daughter with complaint again of primary amenorrhea. On evaluation, axillary and pubic hair are present. Secondary sexual characters are normal. LS, FSH are normal. But here now see. So, I am thinking again what uterus vagina. Uterus is absent this time. So, there could be two reasons. XX, MRKH, always. Whenever uterus is absent, it is either agenesis, means it was a normal female, but because of uterine anomaly, uterus is not formed. That will be an XX girl. Androgen insensitivity is an XY boy who looks like a girl because body is insensitive to androgen. So breast development will be there. External genitalia will be female, but internally uterus vagina are not there. What is the differentiating point? Ek to karyotype. Second, androgen insensitivity is there. As a result, pubic and axillary hair will be absent. That is a second differentiating point. Third point क्या मिल सकता है आपको question है? What can they give? That uterus, that ultrasound is showing ovaries. Ultrasound showing ovaries means it is XX, means MRKH. So if the pubic hair and axillary hair are normal, it means it is not androgen insensitivity. Insensitivity means they will be absent. What it is? It is MRKH. Got it? Yes, Dr. Alia, very good. So this was all about primary amenorrhea. We discussed ovarian causes पे बहुत questions नहीं आए हैं. सिर्फ Turner syndrome they have asked, which is most common. Then they have mostly asked on uterus vagina, cryptomenorrhea, MRKH, androgen insensitivity. Now comes secondary amenorrhea. A young female has history of spontaneous abortion. She has amenorrhea since then. Secondary amenorrhea, okay. FSH is 6. 6 means, so 5 to 25 is normal. So, this will not work. So 5 to 25 is normal. It means FSH is normal. Then why is she not bleeding? If FSH is normal, then ovary is not at fault. HPO axis यानी ठीक है. HPO axis is intact. Then it means it is not ovarian failure. Ovarian failure में FSH is very high. Sheehan syndrome is a problem with pituitary necrosis that happens after delivery. So pituitary necrosis होगा तो FSH will be very less. FSH normal है. It can be PCOS or Asherman. PCOS may be FSH is normal, but they have given you a history of abortions. Or since then only she is amenorrheic. It means she might have got curettage, and as a result now she has got amenorrhea. So it is Asherman. So only history is the one which is differentiating Asherman with the PCOS. ठीक है? Now an 18-year-old girl presents with history of low-grade fever, weight loss, abdominal pain and amenorrhea for 6 months. Now we comes to another cause of amenorrhea. On examination, pelvic mass is felt. Ascites positive. So when you see these so whenever we are talking about secondary amenorrhea, we said PCOD, Asherman. Did we ever mention that patient will have fever, weight loss and ascites? When patient has fever, weight loss, it means it is some kind of infection. So there is some kind of infection which is having ascites and pain and amenorrhea. Means this infection is affecting the uterine lining. So what infection will affecting the uterine lining? Genital tuberculosis. Tuberculosis is the one which is causing these general symptoms. Malignancy or fibroid में these will not happen. Ectopic pregnancy will not present with fever, weight loss and abdominal pain. So this is showing us infection. And which infection? Tuberculosis. So about tuberculosis, we need to know few things. What? It is always secondary from the lungs. So genital TB is never the correct. Is never the primary reason. It is always secondary from the lungs. What is the area which it primarily affects? It affects the fallopian tube. And which part? Ampulla. So it starts with the mucosa of the ampulla. It leads to fibrosis and the necrosis of mucosa, and then it invades the myometrium. As a result, the whole fibrosis of the tubes will happen. So there will be different structures you will find. The tubes will be beaded because fibrosis has happened multiple places. The tubes will be blocked. As a result, fluid will pent up and hydrosalpinx, swollen tubes. Tobacco pouch appearance means the tubes have become fibrous, so fimbria have come in. When they come in, they form a tobacco pouch appearance. So they all are appearance of genital tuberculosis. Then after fallopian tube, it can affect uterus also. And how will it present? Initially, there will be polymenorrhea. But then when it is affecting endometrium basalis should never be affected, because if it is affected, it will lead to adhesions. So it affects endometrium basalis. As a result, adhesions happen followed by complete amenorrhea. So how the question will give you scenario, like here, fever, patient has fever and appetite loss, weight loss, or infertility, or amenorrhea, or ectopic pregnancy. She can also have ectopic pregnancy. So that is how patient will present. So this is how it will look like. Can you see beaded appearance? So here fibrosis happen, it is normal, then fibrosis, then normal. So beaded appearance. Or you can have hydrosalpinx. Since the tubes are blocked, when you pushed the dye inside, it has all collected in the tube. Now tubes are so swollen and damaged. Hydrosalpinx. Also there is tobacco pouch appearance. Can you see here? वो tobacco pouch, you know, that pouch that mummy log have, where you just pull the strings and it closes. That is tobacco pouch. So when there is terminal obstruction and the fimbria comes inward, it leads to tobacco pouch appearance. So they all are appearance of the genital tuberculosis. Okay, so this is sufficient about TB. Now comes abnormal uterine bleeding. Let's discuss some questions on AUB. So which of the following peaks will be responsible for ovulation? You all know which peak is responsible for ovulation? LH. So which peak? What is the LH peak here? Can you see the image? I hope this red color peak is of LH peak happening just before ovulation. So peak number 5. अच्छा option में नहीं है, but it is peak number 5. What is the cause of LH peak? Why is it happening? Can you see here? Here the level of estrogen. When the estrogen is high, estrogen is rising. This persistently high estrogen is the reason for LH peak. So LH peak is the reason for ovulation. But the reason for LH peak is persistently high estrogen level. So estradiol is the one which is leading to this LH surge. And after how long of LH surge ovulation happen? LH surge matlab when the peak has started. So after how long of LH surge the ovulation happen? After 24 to 36 hours. After how long of LH peak the ovulation happen? So surge means when it started, peak means at the peak. So from the surge to ovulation is 24 to 36 hours. From the peak to ovulation is 12 hours. ठीक है? What is the cause of LH surge? Estradiol. This is next question. Which of the following procedure is done with the instrument? What is this? You are trying. So can you see this is very thin, but it has a cavity. So you are trying to collect something with this thin cannula. What are you trying to collect? Cervical sampling, you will not use this. You know what do you use? You use Ayer's spatula. Hysterosalpingography mein you are putting a dye inside. So you need a steel cannula so that the dye can be pushed in. So it is what? It is endometrial sampling. This thin tube will go inside, collect the endometrial fluid and will come out. So this is for endometrial sampling. So let's go ahead with AUB, abnormal uterine bleeding. Whenever it is there, how do you investigate that patient? A patient comes to me with abnormal uterine bleeding. How will I investigate? I will rule out pregnancy first, always. Then I will just do the CBC and platelet count to see how significant the bleeding is. Rule out infections and all. सबसे important क्या है? What I wanted to tell you is in AUB, ultrasound. Because abnormal uterine bleeding के क्या causes हैं? Palm coin. Remember palm coin? Polyp, adenomyosis, leiomyoma, malignancy. So I'll do ultrasound. And coin से क्या है? Coagulopathy and ovulatory defects. So anovulation is again a very common cause of abnormal uterine bleeding. So I need to do the ultrasound to rule out any structural causes. Also, I will need to do an endometrial sampling, because remember M is for malignancy and hyperplasia of endometrium. I do not want to miss that. A patient is of premenopausal age group. She can have hyperplasia, atypical. She can have cancer. I will not miss that. And the presentation will be AUB. So after doing ultrasound, what will be my next step? Endometrial sampling. And that's what the instrument shown in the question was used for. Why am I doing sampling? In anybody who's more than 40 years. Anybody more than 40 years or less than 40 years but high risk of cancer, I have to do the sampling. No matter ultrasound is showing me a fibroid, still I'll do sampling. So endometrial sampling is done in any lady presenting with abnormal bleeding more than 40. Any lady less than 40 presenting with abnormal bleeding with high risk factors. What are high risk factors? All which increase the estrogen content of body. PCOS, obesity, hypertension, diabetes, thick endometrium. Medical management say it is not getting corrected. Familial cancer syndrome, Lynch syndrome. So in these I will do biopsy using the People's cannula which was shown in the image. Endometrial aspiration using this People's curette. Right? Got it? So I did CBC, I did platelet count, I ruled out infection, it's okay. But do I want to rule out structural causes using ultrasound? Yes. Do I want to rule out malignancy and hyperplasia? Yes. So I'll do sampling also. Okay? Now, a 30-year-old woman presents with severe dysmenorrhea, dyspareunia, infertility. Diagnosis of endometriosis was made. She was posted for laparoscopy and there were dense adhesions in the bowel and the ovaries were stuck. How will you manage? So, she is 30 years old, she is a patient of infertility. Will you do hysterectomy and oophorectomy? She is just 30, why will you remove ovary and uterus? Absolutely no. Cystectomy and adhesiolysis, gestrinone to decrease the LS surge, or laparoscopic uterine nerve ablation for chronic pelvic pain. So basically her problem is not chronic pelvic pain, her problem is pain and infertility. So what will you do when you are doing laparoscopy? There are so many adhesions, you will remove the cyst and you will remove the adhesions. Removing the adhesions and removing the cyst will correct both the things. It will correct her infertility and it will correct her dysmenorrhea. Okay, so that will be the treatment that will be done in this patient. So let's see palm coin जो होता है उसको just in one slide we will cover palm coin. What is polyp? Polyp is the endometrial growth, small endometrial growth. ठीक है? What is fibroid? Fibroid is a fibromuscular tumor. What is adenomyosis? Endometrial growth. Endometrium goes into the myometrium. So endometrial growth into the myometrium leading to swelling of the uterus is adenomyosis. What is endometriosis? Endometrial growth outside the uterus, in the pelvis, in the ovary, in the pouch of Douglas. That is endometriosis. How the patient will present? So this is endometriosis. Can you see black spots? These are endometrial tissue all around in the pelvis. How the patient will, what the question will give you in history? If question give you a patient has heavy flow and spotting, that's it. Think of polyp. If patient is giving you, question is trying to give you fibroid, they will mention the pressure symptoms. So fibroid is generally big, so they will give you heavy flow, spotting and pressure symptoms. She is heaviness, she has increased urinary frequency, constipation. So pressure everywhere. Whenever question is giving you adenomyosis, always remember the main focus will be on pain. Adenomyotic uterus is very uniformly, globularly enlarged, uniformly, and it is very painful. So patient will have abnormal flow, but the main symptom will be dysmenorrhea and chronic pelvic pain, not infertility. It does not cause infertility. But dysmenorrhea, pain, chronic, always she will have pain is adenomyosis. Endometriosis, when question will give, they will always give you abnormal flow, dysmenorrhea, pain plus infertility. So when infertility is mentioned, it is endometriosis. When only pain is mentioned, it is adenomyosis. When pressure symptoms are mentioned, it is fibroid. Let's see diagnostic, let's see how the uterus will be there. In fibroid, uterus is irregularly enlarged. Adenomyosis, uniformly soft, enlarged, mobile uterus. Endometriosis, normal uterus, but itne adhesions hai, it is so many adhesions, uterus is stuck to the surrounding structure, it is immobile. Normal size, immobile uterus, endometriosis. Polyp, normal. Polyp एक small endometrial growth है, inside uterus, nothing will be found there in examination. ठीक है? What is diagnostic choice for polyp? Hysteroscopy. It is something growing in the cavity. So how will you diagnose? Hysteroscopy. Fibroid का diagnostic of choice? Ultrasound. Adenomyosis का diagnosis of choice, histopath. Endometriosis का diagnosis of choice, the endometriotic tissue is not inside uterus, it is outside in the pelvis, so you need laparoscopy. Got it? So remember this table, how the patient is presenting and what are the diagnostics of choice. Clear? ठीक है, थोड़ा सा और देखते हैं. Let's see a little more. So this is how polyp will present. A small growth with single feeding vessel is polyp. The myoma also looks like that, submucosal myoma, but there will be multiple vessels. See, this is multiple vessels, that is fibroid. Single feeding vessel is polyp. ठीक है? Then when they are giving you this, can you see this uterus in the first image and this growth? It is irregularly enlarged. Just one part has a growth, that is fibroid. Can you see the second image? This is uniformly, beautifully enlarged. I don't know why I am using my pen, it is not working at all. Yeah. So when it is so uniformly enlarged, and the cyst, can you see the cyst on myometrium? What are these cysts? It is nothing but the endometrial tissue which has entered into the myometrium. So the endometrial tissue should have stayed in the endometrium. It goes and stays in the myometrium. As a result, cyst develop. As a result, myometrium as a uterus produce a reaction and becomes enlarged, but very smoothly, uniformly enlarged. So that is adenomyosis. Okay, what is endometriosis will look like? Endometriosis ka diagnostic I told you, laparoscopy. In ultrasound you can see cyst, but diagnostic of is laparoscopy, because what all you can see as mentioned in the question. Can you see adhesions here? So dense adhesions are there. So there are dense adhesions. There are large cystic ovaries are there. If I don't know if you can see it, I think it is hidden behind my photograph. Okay. Yeah. So if they give you dense adhesions, large ovaries which are stuck with each other, then it is endometriosis. Okay, got it? So what is the treatment of endometriosis? Either you give hormones, or if there are dense adhesions, you remove the adhesions and do the cystectomy. What is the treatment of fibroid? Myomectomy. Right? So myomectomy is the treatment, but remember, myomectomy has to be done only when patient is symptomatic. 20 weeks fibroid, patient has no symptom. Will you treat? No. You will treat only when patient has symptom. Okay? Now, identify the type of myoma labeled in the image. Image 4. See this one, the 4 one. It is you can see it is pedunculated, easy submucosal myoma, isn't it? So pedunculated submucosal. So depending on where it is located, myoma has been categorized. Very easy. You start from the cavity. Category 0 is pedunculated. Category 1 is a small part has gone into the uterine wall. That is category 1. Category 2 is more part has gone into the myometrium, but 50% though it is in the cavity only. Then 3 means within the wall, 4 is completely involved, 5 is a little part is outside the uterine wall, it becomes subserous, 6 is subserous, 7 is pedunculated subserous. So this is the classification of fibroid based on where they are located. Now, a postmenopausal woman comes with pain since 4 months. She has fibroids. Now, radiological investigation shows this. Fibroids clay, we don't do X-ray as such, but chalo, they have done. So, what type of degeneration is this? How, even if you don't know, all kind of degenerations can happen in a fibroid, in a long-standing fibroid. The radio opaque, kaun sa hoga? You can see something in the pelvis. It means whatever it is radio opaque. What will be radio opaque? Fat or hyaline or calcified? So calcified degeneration is obviously be radio opaque and will always be also be visible on the X-ray. Little absurd question I must say, because it is never done, but they just want you to know ki calcific degeneration happens in a long standing fibroid when calcification happens, and it is visible on radiology. So this finishes our abnormal uterine bleeding. Okay? So this much was more than enough. You know palm structural causes, you know all of them, how they present, what are their diagnostic method of choice, and how will they look on ultrasound. Okay, now you have got to know, you have known PCOD and anovulation. Now we will start with infections. A woman present with complaints of greenish discharge. Examination is vulvovaginal erythema. Saline microscopy में motile organism service में. It is motile organism इन सब में एक ही दिखता है, trichomonas. So infections ना we can have to read in 4 categories. Vulvovaginitis, infection of vulva and vagina. Cervicitis, infection of cervix. और ऊपर जाओ PID and last में ulcers. All of them have different specific organism. When I am talking of vulvovaginitis, I am talking of only 3 infections: trichomonas, bacterial vaginosis and candida. Only these 3 cause vulvovaginitis. There are other rare also, but the common one are only these 3 vulvovaginitis. When I talk about cervicitis, I will not talk about these 3. I will talk about other organisms. So how will they present? First, about bacterial vaginosis. Bacterial vaginosis is not an infection. It is just that the vaginal flora, which has a lot of lactobacilli, due to certain circumstances, lactobacilli decrease and other bacteria which were there in the vagina, like mobilincus and parvotella, they increase in amount. So it is not an infection patient is getting from outside. It is just change in the microbacterial flora. Then why do we have to treat? Because when this flora is changed, this patient is prone for other infections. Why the flora has changed? If she has multiple sexual partners. So she has not got it from any partner. But because the pH has changed due to multiple partners, that is why the flora has changed. Or like douching. This lead to bacterial vaginosis. So is it a sexually transmitted infection? No. All the bacteria are there in the vagina. It's just that one bacteria's concentration has decreased, another one has increased. So it is not an STI. Okay, so see, this is gram positive. What do we see? Rod-like bacilli, they are lactobacilli. But when they decrease, in the second image, there are a lot of other bacteria increase, which are small rods, comma-shaped. They are bacterial vaginosis. And there are so many that they will blur the epithelial border. Can you see the epithelial border here? Can you see this border? Is it visible? No, because the bacteria have adhered to the epithelial border. So what is it called? Clue cells. This was the question asked in last year. What are clue cells? Lot of bacteria getting stuck to the epithelial border is the clue cells. Okay? So this is bacterial vaginosis. Most common cause of vaginal discharge. How the patient will present? It is not an STI, but it increases the risk of STI. Diagnosis होती है या तो Nugent score से means gram stain कर लो and see the number of lactobacilli. You don't need to remember this criteria, but you remember Nugent score is a gram stain criteria. Amsel's criteria is important. So Amsel's criteria is for bacterial vaginosis. You need any 3: homogeneous discharge, homogeneous discharge, then clue cells are there, then fishy odor. So they will have fishy odor. Either fishy odor ऐसी आ जाएगी, you have just taken the discharge, you will have fishy odor, or when you add KOH, the fishy odor will be there. What do we call it? We call it whiff test. अच्छा, तो Nugent score, I think screen is not visible. So if any screen is not visible, please just let me know, because na, I will not understand that whether my screen is visible in that part or not. Okay? I will take this to here. Okay. Amsel's criteria यहाँ पे आ गया है. So you have either thin discharge, clue cells, pH is high, or fishy odor. Fishy odor, या तो the discharge will be having fishy odor, or if you add KOH, fishy odor will come. That is called whiff test. So any of these 3 will called Amsel's criteria positive. So knowing about bacterial vaginosis, how are you diagnosing? By Amsel's criteria. What is the discharge? Thin discharge, clue cells will be visible, whiff test is positive. How are you gonna treat? Metronidazole. Remember, what is the drug of choice? Metronidazole for 7 days. Gel रहने दो, बस metronidazole is the treatment of choice. Will you treat the partner without even seeing the partner? कई बार what do we do in India is, if the patient is infective, she has some infection, we assume that partner will also have infection and we treat the partner even without examining. इसे हम कहते हैं expedited partner therapy. Treating the partner if one of the partner is having that infection. Bacterial vaginosis is not a sexually transmitted infection. I told you, it is not something she has received from the partner. So you will not treat the partner here. Clear? Next, vulvovaginitis. Dr. Mukesh, metronidazole not 400, 500. Okay? It is 500 mg. Trichomonas. So trichomonas is a sexually transmitted infection. We are reading vulvovaginitis, जिसमें मैंने कहा था vulvovaginitis is by 3 organisms: bacterial vaginosis, trichomonas, and candida. So trichomonas is a sexually transmitted infection. So am I going to treat the partner? Yes, I will treat the partner in trichomonas. So if a lady has come to me with trichomonas infection, am I going to treat the partner? Absolutely. So how will I diagnose? Women will have greenish frothy discharge, first of all. And I can see the strawberry cervix. Strawberry cervix, it's not cervical infection. It is just the dilated vessels I can see, strawberry cervix. How will I treat how will I diagnose? Trichomonas are basically motile organisms. You take this discharge, put it in a saline drop, look it in the microscope. So microscopy mein you can see the trichomonas like this. Trichomonas are very well visible on the saline microscopy. But trichomonas look very similar to leukocytes. Leukocytes and trichomonas are same size. How will you differentiate? By their jerky movement. They are motile. So trichomonas are motile organisms, and that is how they are differentiated in microscopy. And that is what their diagnostic test. You can also culture them, but the main test commonly done is microscopy. How will you treat? The way you were treating bacterial vaginosis, again, metronidazole is the treatment of choice. Are you treating the partner? It is a sexually transmitted infection. She has got it from her partner, or she can transmit it to her partner. I am going to treat the partner. Even when I am not seeing the partner has symptom or not symptom, I will treat the partner. Okay? Third cause of vulvovaginitis is candida. Whenever question is giving you candida, what will they give? They will always give discharge, curdy, but lot of inflammation. Trichomonas, the bacterial vaginosis, I never said there is lot of inflammation, lot of itching. In candida, there is very much inflammation and itching. When the patient is passing urine and urine is touching the urethral meatus and around surround area, it is painful. So that is how the candidiasis is present. And a curdy discharge. Okay? How will I diagnose? Revise again. How was I diagnosis bacterial vaginosis? By Ansel's criteria. How was I diagnosis trichomonas? By microscopy. How am I diagnosed by candidiasis? Again by microscopy. If I put this wet preparation on microscope, what will I see? I'll see budding yeast cells. That is how it is diagnosed. It can also be cultured. Is it a sexually transmitted infection? No. Candidiasis is not a sexually transmitted infection. They can happen anytime in a woman. If the hygiene is not maintained, if there is constant wetness, then it can happen. It is not sexually transmitted infection. It is the only infection that can happen even in low pH. All other infections were happening when the pH was high. All the infections happen when the pH is high. Only infection that can happen when the pH is low is candida. What is the treatment? Obviously, I'll give an antifungal medication, which is either a clotrimazole cream or a fluconazole tablet. These are the treatment. Revise again. What was the treatment for bacterial vaginosis and trichomonas? Metronidazole. Will I treat partner here? It is not STI. She has not got it from her partner. I will not treat the partner. So in 3 causes of vulvovaginitis, trichomonas, bacterial vaginosis and candidiasis, in which one I was treating the partner? Trichomonas. Rest 2 I am not. Now let's come to the cervicitis. Cervicitis has 2 causes, gonorrhea and chlamydia. So whenever I am talking about cervicitis, I am talking about gonorrhea and chlamydia only. Okay? So how the patient will present? Question will give us. So patient will come with vaginal discharge only. Patient will not know cervix se aa raha hai ya vagina se. So question will say the patient has vaginal discharge. When you did the PS, you will always do PS. You saw either the exudate is coming from the os, or when a swab is passed, the cervix is bleeding. So cervix bleeding or discharge coming from cervix is a sign of cervicitis. If it is not there, it is basically the infection is of vagina. So abnormal vaginal discharge with intermenstrual spotting will be the feature of cervicitis. And what are the causative organisms? Gonorrhea and chlamydia. And how will I diagnose them? By nucleic acid amplification. which is done? No, it is not done. As soon as I suspect cervicitis in India, we just start the treatment. But if asked what is the diagnostic of choice, it is nucleic acid amplification. So chlamydia trachomatis can present with PID, infertility, ectopic. What is the treatment? Which is more important? Chlamydia को कैसे treat करते हैं? Doxycycline. Doxycycline is the treatment of choice for chlamydia. Okay. If the patient is pregnant, I cannot give doxycycline. What will I give? Azithromycin. For chlamydia, I will give azithromycin. Will I treat the partner? Yes. Cervicitis से लेके PID से लेके ulcers. Now everything is sexually transmitted. Everything. So in all the cases, we will treat the partner even without testing them, even if they are asymptomatic. So I'm gonna treat the partner. ठीक है? Gonorrhea, again gonorrhea में भी what is important is what is the treatment. So they are first of all gram negative diplococci intracellular. Remember this line. They are gram negative intracellular diplococci presenting generally asymptomatic, but they have cervicitis and urethral infections. And how will I treat? Ceftriaxone injection, IM. IM ceftriaxone is the treatment of choice for gonorrhea. What was the treatment for chlamydia? Doxycycline, azithromycin. ठीक है? Ceftriaxone IM. If patient is not ready for injection, cefixime. Again, will I treat the partner? Yes, I will treat the partner. Clear? So vulvovaginitis 3, candida. Was I treating the partner? No. What was I giving? Fluconazole or clotrimazole cream. How was I diagnosing candida? Microscopy में yeast cells. Bacterial vaginosis. Is it a STI? No. Will I treat the partner? No. What is the diagnostic of bacterial vaginosis? Amsel's criteria. Whiff test. Clue cells. Then, Then third, trichomonas. Is it a STI? Yes, it is an STI. How am I diagnosing it? Microscopy. What I am seeing? I'll be seeing motile organism in trichomonas. Will I treat the partner? Yes. What I am using for treatment of both bacterial vaginosis and trichomonas? Metronidazole. Cervicitis caused by chlamydia and gonorrhea. How do we diagnose? Nucleic acid amplification. How will I know it is cervicitis? Discharge coming from cervix or cervix is bleeding. What is the treatment? For chlamydia, doxycycline या फिर azithromycin. For gonorrhea, ceftriaxone. Am I treating the partner in both? Yes. Clear? So this was cervicitis, vaginitis. Now come to genital ulcers. सब पे questions have come, that is why we are revising them. So genital ulcers पे many questions are not asked. They just give you the feature of ulcers and then they expect you to diagnose it. Treatment and causative organism, no. But what ulcer it is, you have to tell. So when they say painful ulcer, remember painful ulcers are only two. Herpes and chancroid. They are as soon as they say painful ulcer है, start thinking of these two. बाकी सब हटा दो options है. Herpes will be multiple ulcers and the lymph nodes will be painless. So painless lymph nodes, multiple small ulcers, herpes. But one or two ulcer and painful lymph nodes. ये क्या हो गया? Multiple ulcers, one or two painless. One or two ulcers but painful lymph nodes, chancroid. So painful ulcer, painless lymph node, herpes. Painful ulcer, painful lymph node, chancroid. When I talk about painless ulcer, when they say painless ulcer है, 3 infections: syphilis, lymphogranuloma venerum, granuloma inguinal. Syphilis मतलब S से याद रखो, very sweet ulcer. Syphilis का ulcer is also painless and the lymph node is also painless. इसलिए many times patient will not even come to you. Neither the ulcer, जब तक patient को pain नहीं होता ना, unless the patient has pain, patient will not come to the doctor. So syphilis ulcer generally patient will not come. The एक तो पहली बात, it is STI. Patient has got it from sexually transmitted infections, and the ulcer is not painful. The lymph node is not painful. So this is syphilis. ठीक है? Granuloma inguinal means granuloma inguinal is painless ulcer and no lymph nodes. Very very rare lymph nodes. You can found pseudobubo. Pseudobubo क्या होता है? Means there will be skin induration near the inguinal area which look like lymph node, but when you palpate you realize it is not lymph node. So painless ulcer, painless lymph node. Very nice. Syphilis. Painless ulcer, no lymph node, granuloma inguinal. Now, ulcer is painless, but the lymph node is painful. Lymphogranuloma venerum. Very painful lymph node. In fact, by the time patient comes to the doctor for lymph nodes, tab tak ulcer has gone, and the lymph nodes are so painful it can also lead to stricture and lymphedema. So that is lymphogranuloma venerum. Ulcer is painless, but the lymph nodes are very painful. One other thing, since the lymph nodes above and below the inguinal ligament are there, they will form groove sign. So LGV will have groove sign. Pseudobubo will be present in granuloma inguinal. Don't remember the treatment, remember what are the features of the ulcer. All of these are sexually transmitted infections, yes. So it means in all of them I am treating the partner. Patient ko syphilis ulcer hai, without seeing the partner will I treat? Yes, except one, herpes. Whenever it's a viral illness, I do not treat the partner without symptoms. Because viral आप partner को treat क्यों कर रहे हो? If the patient is asymptomatic, partner is asymptomatic, why are you treating? Because you know, sexually transmitted infection, it is there, partner will be having the organism. You want to remove the organism from the partner's body, even before symptoms. Antiviral will never remove the virus. Antiviral सिर्फ symptoms को कम करता है. Once you have got that herpes, it is there in your body. Anytime again can herpes happen, isn't it? It will never go again. It will never be removed by antiviral. So giving antiviral to a patient who has no symptom is of useless. क्योंकि antiviral का काम, antiviral works only for symptoms. So all of the patients, syphilis, LGV, chancroid, partner treatment will be done. In herpes, partner treatment is not done. Is this clear? Now cervicitis हो गया, vaginitis, ulcers, PID. What is PID? Infection of the uterus, tubes, ovaries and the pelvic peritoneum. As such, we don't have a confirmatory diagnosis. We start the treatment of PID based on clinical suspicion. What is clinical suspicion? What will indicate PID? Question is also there. So any sexually active woman with pain abdomen, with no other obvious cause, with any one of the finding on examination. क्या? What one finding? Cervical motion tenderness or uterine tenderness or adnexal tenderness. So she is sexually active. She came with pain abdomen. I palpated. I could not see ureteric stone or appendicitis. There are no other obvious cause. I did the PB. It was uterine tenderness. So I will start the treatment for PID. That is how PID का presumptive diagnosis is made. ठीक है? Additional criteria होते हैं. If it is fever, abnormal discharge, are additional criteria. So see the question. A young female patient comes to the department with lower pain, fever, vomiting and foul smelling discharge. On examination, she has high fever. Sexually active है, pain है, vaginal discharge and fever भी है. Cervical motion tenderness is there. So what is your diagnosis now? PID. ठीक है? 27-year-old patient present with malodorous vaginal discharge. On examination, whiff test is positive and gram stain shows clue cells. What I am dealing with? What I am dealing with here? Bacterial vaginosis. So infection is commonly treated with what? Metronidazole. Simple. Okay. Which part of the fallopian tube is most commonly involved in genital TB? We have discussed. Ampulla. A couple presented in outpatient department with infertility. Husband semen analysis was normal. Wife had menorrhagia and HSG showed tobacco pouch appearance. So does TB have menorrhagia? Yes. Initially when it affects the endometrium, it is menorrhagia. When it goes to the basalis layer, adhesions developed, then develops amenorrhea. So distal dilatation of tube and tobacco pouch appearance. What are we dealing with? Tubal polyp, spasm, endometriosis, salpingitis. It is tubal salpingitis due to tuberculosis. Okay. So this was all easy infections now. Marsupialization is an ideal treatment of choice for condition X. Marsupialization means there is some cyst, you remove the cyst and you stitch the walls of the cyst ऐसे upturn करके. That is marsupialization. So in which condition you will do it? In Bartholin gland. In Bartholin gland cyst, the treatment is marsupialization. Now there was again a question on, no, not for polyp bache, it is marsupialization is for Bartholin gland cyst. Right? Now, warts. The question is on warts. There has been a question on treatment of warts. Warts are caused by HPV. 90% warts are caused by low risk HPV 6 and 11. Usually asymptomatic, मतलब there are growths but they don't have pain. So there are painless growths. ठीक है, diagnosis is by visual. You visually see them, you can see the diagnosis. What are do's and don'ts in warts? Since this is an HPV infection, will you do the pap smear? Will you do the cervical screening of this patient? Yes. Why will you do the cervical screening of this patient? Because warts are caused by low risk HPV. Pap smear में we check the high risk HPV. So I will do it. So ये मैंने correct बनाना चाहा है, जो नहीं बना. Will you treat the sex partner? Even if he has no warts, will you treat? Wart is by human papilloma virus. It's a viral infection. What did I told you about viral infection? Unless patient is symptomatic, you will not treat the partner. So am I going to treat the partner in warts? I am not. This is my cross. My pen is not working, so cross is not happening. ठीक है? Will you test this patient for STD? Yes. Warts happen? Yes. Condyloma acuminata is the another name for warts. Very good. Correct. So question can be asked on condyloma acuminata also. So don't get confused. It is warts only. Will I test this patient for other STDs like HIV and syphilis? Yes. Because it's a high risk patient. Then vaccination लगाएंगे इस patient को. If she is a young girl, will we give her vaccination against HPV? Yes, we will give vaccination also. Since HPV warts are caused by low risk HPV, vaccination होती है against high risk HPV. We will do that. What is the treatment? So treatment can be two types. Patient खुद administer करता है वो, which is imiquimod, podophylox और cinecachicins. एक होता है administered by the doctors, which is trichloroacetic acid, then cryo and then surgery. So these all can be used when the warts are there on the skin. But if they are urethral warts, they are cervical warts, they are vaginal warts, means they are in the mucosa, inside vagina अगर warts हैं, cervix पे warts हैं, or patient is pregnant. So in all these high risk conditions, what treatment will be used? So question was asked in pregnancy warts, what will you use? Remember all these treatments which were clinical, administered by clinical, that can be used in all high risk warts. Urethral हो, cervical हो, pregnancy में हो. In pregnancy, you cannot use imiquimod, podophylox or cinecachicins. Only chemical that can be used in pregnancy is trichloroacetic acid. You can also do cryo or you can also remove surgically. ठीक है? Dr. Mukesh, Gardasil, you will, in a patient of warts, since the patient of warts is already a high risk patient, we will prefer nonavalent Gardasil vaccine in this patient, which can provide protection against 9 HPV viruses. Because she already has HPV, we will give her extra precaution. Okay? So this has finished infections. Urogenital, vulval, vaginal, cervicitis, all of them. Just a second, I'll just check my batteries. Very less too now. Now we'll come to the infertility. Okay? I hopefully, yes, we will be able to finish on time most likely. 4:30 tak we should finish. Chalo, infertility. Okay. A male was referred to the urology department for evaluation of, just a second. Male was referred to the urology. Yes, Dr. KK, cryo, TCA and surgery using electrosurgery are all safe in pregnancy in warts. Okay? A male was referred to urology OPD for evaluation of infertility. Karyotyping shows XXY. Which of the following statement is not true about this patient? Yes, not true. So this is, since Y chromosome aa chuka hai, it will be a male. But now it has extra X, so definitely there will be problems. Okay? When there is extra X, what will happen? The testis will not function. So see, the male infertility can be testicular, pre-testicular, testicular and post-testicular. XXY karyotype abnormality is a testicular cause. Extra X chromosome will not help testis to function properly. As a result, levels of FSH will not be reduced. Whenever the organ the sex organ, either ovary or testis is not functioning, so FSH will be very high because वो negative feedback is not, it is not getting, pituitary is not getting the negative feedback. Testosterone produced hota normally, it would have negatively inhibited the FSH, that is not being done. So whenever there is problem in ovary or in testis, FSH is always high. So levels of FSH are reduced? No, this is not true. Azoospermia will happen? Yes, there will be no sperms. Patient ka estradiol level will be high since there is extra X chromosome. Patient will have gynecomastia. Patient will have infertility. Testis size will be reduced. Okay, so let's study male infertility. Pre-testicular, testicular and post-testicular causes होते हैं. First, so all of them, no matter if the cause is pre-testicular means hypothalamic, problem is in testis or there is obstruction. How a male infertility patient be diagnosed? The first test is semen analysis. In all these three, semen analysis will always be abnormal. ठीक है ना? Once we get azoospermia, एक बार we did semen analysis, we saw sperms नहीं है. Then we start evaluating कि what of these three the causes. So what is the normal amount? Remember, normal amount is 1.4. Just give me a second, so I'll just get the pen. Just hold on. Yeah. So what are the normal parameters for semen analysis? According to WHO ने 2020 में they have changed their semen parameters. So what is the normal amount of semen? 1.4 ml. 1.4 ml should be the single ejaculate semen. Sperm count 16 million per ml. 16 million per ml is the normal count. Motility, total motile should be more than 42% and actively motile should be more than 30%. Previous आप देखोगे values, so they were 40 and 32. So this is 2020 guidelines. Morphology is same, 4%. At least more than 4% sperms has to be normal. So if the sperm count is less, what do we call that? Azoospermia. If the motility is less, we call it asthenospermia, weak sperms. If the morphology is garbad, morphology is not correct, we call it teratospermia. So these are the terminologies. So if we look at the cause of infertilities, pre-testicular means problem is in the hypothalamus or pituitary. Remember, it is a very rare cause. Pre-testicular is a very rare cause of male infertility. Testicular and post-testicular are common. So what will happen to the hormone? If there is a pre-testicular cause, FSH will fall. In testicular, they will be high, hypergonadotropic. In post-testicular, they will be normal. Okay? In testicular, what will else will be there? The testicular volume will be less. Okay? Common causes of pre-testicular are Kallmann syndrome. जैसे Kallmann syndrome was the cause of amenorrhea in females also. So this is a cause, Kallmann syndrome and prolactinoma in males also, very rare. So pre-testicular causes are very less. Testicular causes क्या क्या हो सकते हैं? It can be, first of all, जैसे हमने अभी पढ़ा, XXY. So there is XXY Klinefelter syndrome. Then the Carter-Jenner syndrome. Carter-Jenner syndrome is also called as primary ciliary dyskinesia. What is happening that any flagella is not working. So patient will have a lot of infections and there will be immotile sperms. So that is again a testicular cause. Post-testicular means obstruction है कहीं पे भी. So cystic fibrosis. Why cystic fibrosis? Cystic fibrosis is almost always associated with congenitally bilateral absence of vas difference. So whenever there is congenitally absent bilateral vas, cystic fibrosis is there, always think of CBAVD. It will lead to obstructive azoospermia. Young syndrome. So in Young syndrome also, there will be, what will happen is that the testis is forming normal sperms, but they are not able to travel through the vas difference. So that is why young syndrome is a post testicular cause. इसके अलावा क्या क्या हो सकता है? Patient has got vasectomy, patient has got some ejaculatory duct obstruction due to infections. They all are post testicular causes, and this is the hormones which level which will tell you what is the cause. ठीक है. So when the Carter-Jenner syndrome is there, there are other multiple infections. Situs inversus, bronchiectasis. They are a triad of Carter-Jenner syndrome. ठीक है. ये रहा, right. A male presented with infertility and recurrent hospitalization for infections. So what the patient has? It has Carter-Jenner syndrome, primary ciliary dyskinesia. ठीक है. So this was about male fertility, pre-testicular, testicular, post-testicular. They will just give you the scenario and the hormone levels. By the hormone levels, you have to guess what is the common cause. Female infertility. So female में क्या चीज़ें चाहिए? Male में तो you know the semen will be abnormal. Female में you need two things. You need tubes and you need ovulation. So check whether the female is ovulating or not. When you are talking about female infertility, whether she is ovulating or not. How will you know whether she is ovulating? Menstrual cycle. Regular menstrual cycle is an indication she is ovulating. Basal body temperature, cervical mucus. Now the question comes. What is the best test to indicate that ovulation has occurred? The best test to show that ovulation has occurred is mid-luteal progesterone. Day 21 progesterone is best test to tell ovulation has occurred. The best test to predict the ovulation. Ovulation अभी हुआ नहीं है. Predict means होने वाला है. The best test which will predict the ovulation is, ovulation से just पहले क्या होता है? LS surge. So the best test to predict ovulation is LS surge. Best test to confirm ovulation is progesterone. Done at day 21, done at day 14. ठीक है. So all this will tell you whether the woman is ovulating or not. So Dr. Alia is asking how to differentiate between cystic fibrosis and primary ciliary dyskinesia. So Dr. Alia, if the question will give you cystic fibrosis, they will give you the other findings of cystic fibrosis where there are thickened secretions and there will be loss of sweating. So they will increase the viscous secretions. That is why lung infections are there in cystic fibrosis, and it is an obstructive cause. So FSH-LH will be normal, whereas in primary dyskinesia the FSH-LH will be high. Okay, and there will be recurrent bronchiectasis, and situs inversus can also be given in the question. It is a testicular cause, it is a post-testicular cause. In cystic fibrosis, semen will be acidic. Whenever there is obstruction, the semen generally tends to become acidic. क्यों? क्योंकि seminal vesicle will not secrete, the seminal vesicle secretion will not be able to reach there. But if it is a testicular cause, the semen will not be acidic. So, test for ovarian reserve, I am already getting the answer. Some people are writing AMH, yes. So there were tests for ovulation, whether ovulation is happening or not. There are certain tests for ovarian reserve, means how many follicles are there in the ovary. Suppose patient is not ovulating, I gave her clomiphene citrate. Patient is not responding. First test I have to do is ovarian reserve. How many follicles she has in her ovary? A woman, how many follicles are remaining in the ovary? Is there premature aging happening? So there are tests to see the ovarian reserve. All these tests don't remember. Remember what is the best test? Anti-Mullerian hormone, as mentioned by other people also. AMH, anti-Mullerian hormone, is the best test for ovarian reserve. ये ovary है हमारे पास. It has multiple small follicles. In these small follicles, every time एक chunk of follicle is picked up which matures to form one graphene follicle. ये rupture करता है next cycle में फिर से. From this whole reserve of follicles, again a chunk is picked up and one graphene follicle forms. I want to know how much this reserve I have. These reserve keep on secreting one hormone, that is AMH. And when I measure this AMH, if it is very low, if it is less than 1, it shows me that these follicles are very less in amount. So the best test is anti-Mullerian hormone. It can be done any day of the menstrual cycle. All other tests for FSH have to be done at day 3. Estradiol have to be done at day 3. AMH is being constantly secreted by these small follicles. You can do it in any time of the cycle, and it is the best test. ठीक है. So that is how we know whether she is ovulating or not and how much ovarian reserve she has in her body. Now if I want to do the tube test, what is the first test? If I want to see the tube is patent or not, I'll do HSG, hysterosalpingography, but it is not a confirmatory test. Can you see here HSG? Can you see the tubes? Tubes are somewhere here, but they are not visible. Why? There is cornual block. It is bilateral cornua block. The dye has not even entered the tube. So it is bilateral cornual block in HSG. This is what? Tubes are visible, but can you see how thick and dilated they are? And there is no peritoneal spill. They have to spill in the peritoneum. If the fimbria are open, they will spill in the peritoneum. So this is what block? Fimbrial block. Now if it is fimbrial block means the tube, the dye has filled the tube, it is not going out. And see how it is swollen. So it is actually hydrosalpinx. It is nothing but hydrosalpinx. So what is diagnostic? If I am getting this block of the cornua, will I diagnose tube is blocked? The diagnostic is laparoscopy. I always have to do the laparoscopy. So HSG is the initial test for tube. What is the diagnostic test for tube? Is laparoscopy. I'll do laparoscope, I'll inject the dye and I'll see from my eyes whether the dye is coming out or not. Okay? So a lady comes with inability to conceive, dysmenorrhea, pelvic pain. She has history of pelvic inflammatory disease. HSG show absence of peritoneal spill on the right side. What is it? Tubal block, endometriosis, Asherman, bilateral hydrosalpinx. So it has recurrent PID. So I could have marked bilateral hydrosalpinx, but it is only on the right side. So it is tubal block. Okay? What is this instrument? The test we just read, HSG. This is the Leach-Wilkinson cannula used for hysterosalpingography. So little about hysterosalpingography. When do we do hysterosalpingography? When we are trying to check the tube, means in infertility, in a patient of abnormal bleeding, in a patient of suspected congenital anomalies, a patient is having recurrent abortion. So HSG में images देखे थे ना, you will get bicornuate uterus, didelphys uterus. These are the indications of HSG. Then when is the right time to do it? We will do it between day 7 to day 12. If one answer is asked, day 10, not after that. Because if the patient is pregnant, by chance you did it after ovulation and the patient was pregnant, you will disimplant the pregnancy. So it is always done before ovulation, day 7 to day 10. What do you use? You use water soluble iodinated dye. And what cannula you use? Leach-Wilkinson cannula. Okay? On which the question was also asked. Now another question. A woman with history of infertility is on treatment of HMG, means IVF. She presented with following. Can you see the ovaries and enlarged these thick cysts? What is this? That's what we have discussed already. Is it theca lutein? It is not PCOD definitely. Is it theca lutein cyst or OHSS? Do they look different on ultrasound? No. They look exactly same. How do we differentiate? History. She has been given HMG injections. So her ovaries have got hyperstimulated. If they would have given amenorrhea with passing vesicles through the vagina, UPT positive, I would have marked theca lutein cyst. Okay? Very good. A. This is how PCOD ovary looks like. Small multiple number of follicles in the periphery of ovary. So this is about infertility and little about HSG. Next comes the pelvic organ prolapse. Pelvic organ prolapse and incontinence and fistulas. A female undergoes methylene blue swab test and middle swab is stained with blue color. What is the diagnosis? Middle swab. What is it? Vesicovaginal. So see, genital fistulas के types can be vesicouterine, means through the bladder to the uterus, then vesicovaginal through the bladder to the vagina, urethrovaginal and ureterovaginal. All these can be the fistulas. What are the causes? If somebody asks what are the main causes? Yes, the main causes of fistulas are, in India, the obstructive birth, obstructed labor and prolonged labor. Overall, in developed countries, the most common cause of fistulas is the surgery. Okay, so there the most common cause is the surgery. Now the question क्या क्या आ सकते हैं on fistulas, which is the most common surgery that can lead to fistula? Simple hysterectomy. इसका मतलब is simple hysterectomy a risky surgery? No, because simple hysterectomy is the surgery which is most commonly done. Whenever hysterectomy is being done, almost 20 simple hysterectomy होते हैं, एक radical hysterectomy होता है. So though the chances of ureteric injury are less in it, maybe only 2 ureteric injury will happen. इसमें 1 की 1 हो जाएगी. But the most common cause will be simple hysterectomy, क्योंकि सबसे ज़्यादा simple hysterectomy are being done. So though the most common cause of the ureteric injuries are, so ureteric injuries can lead to fistula, right? So ureteric injuries most common cause is hysterectomy, but the most risky hysterectomy is radical hysterectomy. Laparoscopy ज़्यादा risky है या laparotomy in forming fistulas? Laparoscopy में there is a small space, you are using instruments. The chances of injury is more in laparoscopy. Laparoscopy is a very good surgery. Less blood loss, small adhesions, very fast recovery. But when the abdomen is opened in front of you, you can see everything. Chances of injury are less. In laparoscopy, through this camera, you are doing everything. So the chances are more with laparoscopic surgeries. Right? So these are the common questions that can be asked. Next common question क्या सकता है in ureteric injuries? Next common question can be, what is the most common site of ureteric injury? Near the cervical os. So the most common site is when you are cutting the cervical os. इसके बाद next common site is pelvic brim, right? Excuse me again, my battery is going. Just a second, just 1 second. ठीक है, तो वी डिस्कस दिस फिस्टुलाज, वी डिस्कस्ड अबाउट दी यूरेटर की बात करें तो व्हाट इज़ द कॉजेज ऑफ फिस्टुलाज एंड विच सर्जरी लीड टू इंजरी, व्हाट इज़ द मोस्ट कॉमन साइट नियर द सर्वाइकल ऑस. सो डॉक्टर आलोक क्लास कब तक है बेटा? जब तक चलेगा, मोस्ट लाइकली आई थिंक बाय 4:30 वी शुड बी एबल टू फिनिश, बाय 5 वी विल बी टोटली ओवर. ओके, राइट. सो दीज आर द फिस्टुलाज. कैन यू सी हियर, वन इज विद द यूरेटर, one is with the vesicle and one is with the urethra. So see, urethral dye test में क्या करते हैं? You fill the bladder with the dye. So if the middle swab is stained blue, it is from the bladder. If the lowermost swab is stained blue, it is with the urethra. But if the upper swab is just wet, it will not be stained. Why? भाई ureter में थोड़ी ना dye है. Ureter has no dye. Dye has reached only the bladder. It will not go into the ureter. If any of the swab, or देखो, it is little tricky. If this swab is wet, eventually this swab can also get wet, है ना? The urine can trickle and wet the middle swab and lower swab also. But whenever it is ureterovaginal, whenever the leak is from ureter, it will never be stained, क्योंकि ureter has no dye. But if it is blue stained, it is either from the bladder or from the urethra. So अगर middle swab stained है तो bladder है. If the lower swab is stained, it is urethra. If none of the swab is stained, they are wet, it is from ureter. So this is done when you are suspecting the fistula. But what will be the confirmatory? How will you confirm? It is not confirmatory. If the ureterovaginal fistula is there, you want to confirm the site and the size. Same with vesicovaginal. So confirmation is using the cystourethropy. In a vesical and urethral, you will do cystourethropy. In ureteral fistula, you will do CT scan, CT urogram. That is confirmatory. They are the first they are not the diagnostic test, they are the first line investigation. Okay? When the surgical repair is done, suppose you did the hysterectomy and you saw the fistula has been formed. If you have diagnosed it immediately during the surgery, repair it within 24 hours. If 24 hours have surpassed, what happened? This fistula develops all inflammation and edema. Now if you have diagnosed it after 24 hours, you have to wait for how long? 6 to 8 weeks. Sorry, 8 to 12 weeks. Because if the inflammation and edema is there, now you will stitch, it will give away. So within 24 hours, stitch immediately. After 24 hours diagnosed, wait for 3 months. 2 to 3 months. Okay? So identify the fistula labeled below. This is very easy. So the fistula is between bladder and the vagina. So it is vesico-vaginal. Okay? The highest incidence of ureteric injury is seen in, highest incidence means most risky is Vardynes. Okay? Most common, किस surgery में मिल जाएगा? Most common, the surgery which is done most commonly, abdominal hysterectomy. But the highest incidence, the most risky is Vardynes. Vardynes is the radical hysterectomy. You are trying to remove the pelvic tissue and the uterine artery at origin, all the lateral tissue, so chances are more. A woman complains of involuntary urine voiding during workout. What is her diagnosis? So this is the last year question. It is very simple. What is urge incontinence? Means when you have urge, your bladder is full or maybe not full, but when you have urge of urination, you are not able to control it and not able to reach up to the washroom. You are not able to hold that urge of urination, that is urge incontinence. Stress means you are able to hold the urge, but when your bladder has urine inside it and any stress is given, you coughed or you did a workout, you danced, and due to that stress, the sphincter opened up and the leakages happened. That is stress incontinence. Neurogenic means there is problem in the nerves, like diabetes, like spinal cord problems. All these can lead to neurogenic incontinence. So when involuntary voiding has occurred during the workout, as the stress happened, the sphincter opened up, it is stress incontinence. Urge incontinence means sphincter is intact. The detrusal muscle are working so fast that you have urge to go to the washroom, but you are not able to control. Muscle are functioning so fast, leakage will happen. That is urge incontinence. Detrusor overactivity. Machial cultoplasty is done in which of the following? So see, vaginal wall prolapse can be of, yes, Dr. Alia, it was stress, good. So prolapse can be of anterior vaginal wall, it can be posterior, it can be the uterus. Anterior vaginal wall में क्या क्या है? Bladder and urethra. Posterior vaginal wall में rectum and, so there is rectum and anus. So when it is the cystocele, means upper 2/3 the bladder has come out or the urethra has come out. The term we use is anterior colporaphy. कुछ नहीं करते हैं. What we do, we open the vaginal wall, we push the content back and we tightly stitch the vaginal wall. So we are not removing or cutting anything. Bladder को हटा थोड़ी सकते. We cannot remove it. We just tightly stitch the vaginal wall. It is anterior colporaphy. Similarly, posteriorly, अगर rectum से आ रहा है या फिर urethra नहीं, sorry, anal canal आ रहा है, we call it posterior colporaphy. But enterocele क्या होता है? When the bowel is coming. So bowel is not posterior vaginal wall. It is coming from the apex. So that is called as the highest prolapse, central prolapse. So enterocele is a central prolapse. For that, posterior colporaphy, stitching the posterior vaginal wall will not help. ये posterior vaginal wall है, उसके ऊपर से enterocele comes. So this is, you cannot repair it with just a posterior vaginal wall repair. You have to open this peritoneum, send the loops inside, make a pursing suture here. इसे हम कहते हैं machial cultoplasty. Culdo sac क्या होता है? Pouch of Douglas को भी say Culdi sac. Remember, between the uterus and the rectum there is a pouch of Douglas. इसे हम Culdi sac कहते हैं. From there enterocele comes. It has nothing to do with the posterior vaginal wall. So posterior colporaphy will not help. Enterocele में remove that Culdi sac, remove excess peritoneum, send the bowel back, stitch the peritoneum. We call it machial cultoplasty. So what was the question? Why is machial cultoplasty done? For enterocele. When we are stitching the Culdi sac, the pouch of Douglas. What about the uterus? If the uterus is coming, what will you do? Hysterectomy, vaginal hysterectomy. But suppose this is a young patient, she does not want hysterectomy, her family is not complete, then there are other options. What are the other options? You can, if the degree of prolapse is only first or second degree, use pessary. Pessary cannot be used in advanced prolapse. In advanced prolapse, she want to preserve uterus, what will you do? Sling operation. Best answer is sling operations. Purandare sling operation, Shirorkar sling operation, sacrohysteropexy. Sacrohysteropexy means sacrum, uterus, pexy, stitch them together. So take a sling attach it to uterus and stitch it to sacrum, sacrohysteropexy. They all are sling operations. इसके अलावा what is mentioned is Fothergill, modified Manchester Fothergill. See, Fothergill में what do we do when the cervix is coming? When the cervical length is increased, uterus is there, cervix is coming, we cut the cervix and we tie it. We tie the ligaments around it. So Fothergill or Manchester are basically uterus preserving surgery, but they are done for elongated cervix. True cervical elongation. When the uterus is coming down, the problem is not in cervix. You need to pull up the uterus. Cutting the cervix will not help. You need to pull up the uterus. Sling operation is done. If it's a very old patient, she cannot tolerate any surgery, Lee-Fort surgery. Lee-Fort in very old patient, not sexually active, just stitch the labia, close it. So the prolapse, even when it is coming, it will not be visible, patient will be satisfied. Got it? So anterior colporrhaphy, Meckel cholecystoplasty, posterior colporrhaphy for uterine prolapse, either hysterectomy or pessary for the initial stages of prolapse. Sling operation is the best answer in a reproductive age female. Fothergill for cervical elongation and Lee-Fort for a very old patient. Clear? चलो questions देखते हैं. The best recommended management in case of walled prolapse. So walled prolapse with cystocele and rectocele means anteriorly cystocele bladder, posteriorly rectocele सब आ रहा है. So anterior colporrhaphy plus posterior colpoperineuraphy. Isn't it? Anterior wall भी repair करेंगे, posterior भी करेंगे. Okay. Now a 75-year-old woman comes with complaint of mass per vaginum and she was posted for operative repair. During pre-anesthesia, she was found to be unfit for a major surgery. What will you do? She is 75 and she is unfit. What will you do? Cervicopexy is a major surgery. उठा के उसको through sling you are putting it. Shirodkar sling, Khanna sling, they are to be done in a reproductive age female who want to preserve her uterus. Lee-Fort's repair will be the ideal for her. Correct, Dr. Alia. Good. A patient presents to you with complaint of mass descending per vaginum. On examination, you saw grade 3 prolapse and an ulcer. Which of the following is the cause for this ulcer and the treatment? Why ulcer happen in the prolapse? Because the dependent parts get the blood, but the venous return is not happening because the prolapse is there. As a result, venous return is not happening. A lot of congestion is happening, leading to formation of an ulcer, and also because of rubbing from the surrounding tissues. So what do? The venous congestion is the reason. You have to relieve the venous congestion. Lift that part up and shift it up. So unless the decubitus ulcer is corrected, you cannot do the surgery. What do? You just reduce the prolapse part every day using a sponge. Even if it comes out, again put a sponge till the ulcer heals. So this is your answer. It is due to venous congestion, not a malignancy or infection. And venous congestion है, so क्या करोगे? Lift it up, venous congestion will get corrected. Eventually in a week or two, the ulcer will get corrected. Correct. Clear है? So only two things are left, that is contraception and malignancy. Let's quickly finish the contraception first. Now, which of the following cannot be used for emergency contraception? What we cannot use for emergency contraception? Centromin. Centromin is not used for emergency contraception. Centromin क्या drug है? छाया. Saheli. You remember Saheli नाम से आता था पहले. So it is an Indian drug which is an oral contraceptive pill, but it is not used for emergency contraception. Okay. So what do we use for emergency contraception? We have 4 methods. WHO has given only 4 methods for emergency contraception. Levonorgestrel, ulipristal acetate, combined OCPs. Combined OCP means estrogen or progesterone pills in large amount. So many pills can be taken. Yes, it is mentioned in WHO. इसी को हम Zuspi's method कहते थे. Too many pills together of OCPs can work as an emergency contraception. And the most effective, copper IUCD. These are the 4 methods of emergency contraception. So what will be your answer here? Centromin. So levonorgestrel can be taken. So पहले पढ़ते ulipristal acetate is taken as single tablet within 5 days and dose is 30 milligram. So remember all this. Ulipristal is an emergency contraception. Dose is 30 mg. It has to be taken within 5 days of intercourse. Levonorgestrel, it has to be taken within 72 hours, not within 5 days. Either take a single dose of 1.5 milligram, or take 2 doses. 0.75, 0.75 की 2 doses ले लो 12 hours apart. It has to be taken within 72 hours. Combined OCPs को हम कहते हैं ZUSP method. OCPs in high dose. How high dose? Ethinyl estradiol almost 100 mcg. Levonorgestrel 0.5. So normal pills में ethinyl estradiol कितना होता है? माला N माला D में कितना होता है? 30 mcg. And levonorgestrel is 150 mcg. 0.15. So you need almost 4 tablets. So for this you have to take 4 to 5 tablets once and repeat it after 12 hours. Means total आपने 10 tablets लिए OCPs की. So high doses of OCPs can also be used. In fact, previously, पहले, when the emergency contraceptive pills were not developed, that time women used to take large amount of OCPs. But when you are taking large OCP pills, the risks are more. You are taking so high amount of estrogen. So that is why it is not very well advertised. Copper bearing IUCD is the best method with 100% efficacy, and it has to be introduced within 5 days. So remember, Mirena, hormonal IUCD is not used, copper IUCD. These are the 4 methods. Mifepristone is somewhere mentioned. It is an emergency contraception, yes. The dose is 10 milligram. Problem क्या है? It is not available in this dose. Mifepristone की dose 60. Remember वो जो हम abortion वाली dose लेते थे क्या थी? 200 milligram. So Mifepristone की 10 milligram dose is not available. So that is why it is not prescribed as an emergency contraception. Okay. A young lady comes with intercourse 5 days back. She wants emergency contraception. Which one will you advise? 5 days. पहले हुआ है. What can you use? LNJ pill has to be taken within 72 hours. IUCD, yes. OCPs, no. No OCPs. Misoprostol तो है ही नहीं. It's not an emergency contraceptive pill. OCPs, जो not just OCP, multiple OCPs have to be taken within 72 hours only. ठीक है? So this much about emergency contraception is enough. क्या क्या medications है? 4. कब कब लेने and what are the doses? How long should a couple use contraception post vasectomy? So when the vasectomy has happened, is the man infertile immediately after? No, because in the ejaculatory duct, in the vas deferens, everywhere the sperms are there. So the system has to wash out all the sperms. It takes 3 months. So after 3 months, you do semen analysis. 2 semen analysis showing azoospermia. Now you declare that this man has completed the contraception. Now he cannot have more babies. So after how many weeks? 12 weeks. So after 12 to 16 weeks, they can be declared that the contraception is complete. Okay? So let's read a detail about permanent methods also. Permanent methods. Yes, Dr. Alet is 3 months. Correct, Dr. Mukesh. Right? Okay. So permanent methods vasectomy है for males, and for females tubal sterilization. These are the methods of tubal sterilization. इनमें से सबसे commonly which we do these days, modified pomeroyze. This B. Which one do we do? Pomeroyze is done most commonly. ठीक है? So this is the method of choice. This is done when the laparotomy is being done. The tubes are visible. You can do all the tubal ligation procedures. Then you are doing it via laparoscopy. तब you cannot do all this. Laparoscopy में you are going inside using the laparoscopic instruments. You cannot do a tie here and embed here. Then when you are doing laparoscopic techniques, there are only few methods through which you can occlude this tube. You can use either the Hilka clips or the Filshy clips or the Hilka clips, because you have to go inside using an instrument. So only a small thing can be inserted. So these are the tubal sterilization methods. This is Hilka Kleeman clips, Filshy clip, fallope ring or electrocautery. They all are used for laparoscopic tubal ligation. The surgical method used for laparotomy tubal sterilization, what we all read. Vasectomy can be of 2 types, scalpel and non-scalpel. पहले scalpel करते थे when we used to put a small incision on the scrotum, but then it was seen that the skin is very flexible. So non-scalpel again. Non-scalpel में you just make a puncture hole into the folds of scrotum and the hole is dilated. Through that dilated hole, through that one hole, you can hold both the epididymis. You hold it, tie it with a nylon thread, cut it, and you insert it inside. Since it's just an hole, it is less invasive. You do not stitch it. Here, when the incision was given, you used to stitch it. But here you don't stitch. So it is early recovery and it has very less risk. So non-scalpel is more safe. But both of them are done under local anesthesia. Both of them need 3 months to clear the sperms and both of them have same failure rate. Procedure में बस skin incision में difference है. Method of tying the epididymis, the vast difference is same. So failure rate is both same for both of them. ठीक है? So which of the following statement is incorrect regarding vasectomy? The procedure is done under local anesthesia, that's correct. Sterility is achieved in 3 weeks, in 3 months. The non-scalpel method is being widely used now, correct. Vast difference is the structure that is divided, that is also correct. So B is your answer. ठीक है? Identify the hormone present in the contraceptive image shown below. It is what? It is today. लिखा ही है उस पर. तो what is today में क्या होता है? It is in chemical contraception. It is not something physical. Contraception, barrier contraception can be physical. जो physically sperm को block कर रहा है. It can be chemical. There are a lot of harmful chemicals are released which will kill the sperm in the vagina only. So today has non-oxynol 9. Octoxynol 9 used to be a very older chemical that was used, but now it is not used. Menifgol is basically a chemical pill. It is also a contraceptive chemical pill, but it is used only in Europe. And levonorgestrel is not this. Levonorgestrel are oral contraceptive, is a progesterone pill. So barrier contraception can be condom, cervical cap, diaphragm with gel and sponge. They all can be the barrier contraception. Barrier contraception के बारे में you need to know only few things. क्या सारे barrier contraception sexually transmitted infections prevent करते हैं? Does all the barrier contraception prevent STIs? No. So STI क्यों होता है? Whenever the vaginal fluid comes in contact with seminal fluid, then the STI happen. Cervical cap is going inside and fitting on the cervix. Diaphragm is going and just fitting on the fornices. Whole of the vaginal mucosa is being exposed to the semen. भले sperms are not reaching the uterus, correct? But whole of the mucosa is coming in contact. So क्या ये सब STI prevent करते हैं? No. Only condom is the one, male or female, कोई भी हो. Male female condom are the one which prevent sexually transmitted infections. Cervical cap, diaphragm, sponge, they do not prevent STI. The seminal fluid will come in contact with the vaginal mucosa. They will transfer the STI. ठीक है? Condom is used during the act, but cervical cap or diaphragm or sponge have to be inserted at least 30 minutes to 1 hour before the act. And after the act, they have to stay within the female body for at least 4 hours. ठीक है? So condom can be removed immediately. Then condom, male, when I'm saying condom, I'm talking male and female condom both. So they both prevent STI. They are used during the act. You do not need to insert them way before the act. They can be removed immediately after the act. They are not used with spermicide. Diaphragm and cervical cap have to be used with spermicide because they are very less efficacious. So you add always a spermicide to increase the efficacy. But condom are made of latex. If you will add spermicide here, it will lead to rupture. So condom may you do not use a spermicide. If you read about spermicide, basically they are the chemical barriers, like non-oxynol 9. They do not prevent STI. In fact, a person who is at risk of STI, they can increase the risk of STI because they can cause vaginal lesions. If used persistently, they can cause vaginal lesions, and hence they are not used in a person who is at prone of having STI. ठीक है? And they are also toxic to lactobacilli. They change the vaginal flora. Okay, so this is about the barrier contraception. Next, IUCD having the longest lifespan. Copper T 380A. It has lifespan of 10 years. So IUCD के बारे में remember 5-6 points. How does IUCD act? How does an oral contraceptive pill act? It inhibits ovulation. But what is IUCD doing? It is creating such a bad environment in the uterus. There is a device in the uterus. It is creating hostile environment in the uterus. As a result, sperm will die in the uterus only. So when sperm die in the uterus, what is it inhibiting? It is inhibiting fertilization. And suppose one sperm went into the tube and fertilization हो जाता है, embryo is formed. When the embryo comes in the uterus again, it will prevent implantation. So there are two modes of action. It prevents fertilization, it prevents implantation. But if an embryo has implanted, remember, none of the contraceptive device will act on an implanted embryo. Implanted embryo means pregnancy has happened. If you are acting on an implanted embryo, then you are not a contraceptive. You are an abortifacient. So emergency contraception ho, oral contraceptive pills ho, IUCD ho, disimplanting an implanted embryo, it is not their action. That will be an action of an abortifacient. They just inhibit fertilization and inhibit implantation. Implantation को होने नहीं देंगे. If it has happened, कुछ नहीं कर सकते फिर. ठीक है? Next, government is providing few free of cost copper-teas. What are those copper-teas? Copper-T 380A and copper-T 375. They are available free of cost under National Family Planning Program. कौन से copper-T are being provided? 380A and 375. 380A has lifespan of 10 years. 375 have lifespan of 5 years. So this is 375. If image is asked, this is copper-T 380A. Another copper-T is there, Mirena, which is a hormone releasing copper-T, which has which hormone? Levonorgestrone. This is Mirena. It has a lifespan of 5 years. Which of these is used for emergency contraception? 380A or 375, any can be used. Mirena is not used for emergency contraception. Okay? What are the contraindications of copper-T? Pregnancy, obviously, active PID, not POD. Active PID, molar pregnancy में नहीं दे सकते, and distorted cavity. They all are the contraindications of an IUCD. Timing. A patient has delivered. Can I insert IUCD? Yes. But I have to insert it within 48 hours. If those 48 hours are missed, then now the uterus has become very soft. If I will insert, I will perforate. So I will have to wait for 6 weeks. So 48 hours to 6 weeks, I am not going to introduce an IUCD. So IUCD can be inserted post-delivery within 48 hours. If this is missed, you will insert an IUCD after 6 weeks. So this has finished our contraception. Okay? We discussed emergency contraception, a little about IUCD and emergency. इतने ही questions आए हैं. ठीक है. OCPs पे I have not seen any question. So I didn't took it in detail. OCPs पे I have never seen that any question in last 4 to 5 years. ठीक है. So last thing left is cancer. Okay, and most likely we will finish it by 4:30 so that you can have time for revising also. So cancers पे question करते हैं. Which of the following is not a hyperestrogenic condition? Hyperestrogenic condition क्या क्या होते हैं? Low BMI, ovarian cancer, endometriosis, tamoxifen. Low BMI. A woman who is obese, then there are high chances that whatever androgen are there in her body, that can be peripherally converted to estrone. Whenever there is high fat is a source of estrogen. So high BMI is a hyperestrogenic condition. It is a risk for cancer, not low BMI. So starting with endometrial cancer, what are the high risk for endometrial cancer? Infertility, anovulation, diabetes, tamoxifen, nulliparasomia. A woman who has never been pregnant, her uterus has never delivered a baby, no changes in uterus has happened, these are at high risk of endometrial cancer. So हर कैंसर के बारे में we will remember 4-4-5-5 points. ठीक है? Not details, सबके बारे में 5-5 points जो हमें पता होने चाहिए. मोस्ट कॉमन एंडोमेट्रियल कैंसर कौन सा है? एडिनोकार्सिनोमा. मोस्ट कॉमन सिम्टम क्या है एंडोमेट्रियल कैंसर का? वजाइनल ब्लीडिंग. एवरेज एज ऑफ एंडोमेट्रियल कैंसर, इट इज पोस्ट मेनोपॉजल, 60 years. What are the risk factors in a post menopausal woman? We read in a reproductive age woman what are the risk factors. In a post menopausal woman, anybody in post menopause having endometrial thickness more than 4 mm. 4 mm बहुत thin लगता है, but for post menopausal woman it is thick. So eating more than 4 mm, or there is a mass, there is a growth, or there is fluid, they all are indicative कि इसको that she might be having a cancer. ठीक है? Then comes pre-op workup. देन कम्स द ट्रीटमेंट. एंडोमेट्रियल कैंसर का ट्रीटमेंट क्या है? डिपेंडिंग ऑन स्टेज. सी, सिंपल हिस्टेक्टमी. वाई वी आर डूइंग सिंपल? एक्सटेंडेड रेडिकल क्यों नहीं कर रहे? क्योंकि इन एंडोमेट्रियल कैंसर आफ्टर हिस्टेक्टमी वी हैव टू गिव रेडिएशन. सो ज़रूरत ही नहीं है, वी डू नॉट नीड टू डू एक्सटेंडेड हिस्टेक्टमी, बिकॉज आफ्टर ओनली स्टेज 1A1 इज़ द वन जिसमें आप रेडिएशन नहीं देते. आफ्टर दैट इन एवरी स्टेज यू गिव रेडिएशन. So the treatment for endometrial cancer is simple hysterectomy followed by radiation. It is not radical or modified radical, because when you are doing simple hysterectomy, after once you give radiation, all the cancer tissue will be killed. So for endometrial cancer, you do simple hysterectomy and you give radiation except stage 1A1. ठीक है. Pre of workup उससे पहले क्या करते हैं? To know the stage, ultrasound and MRI, chest X-ray, because that is the first place where metastasis happen, and CBC, LFT, KFT. MRI से we can know the stage of endometrial cancer, and then we go for hysterectomy and radiation. In which of the following we can reduce the risk of endometrial cancer in a post-menopausal woman of HRT? So anybody, any hyperestrogenic state, whenever the estrogen content is high, risk of endometrial cancer is high. We read hyperestrogenic states, PCOD hyperestrogenic है, diabetes, tamoxifen therapy पे है patient, obese है, right? बट अगर आप ईस्ट्रोजन बाहर, इफ़ यू आर गिविंग ईस्ट्रोजन फ्रॉम आउटसाइड लाइक इन HRT, यू आर गिविंग ईस्ट्रोजन, आप उसको ईस्ट्रोजन दे रहे हो, सो इज शी एट रिस्क ऑफ एंडोमेट्रियल कैंसर? येस. देन वाई आर यू गिविंग HRT? बिकॉज यू हैव टू गिव अ प्रोटेक्शन इन फॉर्म ऑफ प्रोजेस्ट्रॉन. प्रोजेस्ट्रॉन इज प्रोटेक्टिव फॉर एंडोमेट्रियल कैंसर. सो एन HRT is never given alone. Never you give estrogen. In oral contraceptive pills also, you saw progesterone only pills. There are pills जिसमें सिर्फ progesterone होता है, but there are pills जिसमें सिर्फ estrogen होता है. No, you always give combined oral contraceptive which has estrogen plus progesterone. Whenever you are giving estrogen, you always add progesterone because there is a chance of endometrial cancer. So what will you give in a woman of HRT? I will be adding progesterone to this patient. ठीक है? Yes, Dr. Alia, correct. Progesterone is added. A patient with unilateral breast cancer is on tamoxifen. This will increase risk of what? Her estrogen content will be high. Tamoxifen is an estrogen receptor. No, tamoxifen is selective estrogen receptor modulator. So it is estrogenic for uterus and anti-estrogenic for breast. So as the estrogen content will be high, it will lead to which cancer? Endometrial cancer. Okay, so it is a high risk factor for endometrial cancer. A patient presents with endometrial thickness of 14 mm with adnexal mass. She has history of complex endometrial hyperplasia. They have given. उसको history थी. What is the treatment of complex endometrial hyperplasia with atypia? Endometrial hyperplasia with atypia का treatment is hysterectomy. Endometrial hyperplasia with no atypia, simple hyperplasia, the treatment is progesterone. Protection तो endometrium को देना ही है. If it is getting thick, risk of cancer is there. If atypical cells are there, she will turn into cancer. Hysterectomy is the treatment. If atypical cells नहीं है but hyperplasia है, give her progesterones. Now she has history, she did not got hysterectomy. Which of the following is the likely cause? Now thickness is high, adnexal mass is there. It means it is endometrial cancer which has metastasized to ovary. Isn't it? A patient of carcinoma endometrium is treated with external beam radiation. That's what I told you. The treatment is hysterectomy followed by radiation. Which is the most radiosensitive organ in pelvis? See, radiosensitivity is highest when, yes, radiosensitivity is highest when the cells are very actively dividing. So the most actively dividing cells are in GI. So GIT symptoms are the most common after radiation. So most radiosensitive tissue is the GI tissue. The small bowel is the most sensitive one. After that, the large bowel. So if you ask in the perineum, which is in the pelvis, what is the most radiosensitive? It's not ovary, vagina, bladder. They all are radiosensitive. But most one is the rectum. The rectal fistula, the rectal bleeding will be the most common symptom this patient will be having. Right? Which type of hysterectomy is there in case of carcinoma cervix? So carcinoma cervix stage 1B. So stage 1B, 1, 2, 3. So the question is not a good question. Stage 1B, 1 में modified radical करते हैं. Stage 1B 2 में रेडिकल करते हैं, स्टेज 1B 3 में कीमो रेडियो देते हैं, तो सब कुछ करते हैं. बट सिंस दे हैव just mentioned 1B, I think they are mentioning 1B1. I would have marked type 2. Type 1 होती है सिंपल हिस्टेक्टमी, टाइप 2 होती है मॉडिफाइड रेडिकल. रेडिकल है, रेडिकल मतलब रिमूविंग लॉट ऑफ टिश्यू, बट मॉडिफाई कर दिया, मीन्स थोड़ा सा रोक लिया अपने को, यू हैव जस्ट बिकम लिटिल कंजर्वेटिव. सो सिंपल मॉडिफाइड रेडिकल, रेडिकल एक्सटेंडेड रेडिकल. एक्सटेंडेड रेडिकल में आगे ब्लैडर, पीछे रेक्टम सब हटा देते हैं. तो सिंपल मॉडिफाइड रेडिकल, रेडिकल extended radical. So Dr. Alia, you are asking that why ovary is not very radiosensitive? Yes, ovary is also very radiosensitive, definitely. But when it is asked what is the most radiosensitive tissue, it is always the GI. GI has the most rapidly dividing cells. That is why. Right? So a lot of people have that doubt in this question. Ovary है, vagina, bladder and rectum. So GI is the most sensitive, but still if many of you think it is the answer was the ovary, I will check this question and will let you know. Okay? How will I let you know? You can join my WhatsApp chat group. I will just mention the link here, and once you are on that group I will mention the answer there. Okay? Because this is the only question I think where everyone is marking ovary. Right? चलो कैंसर सर्विक्स पढ़ते हैं. कैंसर सर्विक्स में भी जैसे एंडोमेट्रियम में भी जस्ट रेड इंपॉर्टेंट थिंग्स, सिम्टम, एज, रिस्क फैक्टर्स एंड ट्रीटमेंट, वैसे ही कैंसर सर्विक्स भी करेंगे. ठीक है. मोस्ट कॉमन सिम्टम वजाइनल ब्लीडिंग. कॉजेटिव ऑर्गेनिज्म क्या है? HPV. herpes and chlamydia are co-factors, but the causative is HPV. If suppose a patient comes with bleeding and a gross lesion is seen, what will you do? Will you do pap smear? Pap smear करते हैं when there is nothing visible. Cytology means आपने वो fluid ले लिया from cervix when no lesion is visible. If you can see any lesion on cervix, your next step is always biopsy. आपको दिख रहा है ना, so next step is biopsy, not the pap smear. Pap smear is done if it's a screening test when the cervix is looking healthy. You cannot see anything in cervix. If the growth is visible, the next step is biopsy. ठीक है. What is the risk factor? Hereditary is not the risk factor. इसके अलावा young age, multiple sexual partners, unhygienic, high parity, low socioeconomic status, they are the risk for. So it is basically a cancer of lifestyle. We can say that. How do we treat cancer cervix? So we know stage 2A के बाद we do chemo radio. उससे पहले we can do surgery. But see, इससे ज़्यादा easy तरीका what I tell you is the easy way. So whenever the lesion is more than 4 centimeter. So remember, whenever the lesion is more than 4, or lesion has gone cervix or vagina, upper vagina. So whenever the lesion has gone out of cervix and upper vagina, it has gone out, or the lesion is more than 4, you always do chemo radio. So here, like 2A2, more than 4, chemo radio. 1B3, more than 4, chemo radio. Lesion more than 4 centimeter, or lesion has reached outside the upper vagina. Upper vagina के बाहर गया, lower vagina, parametrium. Question ने आपको दिया, the lesion is on the parametrium. Don't calculate the stage. Chemo radio is the answer. Surgery is done only when the lesion is in cervix and upper vagina and it is less than 4 centimeter. Then only you do surgery. और क्या surgery करते हैं? There are always uterus preserving surgery in cancer cervix, and there are always uterus non-preserving surgeries. So uterus preserving surgery stage 1A1, सबसे पहली stage. When you are trying to preserve the uterus, it is such a small lesion, just remove the cone. Conization. Remove that cone of cervix. If she does not want to preserve the uterus, she is too scared, do a simple hysterectomy. That is only for stage 1A1. After that, the uterus conserving surgery becomes modified radical trachelectomy. And if she does not want to preserve the uterus, simple नहीं करेंगे, you will do modified radical hysterectomy. But up till what stage these two are done? Till the lesion is 2 centimeter. जैसे lesion 2 centimeter से ज़्यादा हुआ, as the lesion crosses 2 centimeter, uterus preserving surgery नहीं कर सकते. You have to remove the uterus, and the surgery will be radical hysterectomy. As soon as the lesion crosses 2 centimeter, you see here 1B2 radical hysterectomy. 1B3 lesion more than 4 centimeter. I told you, more than 4 chemo radio. Less than 4 upper vagina. Less than 4 है, अपर वजाइना में, अभी वजाइना से अपर वजाइना से इट हैज़ नॉट कम आउट, रेडिकल हिस्टेक्टमी। मोर देन 4 अपर वजाइना में ही है, बट मोर देन 4 है, कीमो रेडियो। इसके बाद नाउ द साइज डजंट मैटर, इट हैज़ कम आउट ऑफ वजाइना, इट इज़ लोअर वजाइना, पेल्विक वॉल, पैरामीट्रिया, कीमो रेडियो एवरीवेयर। गॉट इट? सर्वाइकल कैंसर की स्टेजिंग की सर्जरीज आर द मोस्ट डिफिकल्ट वन, बिकॉज इन डिफरेंट स्टेज यू डू डिफरेंट टाइप ऑफ हिस्टेक्टमी। वाई? सी, सब हिस्टेक्टमी के बाद यू आर नॉट गिविंग कीमो रेडियो। आपने इधर रेडिकल हिस्टेक्टमी यू डिड, यू आर नॉट गिविंग कीमो रेडिएशन। इधर यू डिड मॉडिफाइड रेडिकल ट्रैक्टिकलेक्टमी, यू आर नॉट गिविंग रेडिएशन। सो द सर्जरी विल बी डिपेंडिंग ऑन स्टेज, यू विल एक्सटेंड द सर्जरी। एंडोमेट्रियल में सबको वी वर गिविंग रेडिएशन, दैट इज वाई सिंपल हिस्टेक्टमी वॉज डन। सिंपल हिस्टेक्टमी कर दो, सबको रेडिएशन दे दो, बट सर्वाइकल कैंसर में वी डोंट डू दैट। Okay, so somebody has asked that if the staging is important for the questions which I have seen for almost like 5-6 years of question, dear, the staging has not been asked. They have not asked the stage, but yes, they have asked the treatment, stage wise treatment they have asked. So if you have less time, I would suggest read something else, do not try to rectify the stages. लास्ट डे थोड़ा सा स्टेजिंग पढ़ के चले जाना, दैट इन केस इट कम्स, ऐसा ना हो कि बिल्कुल आइडिया नहीं है, बट डू नॉट गिव टू मच फोकस ऑन स्टेजिंग। क्वेश्चंस हैव नॉट बीन आस्क्ड ऑन स्टेजिंग। ठीक है, ये ट्रीटमेंट समझ में आया? मोर देन 4 सेंटीमीटर क्वेश्चन में लिखा है कीमो रेडियो, मार्क करो। दे हैव मेंशन्ड एनीथिंग बिलो अपर वजाइना, सर्विक्स और अपर वजाइना से नीचे कुछ भी इन्वॉल्व है, कीमो रेडियो। प्रॉब्लम आती है सर्विक्स अपर वजाइना में और 4 से कम है, अब सर्जरी करना है, कौन सा सर्जरी? 2 सेंटीमीटर से लेजन इज लेस देन 2 सेंटीमीटर, आई कैन कंजर्व द यूट्रस और आई कैन रिमूव द यूट्रस। स्टेज 1A1 में इफ आई कंजर्व द यूट्रस आई विल डू कोनाइजेशन, इफ आई वांट टू रिमूव आई विल डू सिंपल हिस्टेक्टमी। इसके बाद इफ आई वांट टू अप टू 2 सेंटीमीटर, रिमेंबर, if I want to conserve uterus I'll do modified radical trachelectomy, if I want to remove uterus I'll do modified radical hysterectomy. Lesion crossed 2 centimeter but less than 4, then chemo radio की ज़रूरत नहीं है, but now I cannot conserve the uterus, I have to remove uterus and that too radically. ठीक है? Radiation points. Now when you are giving radiation, can you see these are the radiation tandems given to cervical cancer. So when you are giving radiation, you need to take care of the dosage which is reaching to the points A and B. Why? Because there are important structures lying here which you have to take care of. So point A and B are the points where you will calculate the radiation dose and then only you will give. So question has been asked, where does point A lie? Point A lie करता है 2 centimeter lateral from the cervix and 2 centimeter above. So ये यूट्रस है, और से 2 centimeter lateral and 2 centimeter above is point A. What are you trying to save in point A? Why do you reduce your radiation dose in point A? I am trying to save the ureter and uterine artery. Point B is इसी point से 3 centimeter lateral is point B. What is here? Obturator lymph nodes. That's what I am trying to save. So point A and B are very important points because I am trying to save the uterine artery and ureter. Here I am trying to save the obturator lymph nodes. They are lying 2 centimeter lateral to us, 2 centimeter above. So let's see the question. Yes. "52-year-old women diagnosed with cancer 2B. Which of the following statement regarding radiotherapy is false?" Point B is 3 centimeter lateral to point A. Correct. It is 3 centimeter. Point A is 2 centimeter above the external os and 5 centimeter lateral. No, 2 centimeter lateral and 2 centimeter above. So this is our answer. Point A receives 7,000. Yes, and point 7B receives 6,000. That is true. So your radiation dose has to be 7 here and 6 here. So farther you are from the radiation, your dose will decrease. A 40-year presents to your office with foul-smelling discharge per vaginum. She has been diagnosed with carcinoma stage 3B. What is the primary treatment of her? For stage 3B, it is such an advanced stage, don't even think. It is chemo radio. Radical hysterectomy with pelvic lymph node, no. Stage 3B is very advanced, so it is chemo radio. ठीक है? So this was about cervical cancer. Let's discuss about cervical screening. When is it started? Cervical screening कब start करते हैं? At age of 25. What is the primary test for cervical screening? कौन सा प्राइमरी टेस्ट है? पैप्समेर, HPV. Now the primary test is HPV. So if it is available in your hospital, you go for HPV. How frequently it is repeated? It is a very sensitive test. So you repeat it every 5 years. But if you do pap smear की sensitivity is not good. They miss 50% of the cases. So you repeat it every 3 years. अब उसको frequently repeat करते हैं. Till what age? 65. So remember, start 25, primary test HPV, end age 65. In all this is being done in good resource setting. If the scenario gives you the resource setting is poor, HPV pap smear हर जगह नहीं होता. In poor resource setting, what is the treatment of cervical screening of choice? Via and villi. Visual inspection with acetic acid and visual inspection with lugol iodine. You apply acetic acid. If there are any suspicious area, they will become white cold areas. Similarly, if you apply lugol iodine, if there are any suspicious area, they will turn brown. They will not stain black. So via and villi are like see and treat. See, apply the those chemicals. If you see the suspicious area, take the biopsy. But they are not the primary test. They are screening test. They are done only in the poor resource setting. Right? HPV वैक्सीन के बारे में. So routine age क्या है HPV वैक्सीन का? Routine age is 11 to 12 years. What is the starting age? 9 to 14 years. ठीक है, 9 to 14 years में. So now this has been changed by WHO. So WHO ने dosing change कर दिया. Sorry, इधर मैंने नहीं change की. 9 to 14 years में they say 1 or 2 doses. They have seen कि 1 dose is as effective as 2 doses. So they say 1 or 2 doses from 9 to 14 years and also from 15 years, after 15 years. 1 or 2 doses is more than enough. ठीक है? What kind of vaccines are to be given? Cervarix, Gardasil non-avalent. Cervarix has to be given only in females. But remember, Gardasil quadrivalent and Gardasil non-avalent can be given in males and females both. Right? Which serotype of HPV is responsible for cancer cervix? 16, 18, 31, 33. Now we come on to the last cancer, that is the ovarian cancer. The most common benign tumor of ovary in reproductive age group कौन सा होता है? In reproductive age group. So it will not be epithelial cell tumor. Epithelial cell tumor is a very common cancer of the menopausal age group. The benign teratoma, the another name is dermoid cyst, is the most common benign tumor. Dermoid cyst. So ovary के बारे में पढ़ते हैं थोड़ा सा. See, ovarian tumors basically come from 3 areas. So क्या क्या areas हैं? What all do we have in ovary? We have one epithelium. We have follicles forming the oocytes. And we have one stroma. Stroma क्या है? वो soft tissue, वो muscular fibrous tissue जिसपे everything is lined. So cells, tumor can arise from all of them. When the tumor is coming, and they can be benign, they can be malignant. So when the tumor is coming from epithelial cell, which is the most common tumor overall, epithelial, when they are benign, they are called as adenomas. So when I am saying epithelial benign tumor, it is serous cyst adenoma or mucinous cyst adenoma. But when it is saying, or Brenner clear cell are very less common one. But when I am saying cancer, malignant, I will call serous carcinoma. So serous carcinoma is malignant, mucinous carcinoma is malignant. But serous cyst adenoma and mucinous cyst adenoma are benign. What is their origin? Epithelium. Then I say germ cell tumors. These follicles are the germ cells. They have our germ cells, oocytes. So the tumor can arise from germ cells also. It can be again benign, it can be malignant. But remember, reproductive age group या फिर आप प्री प्यूबर्टल एज ग्रुप की बात कर रहे हो तो सबसे कॉमन जर्म सेल्स होते हैं. मीनोपॉजल एंड प्री मेनोपॉजल में सबसे कॉमन एपिथेलियल होता है. जर्म सेल में बनाइन मोस्ट कॉमन जो क्वेश्चन में दैट वाज आस्क्ड, मैच्योर टेराटोमा. मैच्योर टेराटोमा also called as dermoid cyst is benign. So reproductive age woman has got a benign ovarian tumor. What tumor it will be? Will it be serous cyst adenoma? It will be dermoid cyst. So dermoid cyst is the most common ovarian tumor of reproductive age group. Most common ovarian tumor found in pregnancy, क्योंकि pregnant reproductive age group वाला person will be pregnant, right? So that is most common. Most common, since teratoma has lot of fat, it is very free floating tumor. So most common tumor to undergo torsion. ठीक है? If I talk about malignant germ cell tumors. Can they be malignant? Yes. The most common malignant germ cell tumor is dysgerminoma. And इसके अलावा immature teratoma. When the teratoma is mature, it is benign. When it is immature, it is malignant. So most common malignant germ cell tumor, dysgerminoma. Other than that, they can be immature teratoma and yolk sac tumors. एक और टिश्यू रह गया. What is the another tissue left? That is the stromal cells, fibrous tissue, muscle, stromal cells. So the stromal cells, again, it can be benign, it can be malignant, but they are basically fibroma thecoma. Fibroma thecoma are the benign tumors. Malignant are granulosa theca cell tumor. Remember hormone producing tumors? There are certain androgenic tumors of ovary. These are the one. The Sertoli-Leydig cells किस में होते हैं? Basically males में होते हैं, testis की cells हैं. But yes, they are present small number in ovary also. So Sertoli-Leydig cell tumors are called as arenoblastomas, androgen producing tumors. Granulosa theca cell tumors are estrogen producing tumors. So your stromal tumors are always hormone producing. Your germ cell tumors are most common in reproductive age group. Your epithelial tumors are most common in postmenopausal age groups. ठीक है? If we talk about the tumor markers, epithelial cell have tumor marker CA125. Now I cannot write because obviously my pen is not working. So epithelial cell tumor has CA125 as marker. If I talk about dysgerminoma, so dysgerminoma has what tumor marker? LDH. LDH is the tumor marker in dysgerminoma. ठीक है? What about yolk sac tumor? Alpha fetoprotein. What about the granulosa theca cell tumors? Inhibin. So if a postmenopausal lady comes to me and she has an ovarian mass, what tumor marker will I do? CA125, because epithelial cell are the most common. But if a 35-year-old lady comes to me with ovarian mass, will I do CA125? I will do inhibin, I will do LDH, I will do alpha fetoprotein, because germ cell tumors are more common. So depending on age, I will change my tumor markers. ठीक है? इमेज बेस्ड भी आ सकता है. सो मोस्ट कॉमन टाइप इज एपिथेलियल. ओवरऑल पूछा जाए तो मोस्ट कॉमन ओवेरियन कैंसर्स होते ही पोस्ट मेनोपॉजल में है. रिप्रोडक्टिव एज ग्रुप में द ओवेरियन ट्यूमर्स एंड मैलिग्नेंट ट्यूमर्स आर लेस. सो मोस्ट कॉमन इज एपिथेलियल. व्हाट आर द रिस्क फैक्टर्स? नल्ली पैरिटी एंड इनफर्टिलिटी आर द रिस्क फैक्टर्स. एंड वेग सिम्टम्स होते हैं. पेशेंट विल ऑलवेज हैव वेग सिम्टम्स एंड ऑन एग्जामिनेशन शी विल हैव सम इरेगुलर फिक्स्ड pelvic mass. Some about hereditary cancer. Ovarian cancer can be hereditary due to mutations of BRCA gene. So who should be tested? कौन सी ladies को हम टेस्ट करेंगे for hereditary cancer? All the ladies, everyone. Previously it was said that anyone who has ovarian cancer with family history and all those, then you test for BRCA. Now it is changed. Any girl diagnosed with ovarian cancer, any old lady diagnosed with ovarian cancer, I will test her for a BRCA. Because if in her BRCA gene is positive, I need to test that gene in every lady of that family series. So everyone, all the women with ovarian cancers have to be tested. ठीक है? I have to check for BRCA1 and 2 mutation, and the cancer risk is pretty high in both of them. Don't remember the number. Breast cancer risk is very high. It is 80%. So what is the prevention? If she wants, so basically prevention क्या है? Remove the ovary. That is the treatment. If you have BRCA gene mutation, remove the ovary. But unless you have completed the family, if you have not completed the family, there is only one prevention I can give, and that is OCPs. OCPs are the only chemo prevention for ovarian cancer. As such, as soon as the family is complete, I have to remove the ovaries. ठीक है? How will I evaluate? A patient comes with ovarian mass, I'll do ultrasound, I'll do tumor markers which can be CA125, HCG, alpha fetoprotein. We have discussed that, right? What is the surgery? Revise again. What is the surgery? What was the treatment for endometrial cancer? What was for endometrial cancer? What was the treatment for endometrial cancer? I am waiting for the answer. Endometrial cancer का there was a very simple treatment. Simple hysterectomy followed by radiation. Cervical cancer का what was treatment? Depending on stage. After 4 centimeter, after the lesion has gone into lower vagina and everywhere around, yes, Dr. Alia, simple hysterectomy with radiation. Radiation has to be given to everyone except stage 1A1 ना, तो इसलिए you have to say radiation. Cervical cancer में if we have done surgery we are not giving radiation. If we are giving radiation we are not doing surgery. Not chemo, radio. Endometrial cancer में radiotherapy is given. That is why I was revising. Endometrial में radiotherapy. Cervical cancer में stage upper stages में surgery, lower stages में chemo radio. Ovarian cancer का क्या treatment है? Debulking means ovarian mass on whatever visible mass is there, remove it and give chemo to all the patient. Like you were giving radiation in endometrial, you will give chemo in all the patients in this. So surgery is, इसे हम कहते हैं cytoreductive, means whatever visible mass is there, remove it and then give chemo, because chemo can act when the malignant tissue is out. So the treatment is debulking. Debulking means remove all the cancer mass, remove the ovary, uterus, and it's not radical hysterectomy or modified. No, simple hysterectomy. Simple hysterectomy, remove uterus. If you can see peritoneal, maybe ovarian malignancies are there, remove everything visible, everything suspicious, and then give chemo. That is the treatment for ovarian cancer. So that is a stage wise नहीं है. Ovarian cancer का treatment is not stage wise. Neither endometrial cancer का. It is only for cancer cervix. So cytoreductive surgery plus chemo is the treatment for ovarian cancer. How will you follow whether the patient has been corrected or not? Using CA125 and CT scan. ठीक है? Some images जिसके ऊपर question आ सकता है. What is this? Very small, very smooth cyst, thin unilocular cyst. It is serous cyst adenoma. When they give you something like this, can you see multiple loculi? Multiple loculi. Mucinous cyst adenoma. Mucinous means mucin filled multiple cyst. Solid tumor bossylated dermoid cyst. It looks like this. On cut section, it is such pale tan dermoid cyst. Image based questions आ सकता है. Generally they give only these. Either they give serous or they give multiple cystic mucinous, or they give bossylated dermoid, or they give a cut section where you can see hair, you can see fat, you can see some teeth also, multiple tissues, teratoma. So these are the image based questions on ovarian cancer. ठीक है? Now the most common cause of postmenopausal bleeding all over the world. Most common cause of postmenopausal bleeding all over the world is HRT. Whenever a woman is taking hormones, she can bleed off and on. HRT doesn't mean cancer. वो OC pills ले रही है, she has forgotten, she will bleed. That is HRT. What is the most common cause of postmenopausal bleeding in India? Since in India, HRT intake is not that much, is not that high. So in India, the most common cause is atrophy. Atrophy because she is postmenopausal. So senile endometrial atrophy is the most common cause in our country. Overall, the most common cause is HRT. World में HRT is very well taken by ladies. ठीक है? So चाहे वो world की बात करें इंडिया की, endometrial, little about postmenopausal bleeding. So most common cause in India is atrophic vaginitis and endometritis. In the world, it is HRT. ठीक है? Cancer risk is only 15%. So every woman that comes with postmenopausal bleeding, उसका I am not taking the biopsy. I will take biopsy only when your ultrasound shows thick endometrium. Because if the endometrium is thin, it is 1 mm. Why will I take biopsy? Most common cause is senile endometritis, so that is the cause here. So if the endometrium is thick, more than 4 mm, or there is fluid in your cavity, or there is some growth, then only I'll take biopsy. ठीक है? What is the investigation of choice in a patient with postmenopausal bleed? Postmenopausal bleed है CA125 fractional curettage biopsy pap smear, endometrial biopsy. Pap smear क्यों लेंगे, है ना? Postmenopausal bleeding में वैसे भी क्या कहते हैं, the patient will present with post-coital bleeding in case of cervical cancer. ठीक है? CA125 will be done for ovarian cancer. Ovarian cancer does not present with postmenopausal bleeding. So we just want to rule out endometrial cancer. The choice will be biopsy. So we have finished almost everything. There are only few general questions which were asked, which were not in any topic, like this. Which of the following conditions shows a positive, false positive Baar body? Baar body क्या होता है? An inactive X chromosome. So a female who is XX, X chromosome का over expression ना हो जाए, इसलिए 1X is always inactive. and it is seen as Baar body. When you do karyotype, it is seen as Baar body. ठीक है? So one X is active. The active X will not form Baar body. So males which have only one X, will they have Baar body? No. Females have how many Baar bodies? One. जितने भी X chromosomes हैं उनमें से remove the active one, rest will show the Baar bodies. False positive means Klinefelter है ये male XXY, but there will be a Baar body because there is an excessive X chromosome extra. So this is the reason. Turner is X0, so X0 will not have any Baar body. Down syndrome and Edward तो कोई सेक्स क्रोमोसोम डिफेक्ट नहीं है, ये तो ऑटोसोमल क्रोमोसोम डिफेक्ट है, सो दे विल नॉट हैव बार बॉडी. नो बेटा, टर्नर विल हैव. वाई फॉल्स पॉजिटिव? टर्नर में तो इट इज X0, दे विल नॉट हैव एनी बार बॉडी. क्लाइनफेल्टर विच हैज एन एक्स्ट्रा X, as such it's a male, it should not have shown any bar body. That is why we call it false positive. A male showing bar body is Klinefelter syndrome, called as false positive bar body. What is the direct cause of maternal death? Direct cause of maternal death means something that has happened because you were pregnant. Suppose you had a heart disease which got aggravated because you were pregnant. Will it be direct? No, it will be indirect. So anemia, you were anemic, obviously you became pregnant, the situation got aggravated, the patient died. It is indirect. Malaria, so malaria is also indirect. अब वो malaria उसको, she has not got malaria because she was pregnant. She got malaria from somewhere, but because pregnancy is a condition where the immune system is already low, she died because of that. Or maybe heart disease. Direct cause of maternal death is eclampsia. Eclampsia has happened to her only because she is pregnant. उससे पहले उसको eclampsia नहीं था. So what is the direct cause of maternal death? Eclampsia, PPH, uterine inversion, or sepsis, postpartum sepsis. They all are causes of direct causes of maternal death. During your internship, you notice the following instrument is being used. What is it used for? Can you see this iron rod kind of instrument? This one. It has no cavity, so obviously you cannot use it for any suction and all. What will be used for? To differentiate between chronic inversion and fibroid polyp. Yes, so whenever there is a fibroid polyp coming out, if you want to know whether it is uterus coming out or fibroid, you use the uterine sound. It is a uterine sound, because if uterine sound is going inside, it means ये polyp है. अगर chronic inversion हो जाएगा, uterine sound will not go inside. Diagnose cervical stenosis. Yes, if the cervix is stenosed, you will not be able to introduce the uterine sound. And you measure the uterine cavity and cervical length. That is the main purpose of this. Use in fallopian tube. This is never used in fallopian tube. Is very thin. Fallopian tube recanalization के लिए such a thin wire is used. These steel wires are not used. So this is the thing where it will not be used. ठीक है? So what is the definition of post-term neonate? Post-term होता है after 42 weeks. उसे हम post-term कहते हैं, because now the after post-term means the risk of complications will start increasing. We have to induce this pregnancy. Post-dated क्या होता है? So हम जो the EDD we calculate, expected date of delivery, that is according to 40 weeks. 40 weeks के according we call EDD. So after 40 weeks we will call it post-dated. कि जो मैंने आपको डेट दी थी उसके बाद आई विल कॉल इट पोस्ट डेटेड. बट पोस्ट टर्म मीन्स टर्म से भी आगे चला गया. नाउ द कॉम्प्लिकेशंस विल हैपन. द बेबी विल हैव ओलाइगोहाइड्रोमनियोस. इट इज़ 42 वीक्स. ठीक है? सो आई थिंक वी हैव कवर्ड एवरीथिंग. इफ फ्यू थिंग्स आर लेफ्ट, प्लीज यू कैन जस्ट लेट मी नो. फ्रॉम माई साइड एवरीथिंग इज कवर्ड. द लास्ट one question was asked on malaria, which I forgot to include it into this malaria question. So malaria का remember that अगर they have given falciparum, if they have given vivax, ovale, malaria, as such ovale and malaria are not common in India. Vivax is common. So how to treat malaria in pregnancy? So vivax, ovale, malaria, the treatment is simple and that is chloroquine. And chloroquine can be used in any trimester. So chloroquine will be the treatment whether patient is pregnant or non-pregnant. If the question gives us falciparum malaria, so falciparum malaria is chloroquine resistant already. They don't need to mention that. falciparum में we don't use chloroquine. What do you use for falciparum malaria? ECT, artemether combined therapy. Artemether combined means artemether lumefantrine, artemether sulfadoxine pyrimethamine. We combine it with something. That is the treatment of choice for falciparum. But it cannot be given in first trimester. ACT can be given, artemether combined therapy can be given in second and third trimester. So what will we give in first trimester in P falciparum? Quinine. Quinine plus clindamycin is the treatment of choice. If clindamycin is not available, you will straight away give only quinine. Okay, so this is about falciparum only. Yes. ACT cannot be given in first trimester. So that's all. I will just mention one thing. I will just in this chat group add the WhatsApp group link of mine so that you can join the WhatsApp chat group and ask any questions for the upcoming or the next whatever exams you are giving. Option gynae related question obviously. Okay? So just take care and have revise and study well. Bye bye.